تعال تعال بابا شوف. ماكو صورة بابا، شلون نشيلها الصورة؟
Good morning, all. Please, when you are sign in, keep your mic muted now.
No problem with that.
Okay.
We can edit always.
Okay, no problem. Yeah. And for the covering, remove all the one who closed the camera.
Okay.
And recording. Okay.
In
For
recording?
opening, yeah. For
Oh, I cannot.
You
Because
can
recording
here.
for video.
I know, but I think the arrangement.
صباح الخير.
كيف الأخبار؟ عاشت إليكم.
Shaira, please, can you mute yourself?
Yeah, the one who closed this camera, you can just.
دكتور محمد شلونكم؟
أهلا دكتور أسعد، صباح الخير.
الله يحفظك.
No, not yet. They're still like. Yeah, probably. Maybe that's one problem. Yeah. We now have like 64.
صباح الخير دكتور هشام، شلونك يعني؟
يا هلا، اخبارك؟
Nice to meet you. Long time.
اي والله.
We miss you a lot.
اي والله تو. بس يعني I appreciate كل الكوميونيكيشنز، يعني you put a lot of hard work الصراحه. يعطيك العافيه.
الله يحفظك.
طيب شاش هاي بس خلاص طرشت المحضر.
تعال دكتورة مريم، شلونك؟ شلون صحتك؟
يا هلا، صباحكم
اخباركم؟
الخير والسرور
الله يحفظك.
وتمنياتنا القلبية بنجاح هذا المؤتمر، وإن شاء الله يوفقكم جميعا. وإن شاء الله بكرة احنا عندنا جلسة خاصة بالبريجننسي والديابيتس.
نعم، جلسة مميزة إن شاء الله.
دكتور هشام خلفان،
يا هلا، صباح الخير دكتورة، شلونك؟
الله يحفظك.
صباح الخير دكتورة مريم. صباح الخير.
صباح الخير دكتور محمد، يعطيكم العافية على هالجهود.
يعافيك، ربي يحفظكم إن شاء الله دكتورة.
الله يسلمك.
إن شاء الله دكتورة خلال كم سنة إن شاء الله يكون نطمح يكون الIDF بالبحرين بإذن الله تعالى.
إن شاء الله. هو يعني تحدد، هو طبعا مثل ما أنت عارف كل 3 سنوات كان نعم. المفروض العام يكون في تايلاند 2021، بس نعم. بسبب الجائحة تأجل، والحين بيصير في البرتقال.
اي لشبون صح.
إن شاء الله يعني لازم نرفع لهم يعني رسالة ونشوف، نتمنى إن شاء الله
بإذن الله. الحمد لله من صارت جرين زون حاليا، وهذه أخبار مفرحة.
اي والله أخيرا يعني.
كانت كل الاستعدادات إنه يكون هالسنة مؤتمر بالفيزيكال، بس بالفترة الأخيرة بعد ظهور المتحور أوميكرون اضطرينا إنه كان مو واضحة الصورة، فاضطرينا إنه يعني نسوي شيء استباقي إنه نحوله إلى فيرتشوال.
نعم، بس هو الحمد لله معظم الحالات مال أو يعني جدا الأعداد اللي تدخل المستشفيات بالنسبة للبوزيتيف كيسز والICU جدا جدا قليلة.
الحمد
لله. أهم شيء الإجراءات الاحترازية، الكمامات، واتخاذ يعني إذا كان هناك أعراض بسرعة الواحد يفحص، وإن شاء الله خير.
السلام عليكم.
عليكم
السلام.
صوت مسموع واضح؟
واضح جدا دكتورنا. أهلا أستاذ عبد الوهاب.
أهلا بكم جميعا.
أهلا سعادتكم.
يا هلا
دكتور عبد الوهاب، صبحك الله بالخير.
صباحك بالخير دكتورة، كيف حالك؟ عساك طيبة؟
الله يحفظك، الله يسلمك. شكرا على جهودكم.
أهلا بكم
وعلى استمرارية المؤتمر العلمي الناجح.
دكتور أسعد وجماعته والهيئة مالت التنظيم واللجان العلمية والله تعبوا يعني رغم كل هالمشاكل اللي عندنا من هالجائحة ذي، لكن الحمد لله بعد إن شاء الله المؤتمر يطلع بالصورة المطلوبة، والناس يعني ما تحس انه هو اقل من المؤتمرات السابقه، ان شاء الله يكون على نفس المستوى ويعطيهم نفس الفائده ان شاء الله.
صباح الخير جميعا.
صباح النور.
صباح
الخير. هلا مرحبا.
اهلا دكتوره غاده، نرحب بكم.
اهلا دكتور اسعد.
شكرا لحضوركم. دكتور جميل.
صباح الخير للجميع، واتمنى مؤتمر زاهي مثل كل مره ان شاء الله بوجودكم.
شكرا
دكتور. ان شاء الله.
الله يخليك استاذنا.
Ten to 10:20. دكتور أسعد،
نعم
معالي الشيخ بيكون معنا من الساعة 10 ل 10:20 دقيقة.
ان شاء الله.
أنا هو مرتبط باجتماع ثاني على ما أعتقد على 10:30.
بس تمام، يعني اعتقد كافي يكون الافتتاح على هذا الوقت. نعم، عندنا تقريبا 5 دقائق او 6 دقائق نبتدي ان شاء الله. الصوت واضح اعتقد الامور كلها ممتازه. نرحب بالدكتورة عفاف والدكتور علي مراد والاساتذه، الدكتور قاسم، كل الافاضل المشاركين. نشكركم الحقيقه لجهودكم ومواصله الدعم الغير محدود من كل الحقيقه، من جمعيه السكري، وزاره الصحه، مستشفى نور التخصصي، Education Plus، وكذلك اكيد الدعم من مؤسسه النهره باكريديتيشن بالCME. نشكركم جميعا الحقيقه المشاركه والاستمرار.
الجميع معالي الشيخ محمد بن عبد الله الخليفه.
بالضبط،
باستمرار،
يعني رعايته
يعني
اكيد
ما يتاخر في انه هو يدعمنا.
نعم.
ويحضر ويترأس اجتماعاتنا ويسهل لنا الامور. يعني
أكيد.
المطلوب ان احنا بعض الاحيان تكون امور صعبه، لكن الحمد لله بوجوده دائما يعني تتساهل الامور هذه كلها. يعني ندعي له بالخير يا رب ان شاء الله، ان يكون دائما دعم وسند لنا ان شاء الله.
بالضبط، الله يحفظكم كلكم، وان شاء الله يكون مؤتمر ناجح، وان شاء الله يكون بعد 4 دقائق ننتظر بدء البرنامج.
ان شاء الله.
صباح الخير بولي دكتور اسعد.
يوصل معالي الشيخ. خلاني عامر. You're off your voice is off, your mic is off.
منورين الكل، دكتورة مريم، الأخوان والأخوات كلكم.
أهلا دكتور عامر.
يا أهلا دكتور عامر.
أهلا دكتور عامر، نتشرف بكم.
الله يخليك.
أهلا دكتورة دلال، مرحبا بك معنا.
مرحبا بالجميع دكتور، أهلا وسهلا بالتوفيق.
احنا ما شايفين الدكتورة دلال، وين هي؟ هذا الوجه المبتسم ما احنا شايفينه.
أهلا وسهلا دكتورنا الغالي، شلونك؟
سلمك الله يبارك فيك.
I would like to welcome Professor Asmina.
Good morning, everybody. Good to see you all.
Good morning.
Good morning to you.
Good morning. Good morning.
It must be very early morning in your place.
9 o'clock. It's not
very
that
well.
early.
Very well.
Good.
Very well. You're welcome. You're welcome.
It's my honor and great pleasure.
Yes, ours also. Ours also. We are very glad to have you and your colleagues with us here, and we hope that, inshallah, next IMDO, this pandemic would be over and it will be an open meeting like we used to have every time.
Yes, yes, yes.
So that you see the many changes that have taken place in Bahrain. And this year or two, in spite of the virus pandemic, you can see that so many sort of streets and roads and areas have been newly opened in Bahrain, so that it's worth really visiting. But unfortunately, due to this pandemic,
next year we'll do.
Next year, with the grace of
Sure.
God.
Hopefully next year we will get it physical.
Yes. There is another one who joined us. Only half of the face I can see.
Dr. Richard.
Hello, hello.
Hi, how are you, sir?
Fine, thank you, thank you.
Good morning to you.
Good, good. Good morning, Professor Richard. Good morning.
Good morning.
Dr. Patel has not joined yet.
I'm sure he will join.
There are 3 hours difference between us and them.
No, he's with us. We're all in Bahrain.
Oh, okay. Oh, that makes a difference then. Right.
Yes, yes.
So you are enjoying the sun in Bahrain for a change.
I am. Honestly, to come here in the middle of the English winter is absolutely marvelous. It just hugely boosted morale. Thank you.
Yeah.
And I can see even after 2 years a lot of changes.
Yes. I'm not exaggerating, but there are so many new areas that if there's an opportunity, maybe Dr. Asad or one of our colleagues will take you to see those areas, which is worth visiting, really.
Yes.
And the airport, this is the first time you come through the new airport.
Yes, I didn't recognize it actually. It's lovely, isn't it?
Yeah. It's totally new. Except the staff, who are the same, but all the buildings and all the facilities are completely not renovated, they're all new.
Just you have to mention, they have given you the Swiss code and the bank and the account number. You just go pay the money. Nothing, you don't have to show any passport, nothing, and send them the information that you have given. Then they'll make you the payment slip should be sent by email.
الله عليكم جميعا.
وعليكم السلام.
اهلا دكتور علي. عليكم السلام.
دكتور علي صبحك الله.
حياكم الله يسلمكم خليكم ان شاء الله.
اهلا وسهلا.
السلام ورحمه الله وبركاته.
الله ادعي لله عز وجل ان يبلغ لكم بلاغ عالي في المؤتمر.
ان شاء الله.
يحفظكم العائلات الكريمه كلكم ان شاء الله.
ان شاء الله.
امن وامان.
ان شاء الله.
امين اللهم امين. شكرا.
اسد عندنا عريف للحفل بيقدم شيء؟
اي الدكتور محمد.
نعم.
حيبتدي ان شاء الله.
محمد سلمان؟
نعم.
نعم دكتور.
اوكي.
اللهم ارفع عننا البلاء يا رب.
صباح الخير دكتورة نريمان، اهلا بك.
اهلا صباح الخير. Nice to see you all.
Okay.
Fresh and new start. Very happy to join IMDO for the 5th year. An honor بصراحة.
رحب بمعالي الشيخ. مرحبا معاليكم.
الله يصبحكم الله بالخير. كيف حالكم؟
مرحبا.
يا مرحبا.
صباح الخير معالي الشيخ.
موفقين ان شاء الله.
الله يسلمك.
مرحبا بكم.
مشكورين على رعايتك لنا. الله يسلمك.
الله يسلمك.
تفضل دكتور محمد. العفو.
بسم الله الرحمن الرحيم. معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة رئيس جمعية السكر الموقر، سعادة الدكتورة مريم الجلاهمة الرئيس التنفيذي للهيئة الوطنية لتنظيم المهن والخدمات الصحية، سعادة الدكتورة مريم الهاجري الوكيل المساعد للصحة العامة نائب رئيس جمعية السكر البحرينية، سعادة الدكتور عبد الوهاب محمد عبد الوهاب رئيس مجلس أمناء مراكز الرعاية الصحية الأولية رئيس المؤتمر، أصحاب المعالي والسعادة والحضور، السيدات والسادة المتحدثين والمشاركين المحترمين، السلام عليكم ورحمة الله وبركاته.
In the name of Allah, the most merciful, the most compassionate, Your Excellency, Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, Chairman of the Supreme Council of Health, Chairman of the Bahraini Diabetes Association, respected Dr. Mariam Al Jalahma, CEO of the National Health Regulatory Authority, Respected Dr. Mariam Al-Hajiri, Assistant Undersecretary of Public Health, Deputy Chairperson, Bahrain Diabetes Association. Respected Dr. Abdul Wahab Muhammad Abdul Wahab, Chairman of the Board of Trustees of Primary Healthcare, Chairman of Private Hospital Association. Respected COOs of private hospitals and medical centers, respected speakers and guests, a very good morning to all. Peace be upon you and God's mercy and blessings.
صباح الخير. تحت رعاية كريمة من لدن الفريق طبيب معالي الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة رئيس جمعية السكري البحرينية، ينعقد اليوم مؤتمر الطب الباطني والسكري والسمنة الإمدو في نسخته الخامسة وبصيغته الافتراضية ومن على منصة زوم بسبب الظرف العالمي الذي سببته جائحة فيروس كورونا وما فرضته من حظر للسفر والتجمعات على مستوى العالم، وسعيا منا في استمرار عقد المؤتمرات العلمية والتواصل بين العلماء والباحثين في مجال الطب. يعقد مؤتمرنا اليوم بعد التوكل على الله، وكلنا أمل في انتهاء هذا الوباء في القريب العاجل ليتسنى لنا مرة أخرى التجمع والتباحث في مجال العلم والتطورات في الطب. كلمة راعي المؤتمر معالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة رئيس جمعية السكر البحرينية، يلقيها بالإنابة الدكتور عبد الوهاب محمد عبد الوهاب رئيس المؤتمر. مشكورا.
شكرا.
Dear all, on behalf of IMDO 5 Patron Excellency Sheikh Mohammed bin Abdullah Al Khalifa, Dr. Abdul Wahab Muhammad Abdul Wahab will proceed now with the conference message. The floor is yours, Dr. Abdul Wahab.
Thank you. بسم الله الرحمن الرحيم. صاحب المعالي الفريق الشيخ محمد بن عبد الله الخليفة رئيس المجلس الأعلى للصحة، أصحاب السعادة الأطباء والباحثين والخبراء المتحدثين، أعضاء اللجان العلمية والتنظيمية للمؤتمر، السيدات والسادة الحضور والمشاركين من داخل وخارج مملكة البحرين، السلام عليكم ورحمة الله وبركاته. يسرني أن أرحب بكم في افتتاح الدورة الخامسة من مؤتمر الطب الباطني، وأن أكون ممثلا لراعي الحفل معالي الشيخ محمد بن عبد الله آل خليفة رئيس جمعية السكري البحرينية. أنا أرحب بكم ترحيبا حارا رغم استمرار الظروف الاستثنائية العالمية بسبب وباء جائحة فيروس كورونا، ويسعدني التحدث أمام هذا الجمع الكريم من الأطباء والباحثين والخبراء والمجتمعون اليوم للسنة الخامسة على التوالي للتباحث والتناول في أحدث المستجدات في عالم الطب الباطني، وخصوصا فيما يتعلق بأمراض السكري والسمنة، خصوصا في هذه الفترة الحرجة من الظروف الصحية الاستثنائية، والذي سلط الضوء بشكل كبير على أهمية الرعاية الصحية ودور الكوادر الطبية والعلماء والباحثين في التصدي للجائحة العالمية. وأصبح من الواضح تأثير وخطورة هذه الأمراض مثل السكري والسمنة على صحة الفرد والمجتمع، ودورها في تعريض حياة الأشخاص ممن يعانون منها لمضاعفات شديدة وخطيرة عند تعرضهم للإصابة بالفيروس التاجي، مما يحتم علينا جميعا الاهتمام والتركيز لإيجاد حلول علمية وطبية سريعة لمعالجة الارتفاع المستمر في أعداد المصابين بأمراض السكري والسمنة ومضاعفاتها، حيث لا يزال مرض السكري بما يسجله من زيادة مستمرة في نسب الإصابة به وبمضاعفاته تحديا كبيرا للعاملين في القطاع الصحي والمهتمين في إعداد الأهداف والخطط التنموية. تسعى مملكتنا البحرين دائما لتكون سباقة في توفير الرعاية الصحية الأولية والثانوية والثالثية والخدمات الطبية المتطورة والحديثة، ويظهر هذا جليا في القرارات الحكيمة التي يأمر بها سيدي صاحب الجلالة الملك حمد بن عيسى الخليفة ملك البلاد المفدى حفظه الله ورعاه، وبالمتابعة الحثيثة لتنفيذ هذه القرارات من قبل سيدي صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء الموقر حفظه الله ورعاه، لتكون صحة الفرد والمجتمع على رأس أولويات قيادتنا الحكيمة وحكومتنا الرشيدة. ومع استمرار جائحة كورونا والتي أصابت أكثر من 4 مليون شخص على مستوى العالم، وبمعدل وفيات تجاوز 5 مليون شخص، لتمثل الجائحة واحدة من أسوأ الكوارث الصحية العالمية، والتي استدعت إلى حالة طوارئ صحية عالمية واجهها العالم في العصر الحديث، مما تطلب القيام بإجراءات جدية وغير مسبوقة للتصدي لهذه الجائحة. أيها الحفل الكريم، إن الإجراءات التي اتخذتها مملكة البحرين في مواجهة جائحة كورونا والحد من انتشاره والقضاء عليه، والتي تمثلت بتأسيس فريق البحرين الوطني لتقديم الدعم والمساندة لكوادر وزارة الصحة في مواجهة هذه الأزمة. ولا تزال وزارة الصحة مستمرة بتقديم الخدمات بأعلى مستوى وفق أحدث التوصيات العالمية بما يحفظ صحة وسلامة المواطنين والمقيمين في مملكة البحرين. إن جهود الفريق الوطني قد حققت نجاحا كبيرا في مواجهة الأزمة، وذلك بإشراك عدد كبير من الوزارات والهيئات ومساندة المجتمع المدني، حيث أظهر الجميع التزاما كبيرا بالمسؤولية الوطنية، والذي يمثل المكمل الأساسي للجهود والقرارات والتوصيات، وركيزة هامة لنجاح كافة الخطط المساهمة في قضاء على الفيروس وحفظ سلامة وصحة الجميع، وتقديرا وعرفانا للجهد العظيم والتضحيات الغالية التي قدموها والتي ساهمت بنجاح مملكة البحرين في مواجهة هذه الجائحة، والتي شهد لها العالم أجمع، وتوج هذا الجهد بشرف التقدير والثناء من قبل قيادتنا الحكيمة، حيث نال كل العاملين في الصفوف الأمامية شرف منحهم وسام الأمير سلمان بن حمد آل خليفة للاستحقاق الطبي من لدن سيدي صاحب الجلالة الملك حمد بن عيسى آل خليفة عائل البلاد المفدى، بالإضافة إلى الرتب الاستثنائية تقديرا لجهودهم وتضحياتهم في تلبية نداء الوطن. عفوا. إن عقد هكذا مؤتمرات في ظل هذه الظروف يعتبر تحديا كبيرا ومتميزا، يساهم في بناء القدرات البشرية ومناقشة المستجدات العلمية والتعرف على طرق تقديم الرعاية الصحية أثناء الأزمات وكيفية مواجهتها، وخلق مناخ صحي وإعلامي لبث الإطمئنان وتأمين الحياة الكريمة للجميع من خلال استخدام الخبرات المحلية والعالمية لمناقشة مواجهة التحديات الصحية وابتكار استراتيجيات جديدة لطرق الرعاية الصحية في علاج ومكافحة الأمراض. ويسعى المجلس الأعلى للصحة تحت رعاية معالي الشيخ ووزارة الصحة والهيئات الصحية وبكافة كوادرها في بذل الجهود المتميزة والمعطاء في رعاية مرضى السكري والحد من مضاعفاته عبر تقديم أفضل سبل الوقاية والعلاج بما يصب في مصلحة وخدمة المرضى، وتساندها في تنفيذ هذه الخطط والبرامج عدد من المؤسسات والجمعيات الحكومية وغير الحكومية، ومنها جمعية السكري البحرينية وجمعية المستشفيات الخاصة لتعمل جنبا إلى جنب مع مؤسسات الدولة في تقديم البرامج المتميزة واستحداث برامج وأنشطة توعوية متطورة جديدة، وتعزيز الشراكة المجتمعية واستقطاب المتطوعين والعمل على نشر التوعية والتثقيف الصحي. وفي الختام أيها الحفل الكريم، الزميلات والزملاء، الإخوة والأخوات، اسمحوا لي باسمكم جميعا أن أتقدم بجزيل الشكر والتقدير إلى القائمين على تنظيم هذا المؤتمر العلمي، وأخص بالشكر لجان المؤتمر العلمية والتنظيمية والجهات المشاركة والداعمة لتنظيم المؤتمر Education Plus، جمعية السكر البحرينية، جمعية المستشفيات الخاصة والشركات الداعمة لهذا المؤتمر، وإلى جميع المحاضرين والمشاركين. وأعرب لكم عن تمنياتي بأن يحقق هذا المؤتمر الهام الأهداف المرجوة التي سوف يعقد من أجلها، وأتمنى لكم التوفيق والنجاح في خدمة هذا البلد العزيز وأهله الكرام، والسلام عليكم ورحمة الله وبركاته.
السلام. شكرا جزيلا.
أعطي كلمة بسيطة للإخوة من خارج البحرين. I want to في وقت كلمة للضيوف من خارج البحرين.
نعم دكتور تفضل.
Okay. Your Excellency Lieutenant General Dr. Sheikh Mohammed bin Abdullah Al Khalifa, Chairman of the Supreme Council of Health, Your Excellencies, dear colleagues, distinguished guests, ladies and gentlemen. As the President of the 5th consecutive IMDO conference, I'm greatly honored and pleased to welcome you all and express my sincere appreciation for joining us here in the Kingdom of Bahrain, and extend a very warm welcome to all of you. In particular, our distinguished speakers from the Gulf and Arab states, Europe and United States of America. Your enthusiasm and interest in sharing our experience and knowledge with us is immensely appreciated. Given the circumstances imposed upon us by the COVID-19 pandemic, we are compelled to break away from past tradition and make this event a virtual conference conducted on Zoom platform. However, I assure you that the content and benefit shall not be lacking of the high standard you have been accustomed to with past IMDO conferences. It was great honor to all of the Bahrainis and expats alike to read the tweet of Dr. Tedros Adhanom, Director General WHO, expressing his deep appreciation to the Crown Prince Sheikh Salman bin Hamad Al Khalifa and Prime Minister of Bahrain for his steady leadership and commitment to solidarity in the COVID-19 response, and especially for the Kingdom of Bahrain continuous support to WHO in effort to ensure vaccine equity and to defeat the virus. The cardiovascular diseases, diabetes and obesity, like many other clinical specialties, are not only facing challenges arising from the vast development of new technologies, the increasing emphasis on higher standards, guideline-based care, but also to the ever-rising expectations from the higher quality and an affordable cost with best effective services. This is forcing us to appreciate how services should be provided in the future. These changes will no doubt place an increasing demand on our knowledge, skills, and competencies. To meet these changes and demands, we need to intensify our partnership and cooperation with our colleagues from all over the world. This conference, we hope, shall provide a unique opportunity for local, regional, and international experts to share their experiences and knowledge gained from their research and clinical practice. With this outstanding scientific program prepared by the scientific and the organizing committee, and with the presence of this number of internationally renowned speakers and participants, I'm sure we shall remember this event for many years to come. Finally, on behalf of all of the members of the committees and all of those who spared no time to contribute with their efforts to bring this conference to its final shape, allow me to wish you all a rewarding and a fulfilling experience in IMDO 5 virtual conference. My sincere gratitude goes to Supreme Council of Health, Ministry of Health, National Health Authority, Tamkeen and Private Hospital Association, Educational Plus, Noor Special Hospitals, and all the pharmaceutical companies which supported and contributed to the success of this event. And a very cordial thanks to Dr. Asad Daftar and his team for all the hard work and effort with unlimited dedication to prepare, organize, and present this conference to you all in the best shape and form possible. Finally, thanking you all and wish you a very good stay in Bahrain and hoping to see you in the next IMDO 6, inshallah. Thank you so much.
شكرا جزيلا سعادة الدكتور عبد الوهاب. يتفضل الآن الدكتور أسعد الدفتر نائب رئيس المؤتمر رئيس اللجنة العلمية بإلقاء كلمته مشكورا.
Excellency and respected guests, now the word is for Dr. Asad Daftar, our conference co-chairman and chairman of IMDO 5 Scientific Committee. Dr. Asad, the floor is yours.
سعد.
Dr. Asad, are you there?
We try to call Dr. Asad, just 1 minute.
I think he lost connection or something. I tried to call him as well. Dr. Muhammad, can you proceed with the previous paragraphs?
انتظار دكتور أسعد. تولي حكومة مملكة البحرين الرشيدة في العهد الزاهر لحضرة السيد صاحب الجلالة الملك حمد بن عيسى آل خليفة ملك مملكة البحرين حفظه الله ورعاه اهتماما كبيرا بصحة المواطنين والمقيمين، ويظهر هذا الاهتمام جليا في الدعم الكبير واللامحدود الذي تقدمه الحكومة، ومن خلال المتابعة الحديثة والمباشرة من لدن صاحب السمو الملكي الأمير سلمان بن حمد آل خليفة ولي العهد رئيس مجلس الوزراء الموقر حفظه الله ورعاه، وحرص سموه على تقديم الدعم والرعاية السخية لجميع الفعاليات العلمية والأنشطة والمؤتمرات للارتقاء بمستوى الخدمات الصحية. أن مرض السكري والسمنة ارتباطا وثيقا بنمط الحياة وطبيعة الغذاء، وكلما كنا نمارس أنماطا صحية من خلال ممارسة الرياضة وتناول الوجبات الصحية كلما قلت فرص الإصابة بالسمنة ومضاعفاتها، وقلت فرص الإصابة بالسكري. والتشجيع على ممارسة أنماط الحياة الصحية، اتخذت مملكة البحرين العديد من الإجراءات التي تساعد وتحفز المواطنين والمقيمين على اتباع أنماط الحياة الصحية. أدعو الجميع الآن لفتح الكاميرا لالتقاط الصورة الجماعية من خلال تطبيق زوم.
Dear Excellency and respected speakers and guests, now I call upon all attending IMDO 5 virtual platform to get ready for the group photo. With Allah's grace, hereby we start the scientific sessions of the long-awaited IMDO conference in its fifth edition at 10:30 a.m. Bahrain time. Wishing you all a great knowledge-packed 3 days of the conference. Please open your cameras for the group platform picture.
كل الشكر والامتنان لمعالي الفريق طبيب الشيخ محمد بن عبد الله آل خليفة رئيس المجلس الأعلى للصحة، ولأصحاب المعالي والسعادة والسيدات والسادة الحضور، ولجميع المتحدثين والمشاركين على دعمهم وتواجدهم معنا. والشكر موصول لجميع الشركات الراعية والداعمة للمؤتمر. على بركة الله ستنطلق أعمال المؤتمر وبدء الجلسات العلمية في تمام الساعة 10:30 صباحا بتوقيع مملكة البحرين. شكرا لكم.
شكرا.
هلا he joined back.
قولي بالانجليزي حق الجماعه ان نبتدي الساعه 10:30 لا؟
Yes, I said in English that we are going to start at 10:30 a.m. the conference sessions. Okay. We are starting actually with Dr. Richard Quinton. Dr. Asad, you want to say anything?
Thank you for all of you. Sorry for the technical issues, so I get off. Basically, we will start, of course, 10:30, and the program will be managed by, according to the chairman and moderators.
Okay, Doctor. Thank you so much. Dr. Abdul Wahab, you want to say anything else?
Well, I'm just so glad to see that our kickoff is starting now. Inshallah, it's going to be a very fruitful and successful conference. Warm welcome to all the guests who are with us here, and warm welcome to people who are with us in the virtual sort of sessions that we have. And we hope that we will spend these 2-3 days with very fruitful thoughts and fruitful sort of experience, and widen our contact with each other and extend more sort of collegial relationship with many people who are contributing to this conference. And thank you very much.
Thank you, Dr. Abdul Wahab. Thank you for your support and being the chairman of this conference. Our respect to you. Thank you so much.
Thank you.
And to everybody else for attending. Thank you all for attending. All the CEOs of the private hospitals and medical centers. And the speakers, our delegates, thank you all for attending.
Thank you.
And kindly join us for the 10:30 sessions. And as I said, we are going to start with Dr. Richard Quinton. Dr. Muhammad, we will wait for another 7 minutes or 10 minutes.
I think if Dr. Yeah, we can wait just 5 minutes.
So for others to log in?
To log in, yeah.
I think
almost we have more than around 400 now join us on the platform. 330.
Dr. Muhammad, I think what we can do now, just we will give instructions to the delegates that most of the lectures we are on now.
Yes.
So basically what we are looking for the lectures, it will be between 20 to 25 minutes, but there will be a discussion. Question will be stated down, and chairman, moderator can see your questions, then they can answer. First of all, I wish just to welcome all of you to our 5th IMDO conference, thanking all the team who works really hardly to keep this conference in continuous annual, and to keep it in a position to be step by step to become international, and gradually to host the IDF MENA, and for the future to look for to cooperate whether with the all International Diabetes Federation or British Diabetes Association, and the Society for Endocrinology Network to state the launch for the research and for articles to be posted online and accredited internationally. Looking for all of you to attend and look for the speakers to give us their experience, and this conference will be built by your participation only. Thank you, all of you.
Dr. Asad, thank you. I just like to take this opportunity to thank my chairperson, my CEO of Noor Specialist Hospital, Dr. Afaf Al-Shafi'i, for attending this virtual platform. Welcome, Doctora, and thank you for attending. My medical director, Dr. Abil Liafi'i. Thank you, Doctor, for always supporting us and joining us. Thank you for all the support. Akid, Dr. Abdul Wahab, Dr. Ali Murad, also thank you for your support and for being with us on this great platform. I don't know if someone else from my hospital was here. I think Walid Al-Ansari was here, the CEO of the Gulf Diabetic Center, Medical Center.
You are lucky, Dr. Iman, to have all this support from all
Alhamdulillah, alhamdulillah. Thank you.
Management from the top, Dr. Abdul Wahab, Dr. Afaf, and Dr. Abir. I think it's done.
Honestly, without the support, we cannot make all of this. Thank you all.
The hospital provide a lot of
organizing
support
committee and for the scientific committee. Thank you all. Dr. Richard, you want to start?
Yes, I'm happy to.
Ready?
Happy to start.
How is Bahrain with you now?
Sorry?
Good morning.
How is Bahrain?
Beautiful. I'm looking out of the window. It's beautiful, sunshine. It's the sea.
That's great. That's
beautiful.
Great.
And it's good to see my old friends again. You all look so well.
Definitely. We always look forward to have you, and always in the first session, you're always ready to be the first one to start.
Thank you. So I will share the screen now.
So let me introduce you for our friends. Yes,
okay.
Anybody wants to say anything?
Yes, well, I wish to welcome Richard for this interesting lecture. Richard, he is one of the well-known the endocrinologist in Newcastle and over Great Britain, and he have the favor and flavor of giving the lecture in a way to understand this complicated topics. Thank you, Richard, for your participation.
Thank you very much.
Let me, dear friends, introduce Dr. Richard Quinton, who's a consultant and senior lecturer in endocrinology at the Royal Victoria Infirmary University of Newcastle upon Tyne, regional specialty advisor for the UK Northern Deanery, awarded the Ralph Nobel Prize by the University of Cambridge for MD thesis on hypogonadism, which remains his principal area of research interest. Dr. Richard's topic will be about the obese man with a low testosterone level. What is the evidence to support treatment with testosterone? Dr. Richard, the floor is yours.
Thank you. Okay, so can you all see the screen?
Yes.
Lovely, okay. So many thanks for the invitation. It's such a pleasure to see you all again. When I look at the title, this for me is, when I get a referral in from primary care, this is the heart sink. Oh no, not one more of these, what to do? But of course, behind that, there's the patient who needs some help. And what I'm going to try and do is to make this, well, in real life, I try and make this as simple for myself as possible. And my aim is also to make it as simple for you as possible, to try and turn something that may appear kind of complex and difficult and borderline, and as far as possible, make it more manageable.
Dr. Richard, sorry, can you share your screen? It's not seen.
It's not screen. Okay, so let me just see. I thought I was sharing. So share screen. Share screen. Can you see that?
Not yet. We can see your video now. Yes.
Yes, now you see it. Okay. And you can still see it.
You can see the Donald Duck now.
Very good. Okay.
Good.
So one of the things about male aging, and of course male aging certainly in the Western world is quite strongly associated with obesity and male hypogonadism, is that there's a lot of commonality. For things like fatigue, anemia, osteoporosis, sexual dysfunction, loss of muscle weakness, frailty, and obviously obesity. And we need to be able to distinguish between, for instance, frailty. Is this a man with primary frailty of old age or primary obesity of old age, or is this a man in which hypogonadism may play a part? Because testosterone is a great treatment for hypogonadism. It's not a particularly great treatment or effective treatment for men whose problems arise predominantly as a result of old age. And this is why we're concerned about old age. We want not just to live longer, but we want to live well and have a better quality of life. So this is the science slide. Forgive me, but this is my first and last science slide. And what I wanted to really emphasize is the way that the pituitary gonadal axis integrates both internal and external homeostatic signals. So it's so as to generate function of testes, testosterone production, spermatogenesis. And so where this is integrated mainly are the candy neurons of the arcuate nucleus in the hypothalamus. And they integrate virtually all of the external and internal homeostatic inputs. And then their slave are the medial-basal GnRH neurons. They just do as they're told by the candy neurons, and they don't have any inputs. All the inputs occur higher up. So GnRH then tells pituitary gonadotrophs to make LH and FSH, which drives the testes to make testosterone and sperm. In terms of internal negative feedback, some occurs at the gonadotroph level, but most of it occurs centrally on the candy neurons, and most of this actually is mediated by estradiol. So in fact, if you give a man a selective estrogen receptor modulator such as clomiphene or tamoxifen, or an aromatase inhibitor such as letrozole and anastrozole, you kind of fool and drop estrogen action. You then cause the candy neurons to go into overdrive, GnRH excretion go into overdrive, you push up LH and FSH levels, push up testosterone levels. Body mass is also very important. You need a minimum amount of adipose tissue to make enough leptin to permit the candy neurons to function. We're familiar in women that when they lose too much weight or they're stressed or lack of sleep, but the periods stop. There's a similar thing that's also observed in men when they sort of hyper-exercise and lose weight. But then I've got also, if you have too much weight, that can be one of the stressors to switch your axis off. So sleep apnea, hypercortisolemia, inflammatory cytokines, adipokines, and obviously increasingly we're now getting people who are buying sex steroids off the internet that can also shut the axis down. And there's also an explosion in opiate prescribing. A generation ago, you had to be dying of cancer to get opiates. Now, a bit of back pain, opiates, and that frequently suppresses the male and also female axes. So there are various definitions of male hypogonadism, and this is the way that we chose to do it in the recent Society for Endocrinology guidance, about which I'll be talking later on. So clinical syndrome comprising clinical features and laboratory evidence of impaired testosterone secretion and infertility. Because in our view, with rare exceptions, if you've got preserved fertility, preserved spermatogenesis, it's extremely unlikely that you have underlying hypogonadism. And that's something that other guidelines have really failed to put into the frame. And although the diagnosis conventionally requires the presence of sexual symptoms, testosterone is actually equally important for other aspects of men's health. And through contextual clinical and laboratory ascertainment, the diagnosis should always be framed in relation to a recognized cause and whether the defect is testicular primary or central secondary. And if you're unable to do that, then you're wondering, is the diagnosis actually correct? But also the big simplifier, you hear about, well, levels of testosterone, they must be checked fasted at 9 a.m. and 2 weeks apart or more than, but actually, if you happen to find a low testosterone and a higher LH level, that's primary gonadal failure. There's no other interpretation. You can diagnose that on a single venipuncture without clinical correlation and actually without needing to repeat the sample. So clinical features of hypogonadism. So these fall into what I would call reproductive, sexual dysfunction, infertility, gynecomastia. And if it's severe, failure to develop or loss of secondary sexual characteristics. Non-reproductive, physical ones, fatigue, reduced strength and endurance, anemia, osteoporosis or fracture, vasomotor symptoms. And then the psychological, loss of motivation or concentration, irritability, low or labile mood. And for those with congenital disease, often issues of body shame, depression, distress, and psychosexual issues. What I would say is that the ability of testosterone to improve the psychological issues is much less clear than its ability to improve reproductive or non-reproductive physical issues. So the laboratory diagnosis ideally measures total serum testosterone levels fasted before 11 a.m., preferably after a good night's sleep and not during periods of intercurrent illness. And the diagnosis of hypogonadism is supported by other investigational facets. So if the LH is up, if there's low bone density, if there's anemia, if there's infertility, or if the serum testosterone is below reference range on at least 2 separate occasions. In men with very high or very low sex hormone binding globulin levels, a calculated free testosterone better reflects androgenicity. There are limitations to free testosterone, so the calculation has not yet been fully perfected, and also the SHBG assays are much less well standardized than testosterone assays. So, and also importantly, if your LH is not raised, and therefore you're suspecting central or secondary hypogonadism, you need to do further investigations to look at overall pituitary function, particularly prolactin level, iron studies to rule out hemochromatosis, iron overload, and usually MRI scanning. Unless it seems to you that this looks like non-gonadal illness rather than true secondary or central hypogonadism. And I'll come to that later. So why do we say do the blood tests fasted? And this is because 3 studies, all published in Clinical Endocrinology, showed that with a glucose intake, such as 75-gram glucose tolerance test, or with protein intake, or with glucose and protein, there's a big drop in LH-driven testosterone secretion acutely during the delivery of nutrients, and pushing about 30% of men into the apparent hypogonadal range. So always to avoid false positive diagnosis of hypog, not just early morning sample, but do them fasted. I was going to talk about non-gonadal illness, and this is one of the nicest reviews, 1997, but it's still one of the best reviews, showing how the male reproductive axis no matter how the underlying illness tends to shut down, and that's a physiological parameter. So biochemically, it looks just like central hypogonadism, but it's more analogous to non-thyroidal illness or sick thyroid syndrome. And when the underlying disease is cured or remits, levels of LH, FSH, and testosterone invariably normalize. And this is one cause of having that profile. Obesity can do that as a chronic illness. But we know that with weight loss, you restore eugonadal chemistry, and bariatric surgery will do the same. So the European Male Aging Study gave us great new information. So we've always known there was an age-related decline in serum testosterone, but this showed that reflected the physiological effects of obesity, inflammation, and accumulating illnesses of old age to suppress the gonadal axis. So it's a functional phenomenon. It just shows that as we get older, we generally get more obese, and the illness suppresses the axis. That's not really true hypogonadism, it's physiological. However, crucially, having until now always given talks saying the male menopause, it doesn't exist, it's just a marketing thing driven by the drug industry or by unscrupulous practitioners, actually I'm partly eating my words, because in fact 1 to 2% older men actually genuinely have primary gonadal failure with low testosterone and high LH. This slide here, there's a very similar one from European Male Age Study. This is actually from the Chinese equivalent, SPECT China. But we see here, if we divide men into quadrants, so here are the normal men. So normal testosterone, normal LH. Here are the men who said to have, here are the men with primary hypogonadism. They got low testosterone and high LH, and that's 1.5%, very similar to EMAS. And then we have the men with kind of what they term secondary hypogonadism, with low testosterone, low LH. But of course, many of these men, in fact, will actually just have non-gonadal illness of age. And then with this group that they call compensated hypogonadism, which is about 10% of the older men with normal testosterone but high LH. But actually, when they say compensated, that's a biochemical term. In fact, if a man like this has low normal testosterone and high LH, and they got anemia or osteoporosis, infertility, or sex dysfunction that doesn't respond to Viagra, you think, well, actually, just how compensated was that? But also, you might have just caught some high LH pulse peaks. So that's a kind of mixed bag, maybe, in this group of compensated hypogonadism. Interestingly, in primary hypogonadism, there's of old age, there's a trebling of the risk for type 2 diabetes, as there is in Klinefelter syndrome, and as there is in dystrophia myotonica. So it seems there's something about having primary hypogonadism that trebles your risk of diabetes, of type 2, but what we don't know is the direction of causation. One interesting thing about SPECT China, which wasn't seen in EMAS, was that the fall in testosterone with aging continued until middle age, but actually the very old Chinese men, due to the very low prevalence of obesity, actually had similar testosterone levels to those of younger Chinese men. So the older men hadn't really adopted the obesity-generating Western diets. So why might an obese man have a low testosterone level? So first of all, he has the same chance of being hypogonadal as a slim man. So same things apply. It could also be artifact. So if this blood sample was taken in an afternoon or non-fasted, you could have an apparently low testosterone with inappropriately normal or low LH and FSH. It could also reflect insulin resistance. So we know that in prediabetes, there's normoglycemic hyperinsulinemia, and insulin switches off hepatic SHBG production. Thus, you may have a total testosterone that's low, but SHBG may be very low, and thus if you calculate free testosterone, in fact, that may turn out to be normal. or it may also reflect non-gonadal illness, which is actually a normal physiological response, and what we don't know whether this is adaptive, maladaptive, or neutral. So what should be your first instinct when this referral comes in? Actually, for me, it's people often had blood tests before. Look them up. Look up the hemoglobin and the hematocrit. If the patient's got a high normal hemoglobin and hematocrit, first of all, it's very likely to be hypogonadal, because you need testosterone to make those male range hemoglobin levels. And more importantly, if you put them on testosterone therapy, they'll be very likely to get erythrocytosis or polycythemia, which is really to be avoided. So that's a little bit of low-hanging fruit that can reassure you even before you've seen the patient. So I'm now going to look at some studies. So these were studies done on obese older men with slightly low testosterone and low normal LH. In the studies, these were termed as being men with secondary hypogonadism of old age. Although, in fact, by my definition, I do wonder whether most of them may have had non-gonadal illness. But there's some very interesting lessons that emerge from these. Just to say that, intriguingly, although these studies were actually meant to be of older men, they excluded men with primary gonadal failure or competent hypogonadism with a high LH, which seems a bit odd, because I would say that's the true hypogonadism of old age, where the LH is up, the Leydig cell function begins to drop. So there are two key randomized control studies. The T trials, which is an intersection of 7 interlinked studies, and the T4DM study. And I'll run you through these. So T4DM, published last year in The Lancet, testosterone and prevention of type 2 diabetes. So this was a 2-year randomized control study of 1,000 men aged 50 to 74 years old. High waist circumference. Not all of them were hypogonadal, so that you had to have a fasting non-empty testosterone less than or equal to 14 nanomole per liter. So that's what, 400 American units maybe. And even then, when you think these are obese, insulin resistant, even those with low testosterone may well have had a normal calculated free testosterone. And at baseline, they either had type 2 diabetes or they had impaired glucose tolerance, about 80% IGT and 20% type 2 diabetes. And they were randomized to Weight Watchers lifestyle plus placebo, or Weight Watchers lifestyle plus testosterone under and IMDO every 12 weeks. There were 2 deaths in each group. And at the end of the study, end of the 2 years, 21% had type 2 diabetes with placebo, and only 12.4% had type 2 diabetes with testosterone. So that's very impressive. Challenges. So many of these participants didn't even have non-gonadal illness, let alone hypogonadism. There was no relationship between the baseline testosterone level and treatment effect. And nearly a quarter of the testosterone arm developed hematocrit greater than 54%. And about 50% developed hematocrit more than 50%. And I mean, I personally always prefer to keep the hematocrit below 50% in men on testosterone. So, you know, if you give people a lot of severe erythrocytosis, that can potentially increase your cardiovascular risk of blood clots. So, the T trials. So these were overweight or obese men aged 60 plus with said to have secondary hypogonadism, although by my view, possibly non-gonadal illness. And this was trial number 1, which showed that testosterone improves sexual function, however, by not much more than Viagra. And it doesn't look as if the effect was sustained beyond the first year. So interesting, but not hugely impressive. The physical function arm, no difference in men able to walk more than 50 meters within 6 minutes. The vitality arm, no significant improvement in the fatigue score that they used. This is the interesting bit, though. This is the anemia testosterone trial number 7. And so a third of older men have unexplained anemia. And amongst older men with low testosterone levels and anemia, testosterone treatment significantly increased hemoglobin level. And interestingly, this happened whether or not you thought you knew the cause of anemia or whether it was thought to be unexplained. This, for me, is something of a game changer. So I've talked about hemoglobin hematocrit, and I'll run through why I think this is important. So testosterone stimulates red cell production in the bone marrow. No one's totally sure why. It could be direct action, it could be indirect via increased renal EPO secretion, or it could be mediated by hepcidin, with hormones secreted by the liver that regulates iron absorption. And we know that if you're deficient in testosterone, you have lower hemoglobin and hematocrit, which applies to being childhood, female sex, or if you're hypogonadal. And of course, excessive testosterone causes erythrocytosis, as evidenced by Lance Armstrong. He used quite a lot of it. What are the risks of having a high hematocrit? Well, in the Copenhagen General Population Study, if you had a hematocrit more than 48%, your risk of heart attack was 50% greater than the middle 50 centiles. And in the Tromsø population study, if your hematocrit was greater than 46%, you had a relative risk, a 50% increased relative risk of venous thromboembolism, and a 2.4% increased risk of unprovoked, or 2.4 times greater risk of unprovoked venous thromboembolism compared with the bottom 40 centiles. So we see the high hematocrit seems to predispose to thrombosis, whether arterial or venous, so to be avoided. So testosterone and bone health. This comes from the bone trial, number 6 of the T trials, and also the T4 bone trial, which is a sub-study of the T4DM trial. For the T trials, there was a 7% rise in spine trabecular bone density over 1 year, testosterone gel versus placebo. Smaller rise in the T4 bone trial, but of course, these men had higher testosterone levels at baseline. So, my conclusions. The benefits of testosterone in male hypogonadism can't be extrapolated to men with low testosterone levels due to age-related frailty or non-gonadal illness. You need to avoid or defer testosterone treatment in men who want biological parenthood or have active prostate or breast cancer, erythrocytosis, or uncontrolled obstructive sleep apnea or uncontrolled cardiac failure. And although the T4 DMs trial showed that testosterone protects against diabetes in older obese men with or without low testosterone, this was at the cost of an unacceptable rate of erythrocytosis. And so for obese men with a borderline low testosterone and low normal LH, the evidence really is for lifestyle change. We know that lifestyle change greatly reduces the cardiovascular risk factors and it normalizes testosterone levels. So that is your number one treatment. The things that might push you into treating men with testosterone would be things like osteoporosis, anemia, reduced testicular volume, or refractory erectile dysfunction. So many thanks for your attention. And this is just referencing the guidelines that have just been published in clinical endocrinology. And I will.
Thank you, Richard, for a nice presentation. There is a question over here in the chat, and then the question and answers. One from Professor Barbara. How much, you can see it in front of you, of how much does fasting affect testosterone level?
About 20%.
Yeah. And we have another question from Dr. Huda Omran in the QA. She's asking, is there a role for ROS measurement and other molecular tests in the diagnosis of hypogonadism in diabetic infertile male?
So I would say this is your low-hanging fruit in diabetic patients. What is the hemoglobin and what is the hematocrit? That will, and also what is the LH level? As I said, men with primary hypogonadism have a trebled risk of type 2 diabetes, whether the cause is genetic or congenital, such as Klinefelter's or such as spermatonica, or whether it's testosterone in old age. So, and in men with primary gonadal failure, your only way forward is, well, do they have any sperm left in the ejaculate or testicular microdissection? Now, the question is, but if they have low LH and low testosterone and they want fertility, well, the very last thing that they need is testosterone. And that's because to make sperm, you need a lot of testosterone inside the testes. And the only way to do that is to have the testosterone made locally in the testes by the Leydig cells. You put exogenous testosterone into the system, you drop LH and FSH, and therefore you drop Leydig cell secretion. And actually, although you may raise plasma levels, you actually cause the levels inside the testes to crash, and that takes your sperm count out. So what other treatments are considered? Well, people have looked at gonadotrophin treatment. So you can potentially see, well, if I put HCG and FSH into the system, can I improve the sperm count? Or the other thought is whether to use something like an aromatase inhibitor. I would not use a SERM, such as clomiphene or tamoxifen, in an obese man, because SERMs are prothrombotic. Aromatase inhibitors have the issue that they reduce bone density, but then again, obese men tend to be protected against osteoporosis. So potentially, like a low dose of aromatase inhibitor, say anastrozole, half a tablet every day or every other day, potentially there's some evidence that could improve your sperm count by boosting LH and FSH levels. Only problem is that part of the action of testosterone on male libido is mediated by estradiol. So giving an aromatase inhibitor won't necessarily improve sexual desire, even though you push the testosterone levels higher.
Yeah, there is another question. If we can understand that, does low blood pressure in male has any negative effect on sexual dysfunction? I don't know whether this is the right question, but
so I don't know, I have to say. It's not my area of expertise, but in terms of choice of antihypertensives, if you do have sexual dysfunction, the key thing is the ones to avoid are beta blockers and diuretics, and the ones that definitely improve sexual dysfunction would be the alpha blockers such as doxazosin and possibly also vasodilators. So that's all I can say, really.
Thank you very much, Richard, for a really impressive lecture. Then now we will go for the next speaker, Dr. Evgenia Patrikieva, consultant endocrinologist and consultant working in the neurosurgery department, St. Petersburg City Hospital. She's teaching assistant and St. Petersburg Medical University, founder of educational web resources for patients with the diabetes, senior lecturer for postgraduate courses in European Association for study in diabetes. Virginia, she's really the one who can say that impressive action she do for her patients. She has direct communications with a group of patients and make medicine differently. Her lecture, Dr. Virginia is with us.
Yes, I'm here.
Yes, nice to meet you this morning. So today lecture will be about the assisted reproductive technology in diabetes. Floor for you.
Thank you for a kind introduction. Just a second, I will share my screen. Is everything okay? Can you see my slides?
Yes, please.
Dear colleagues, dear friends, and after all these years of wonderful IMDO conferences, I know that we are one community with one goal to help our patients as successful as we can. And it's a great pleasure for me to be here with you again, even virtually, and with a great hope to meet you next year's face by face. And of course, I would like to thank organizing committee and personally Dr. Assad for his efforts to communicate with everyone here. And I wish everyone good health, even in this complicated era of pandemic situation. Here in Russia, we are again in severe crisis, but I wish you, all of you, good health and peace for your families. Today, my talk will be about a very interesting topic. We will discuss in next 20 minutes, and I will try to spend at least 10 minutes for questions and answers. And I hope for your very active participations and for your questions and comments inside the chat, because it's a great pleasure to communicate with such good doctors like you. And of course, if you need my presentations or any slides from this talk or for other talks for today and tomorrow, you can just text me or find a mail by this address, which you can see on the first slide, and I will send you everything you need, because again, as I said you before, we have the one goal to help our patients. Why the topic of assisted reproductive technologies is so important? Because usually when we discuss it, of course, we have our big brothers, obstetricians and reproductologists who are working with the patients and reproductive functions, and they looks like really superheroes. And we are endocrinologists, and these situations usually are like annoying persons who just started to think that we can help you, but of course you can do anything without us. But it's not true. So for the next 20 minutes, we will discuss why it's not true and why it's so important to remember about all metabolic changes during IRT, and how we as endocrinologists can help our obstetricians to work with patients with infertility. What about agenda? First, we will discuss some sort of short introduction to infertility issues. After that, about risk of diabetes development during these technologies usage. After that about pre-existing diabetes and ART, and we will have some conclusion in the end. So for introduction, of course, annually around 30% of couples in the world experience infertility. Unfortunately, IVF is a powerful therapeutic tool, and of course, it's a medical solution with a great success, but needs to a considerable rate of active cooperation of the patient, because this treatment can be increased not all our metabolic issues and everything with health, but also psycho-emotional exhaustion of mothers during pregnancy. And it's a well-established and efficient fertility technique now, but we still have a lot of issues with safety, both maternal and fetal, and we need to discuss it also. Definition, of course, everyone knows that it's inability to conceive after 12 months of protected intercourse, and 6 months for women 35 years of age and older. And very frequent situation, from 15 to 20% of couples are infertile, 35% it's about female infertility, 30% male infertility, 20% combination of these two issues, and 15% of cases corresponds to idiopathic or unexplained infertility. So it's very often situation. What we know about assisted reproductive technologies, of course, it's a various procedures, and it's possible to use for female or male infertility. We have various steps, including ovarian stimulation, also sperm recovery, gamete, embryo manipulation, cryopreservation, vitro culture, embryo transfer, a lot of things around this. With the great degree of interference of each procedure, it also can vary. And these steps are known to take place at critical time of development, when the genome is undergoing significant epigenetic remodeling. So we still need to remember every second that we are working with very precise and very important time for development of the future human being. And here, because of all these procedures, all this differentiation between them, we need to remember about risk of diabetes development for a woman. And of course, here, when we discuss all these critical things around embryo development, we need to remember about diabetes development risk for a baby. So let's start for discussion of these two fields. And of course, the huge development, very important things what happened for IRT for last years. Even we'll start from the beginning, from the birth of Louis Brown and in 1978 years. It was going so many steps, and now it's really great progress in this field. And just as a short description for you, if you are not working in reproductive field, we have an in vitro fertilization process, we have some sort of associated procedures, and of course, a lot of additional option procedures. And just for knowing of all this terminology, I'm going to show you this slide just for understanding what's going on when we will discuss diabetes risk here. Of course, there are a lot of publications about complications of these reproductive technologies usage, and of course, it's abnormalities and defects in the placenta, defects in nutrient transport, morphological abnormalities, impaired vasculogenesis, antioxidant defects, low birth weight, and intrauterine growth restriction. So there are so many things around complication also. And as you know, the last two issues are associated with detrimental long-term metabolic consequences, and we will discuss it later. It's about obesity, even in puberty of children, insulin resistance, cardiovascular disease, hypertension in adults. But let's just focus on the beginning, and we will start for risk of diabetes development for women. Of course, everyone knows about physiology. There are so many things around these issues, around all changes during the first trimester, second trimester, and of course, always changing in fasting serum insulin is similar to non-pregnant for the first trimester, but later it increases significantly. And of course, insulin actions is also lower for 50 to 70%. And we know all this data from the clamps during the second and third trimester compared to the first trimester. And insulin resistor is a huge problem here. And of course, we can discuss it like a diabetogenic effect of pregnancy stems from impairment of insulin sensitivity and after to increase beta cell activity in response to greater requirement of insulin. This phenomenon occurs primarily during the second trimester or late gestation. And of course, insulin resistor plays an important role of etiology of numerous adverse events like gestational diabetes, preeclampsia, and miscarriage. And there are so many publications. Let's start just from classical ones. And there is a very famous publication from Sonagra with all these numbers here, which increase in number and glucose levels and fasting insulin level. And if you just try to summarize everything around glucose and insulin metabolism, of course, we know that fasting state and postprandial state are changing. Insulin secretion, fasting one for normal pregnancy and gestational diabetes are increasing. And of course, after glucose low in the first phase and second phase, we have some changes and in normal pregnancy and in diabetes. What about insulin resistance? Of course, target organ here is muscular tissue, and we know some molecular mechanisms. What about hormones associated with modification of insulin issues? Estrogens, progesterone, cortisol, all hormones from placenta, leptin, and glucagon. And of course, we know all these severe consequences of insulin resistance, and just try to think about these things like in a common process from the beginning to the final stage of the pregnancy. What about IVF and pregnancy physiology? Of course, we have some studies on oral contraceptive therapies about estrogen and progesterone reported their different findings in relation to the impact of glucose metabolism and insulin homeostasis. Of course, about some impairments of insulin sensitivity and glucose tolerance was commonly experienced with the use of oral contraceptives, but we need to remember that there are some controversial meanings here, that some of them are described about estrogen-related things and others about progesterone-only effects. But we need to remember also that IVF, it's not the same dosages of this hormonal treatment and as oral contraceptive, but we just need to remember that it can be explain a lot of glycemic and metabolic effect of such therapies to those women who involve in IVF. So the answer from physiology point of view here, does IVF therapy influence on glucose homeostasis? Of course, but we still need a lot of things to do in this field. And as a first conclusion, I would like to say that human data is very limited in relation to the effects of IVF on insulin and glucose homeostasis during early pregnancy. And of course, we need further studies to explore the potential for IVF-related hormonal therapies to augment the diabetogenic effect of pregnancy. So what we know now about risk of gestational diabetes mellitus development in a period of assisted reproductive technology usage. As you can see here in this meta-analysis, the findings of this systemic review indicate that the use of IRT treatment is associated with even 1.5-fold increase of risk of GDM. Is it severe? Of course, yes, because all of us knows how difficult it is to treat such women, what we need to do, all issues about insulin treatment, it's still an issue in every day clinic day for diabetologists. So this number is really huge for us. And with increased number of IRT treatment, of course, we need to remember what can we do here, and we will discuss it later. If you're just trying to compare by the region, you can find here Europe, Asia, America, and you can just go through all different types of studies which were included in this analysis. Again, the risk is just great, and we cannot, as clinical practitioners, to forget about it. And it's not enough. So now we have some data about assisted conception as a potential prognostic factor predicting insulin therapy in pregnancies complicated by gestational diabetes. So it's not only things that we know that we will greater risk for GDM development, but we also know that if the women used these technologies to conceive, we need to remember about high risk of insulin treatment for these patients. But of course, here it's very important to remember about babies from these IRT, GDM plus GDM pregnancies, because it's also a great amount of problems with babies. But is it unpredictable? Can we do something? If you know that the risk is high, is it the reason for us just sit and say that it's very difficult? Maybe we don't need to use these technologies because there are so great number of gestational diabetes and insulin treatment. But here the rule is the same. So what is the reason for me to put this paper here? Because the result is very great. Look, we just have 170 patients with middle age, without obesity, no family history of diabetes. And the researchers just perform 3 exercise weekly classes for 60 minutes for these patients. And the conclusion here is perfect. So even if you just try to put some attention to this physical activity and everything to predict all these severe issues with gestational diabetes for IRT treated women, we will have success. So for us, it's again a reminder that we need to do as much as we can do for our patients. And of course, we just go through control intervention groups for gestational diabetes preeclampsia. Here we have the intervention group had a success. So dear doctors, dear friends, let's do everything for our patients and discuss every visit even after IRT treatment, and even for gestational diabetes women, that we need to put a lot of attention to physical activity. So the second conclusion will be that maternal preconception characteristics are likely to play a role. So we need to remember about obesity, about family history of diabetes. We need to be very, very attentive to screening of high-risk populations and for preconception. And of course, we need to manage our women as early as possible, because it's the only way to prevent possible complications and predict IVF success. What about risk for baby? It's well-known slide which was published in Diabetologia a couple of years ago. But of course, if we discuss the greater risk of gestational diabetes for women treated with IRT, we need to remember that it's a high risk for offspring, about adiposity at type 2 diabetes development. And of course, we have a lot of animal studies, and here just like a summary. We can look and find information about cardiovascular morbidity, about hyperglycemia, about activity of insulin, about always expression of lipid metabolism genes, about weight. So it's enough just to say that it can be very important. But what about human study? Of course, just a very famous work from Manon Céline, that it's about higher glucose level for these women and for these children. And of course, it's very important. Even if their numbers are not so high, but we need to remember that it's significantly statistically for us, and we cannot just forget about it. And another work for children from 5 to 6 years old of age. And again, here glucose level were higher for children who were conceived with IRT technologies. So it's again a focus of our attention to work with these children, not as only as endocrinologists, but also as pediatric endocrinologists. Another issue here, it's not only just blood glucose level, it's also body composition in children and adolescents. And of course, here we can just find information that fat composition differs. And of course, it's a way to adiposity and other problems around type 2 diabetes for these children. And also very famous paper, it's about arterial hypertension and during adolescence for these children. And again, it's a reminder of our necessity to be involved to care of these children. If we're just trying to summarize, and it was published in a beautiful review of Maria Florencia, and you can easily find it in the internet, or you can just text me or write me by email. I will send it because it's a brilliant paper. And what we can find here, again, it's about central adiposity and about peripheral adipose tissue at pubertal age, about pulmonary hypertension, altered artery structure, about systolic diastolic pressure, about glucose level, insulin sensitivity, and about high triglyceride levels for these children. And for us, it means that, that it's high risk of type 2 diabetes, metabolic syndrome, and cardiovascular disease. To conclude, first, studies show that IRT could influence on lipid and glucose metabolism, and IRT in these children resulting in a high risk of type 2 and metabolic syndrome. Of course, preconceptional period of IVF conceived children might be a critical time window during which cardiometabolic function can be perturbed, and we need to remember about it. What for me, the main question always is, what can I do for my patient in this situation? And we need to be attentive for this preconceptual period of time. And of course, it's importance of continuous worldwide monitoring of postnatal development of IVF children needs to be discussed very widely. And if you have such population of children or women, let's do something together and publish our data, because of course, if you just try to find information about it, there is not so many publications in this field. And I think that it can be very important for our patients, and we can change the world here. The next part is about pre-existing diabetes and possibility to use IRT, and of course, well-known information about mechanism on interaction between type 2 diabetes and reproductive function. And of course, it's through insulin resistance, hyperinsulinemia, about stimulation of IGF-1 and hybrid insulin-IGF receptor, and of course, with some problems in the reproductive system. if you're just trying to go through this slide, I would say that we easily can just add fertility here, because there is impossible to discuss just vascular things around type 2 diabetes, hypertension, mediated target organ damage, metabolic things, caloric intake, sedentary lifestyle, but it's also a problem not only in cardiovascular field, but also in fertility field. What about type 1 diabetes? There is a little bit difference from type 2 diabetes, and it's mostly about hyperglycemia and decrease in ovarian steroid production, and that's why hypogonadism, pubertal delay, menstrual irregularity, and so on and so forth. But also there are some issues here with polycystic ovarian morphology and hyperandrogenic traits and early menopause here. What we know about IRT and type 1 diabetes, I hope that you have read this paper, which was published a lot of years ago, but it's, for me, it's like a pioneer work in this field, so it's very important to citate this. And the answer for this, not such a great amount of patients with type 1 diabetes, but the discussion here was that they allowed to participate in IVF programs, but only after tight preconception metabolic control, which we need to perform for these patients. And just to remind about all things about pre-pregnancy care, of course, it's safe and effective contraception, education, stop unsafe medication, stop smoking, reduce alcohol, start folic acid, and aim for HbA1c, because we, as clinicians, we can help to our patients with that. There are so many things written about the necessity of usage of CGM here, of flash monitoring here, and of course, with some issues with pregnancy care for type 1 diabetes patients. And what we need to add here, that was a great publication again in Diabetology about live-born children after assisted reproduction in women with type 1 diabetes and type 2 diabetes. And it was a population from Danish cohort with a lot of women who were involved in this study. It's more than 500 of them with type 1 diabetes, type 2 diabetes. And if you could just go through this, the live birth per embryo transfer was 0.5 in women with type 2 diabetes and 1.1 for women with type 1 diabetes. That means that compared with women with diabetes, women with type 1 diabetes had an equivalent chance to live birth in embryo transfer, whereas women with type 2 diabetes has a reduced chance. And again here, because I'm really believe that preconception care here is a key. And of course, we know the structured preconception care reduce perinatal mortality and morbidity in type 1 diabetes. And again, it's true for type 2 diabetes, and we have some clinical implications here. So the last conclusion is that women with type 1 diabetes has equivalent chance to live birth, but for type 2 diabetes is not true. But again, prospective studies in diabetes mellitus patients, including characterization of anthropometristic, maybe glucose and lipid metabolism, treatment at the time of IRT, and biomarkers of chronic inflammation should be performed. So all of you are very welcome. Let's do something like working group on this. And I know that it will be very helpful for our patients. So let's finish from the beginning. Who is responsible specialist for this? Only obstetricians and reproductologists need to be involved in the care of these patients? Of course, no, because only with us and only working as a team with endocrinologists, it will be successful IRT usage for our patients with diabetes, or even without, but with high risk of gestational diabetes development, with higher risk for children who will be born after such pregnancies. So, dear colleagues, dear friends, I know that you believe me that together everyone achieves more. Let's work as a team here. And I would like to have a special thanks to my colleagues working with me with university, in reproductive clinic, and all my teachers, all my friends, because without them, it will be impossible to say anything here. And again, if you need something from my presentation, you can just write me and I will send you everything. Thank you for your attention.
Thank you very much. It's a really nice presentation and interesting topic to keep. I think we need more research in this statement. Regarding questions, we have Dr. Huda Umran thanking you for your lecture, and she's asking whether we need to exclude maturity onset diabetes of young prior to IVF procedure in patients with the strong family history of diabetes, in addition to the routine genetic test before IVF.
Thank you for a question. Of course, we should not exclude these patients from possibility to have a child, because, you know, for a lot of patients, reproductive function is very important, and there is not so many publications about type 1 diabetes and type 2 diabetes, and if we will just try to find some information about other types of diabetes, unfortunately we will not find anything. So if you have such patients, let's do something together, because of course there is no enough information about it. But I'm sure that it's a exclusion criteria, because we need to help everyone, and for patients with other types of diabetes also. What is very important, because we know from animal studies and from human studies which were published before, that the key here is preconceptional care with target level of HbA1c. So we can do it for every patient with diabetes, with any type of diabetes. So let's do it, and I'm sure that it will be successful RT usage in this case.
Any question from the faculty or?
Don't be shy, please.
I think, yeah, maybe later on we will have another questions. Okay. So thank you very much for your lecture, Dr. Regina. And now we will go for the next session. And this one lecture will be for, may I introduce Dr. Nariman Rashid. She's a consultant nutrition and the medical nutritionist in Dr. Nariman Medical Center. She worked in many hospitals in Bahrain, and she has the experience for more than 20 years in this field. She will talk today about the therapeutic effect of intermittent fasting, and looking for the controversy about this method of treatment, and what is the therapeutic benefit and for intermittent fasting. Dr. Nariman, floor for you. Dr. Nariman. We cannot hear you, Dr. Nariman. Hello?
I am trying to share my lecture, but I'm not able to do that. I'm sorry for the delay.
We can see.
Yes, we can see you now.
We can see the lecture.
You can see the lecture?
Sorry.
Okay, now?
Yes, now it's clear.
Okay.
Doctor, but just make a slideshow, please, for your lecture. Just start the slideshow.
Sure, sure. Okay.
Yes, Doctor, thank you.
Okay. Good morning, everybody. My lecture will be the therapeutic effect of intermittent fasting in obesity treatment. The objectives is to understand why simple calorie restriction diet is not working in the long term, Also to introduce the concept of therapeutic fasting and introduce the concept of autophagy as one of the benefits of fasting, understand some myths and misunderstanding of the fasting process.
Dr. Nariman, sorry, but there is no sound from your side.
Yeah, I'm having some difficulty here trying to go back to my first. Okay, so there is only here something perfect. So as an introduction, I would like to say fasting basically is abstinence, food or drink or both for health, religious or ethical purpose. Fasting can be traced back to the 5th century BC when Greek physician Hippocrates recommended fasting for patients who exhibited certain symptoms of. Fasting begins to appear in the medical literature early in 1900s. In 1950, an article in the Journal of Biological Chemistry described fasting as perfectly safe, harmless, and effective method for reducing the weight of those suffering from obesity. The scientific study of the health benefits of fasting seriously began in the mid-1930s when Cliff and his colleagues published a paper showing that restricting the calories fed to rats in a laboratory without producing malnutrition prolonged their lifespan by 20 to 50%, also had lower rates of cancer. In 1945, intermittent fasting enters the literature when University of Chicago scientists reported that alternate day feeding extended the lifespan of rats as much as daily calorie restriction in McKay's earlier experiments. So what is intermittent fasting? Intermittent fasting can be defined as a diet regimen that cycles between brief periods of fasting with either no food or significant calorie reduction and periods of regular uninterrupted eating. Also can be considered as an occasional starvation done in a strategic manner. The most widely studied intermittent fasting regimens are alternate fasting, defined as a continuous sequence of a fast day, 100% energy restriction, and a feed day, no food restriction. The other one, a whole day fasting, which goes to 1 to 2 days per week of complete fasting or meal that provides only 25% of the daily calorie required, with no food restriction on the other days. And the last one would be the time-restricted feeding, the most popular one, a meal plan each day with a designated time frame for fasting. And one meal plan, which means one meal every 24 hours. In general, lifestyle modification is the first line of therapy in obesity treatment, which includes reduced calories, increased physical activity, combined with behavior modification. The most famous theory on calorie restriction diet was eat less, move more. We summarize as reduced 100 calories a day by reducing calorie and increasing exercise. This reduced fat equals to 3,500 calories a week, and this is equal to 1 pound of weight loss per week. But since the implementation of this method, countless studies prove that most people who lose weight with calorie restriction are eventually regaining it back. Some of the studies that shows what I'm saying, that people lose weight, but eventually they regain it. This is a randomized clinical trial, today's study, published in New England Journal of Medicine. The study compared metformin monotherapy with two alternative approaches, one combining metformin with a second pharmacologic agent, and metformin with intensive lifestyle modification, calorie restriction, and exercise. As we see here, metformin with the other combination of anti-diabetic medicine did cause a bit of weight gain. But the combination of metformin with lifestyle, as the patient lost the end, lifestyle modification didn't really work on the long, and people, they went all the way back to the baseline. Another study, randomized controlled clinical intensive lifestyle and metformin treatment versus standard care in over 3,000 subjects at high risk for diabetes. During the first 6 months, lifestyle helped the group to lose a good amount of weight, about 6 to 7 kg. By the end of 4 or 5 years, weight goes all the way back almost to the baseline. The Women Health Initiative Dietary Modification Trial, huge randomized controlled trial for over 50,000 women. The study examined the relationships between weight changes and changes in dietary components over 7 years. These women cut 360 calories a day, increased their exercise by 10%, and the result at the end of 7 years, there was hardly any difference. No difference in weight. UK General Practice Database 2004-2015, 9-year electronic health records. Objective of the study was to examine and estimate the probability of an obese person attaining body weight or 5% weight reduction. The result was probability of achieving normal weight in obese subjects was 0.8%, in morbid obese subjects was 0.1%. 80% of the subjects lost 10% of their weight, they gain it within a year. So as a conclusion, a diet that controls calorie intake has a failure rate of 99.5% for obese patients. So what is the impact of calorie reduction diet on metabolism? Calorie reduction diet leads to a hormonal adaptation, which appears 2 main problems: slowing metabolism, number 1, and increasing hunger. This eventually leads to adaptation to weight loss and ends up with weight gain. How does this happen? Studies shows that 1, reduced energy expenditure. Biometric study of basal metabolism in men, very old study, 1917, 12-year men put on semi-starvation diet between 14 to 2100 calories a day, which was about 30% reduction of their daily calorie requirement. Subjects lost weight, but they had 30% reduction in metabolic rate, complained of feeling very cold and hungry, decreased in blood pressure, inability to concentrate, weakness during physical activity. Again, when they stop dieting or reducing calories, they start to regain weight immediately. Minnesota starvation experiment. The primary objective of this famous experiment detail physical and physiological effects of prolonged semi-starvation on healthy men. Also, their subsequent effectiveness of dietary rehabilitation from this condition. It wasn't really a starvation diet. 40% reduction of their daily calorie requirements. This study went through 4 phases: baseline control phase, 12 weeks, semi-starvation period, 4 weeks, restricted period, 12 weeks, and unrestricted rehabilitation period, 8 weeks. Study result was body mass index, resting metabolic rate declined in 40%, heart volume dropped 40%, and body temperature also dropped. So 40% calorie reduction caused 40% reduction. Great. This is another interesting study. In this study, changes in energy expenditure resulting from alternate body weight. In this study, they first made the subjects gain about 10% of their initial weight by giving them a special high-calorie milkshake. After, they went back to their initial weight, and they went as a third stage to 10% weight loss. At all points, they measured their basal metabolic rate. With 10% body weight gain, as we see here, there's almost 500 calorie increase in basal metabolism. When they lost 10%, a drop 300 calorie of their basal metabolism. So another study, change in during over and under feeding. As we see here, metabolic response to overfeeding, increase in basal metabolic rate and total energy expenditure, and metabolic response to underfeeding, decrease in basal metabolic rate and total energy expenditure. This study was published in American Journal of Clinical Nutrition. We come to the second problem that appears with the calorie restriction diet, which is increased hunger. Long-term persistence of hormonal adaptation to weight loss. In this study, they enrolled 50 overweight or obese patients in 10-week weight loss program, and then they followed their weight for 62 weeks. Calorie restriction results in acute compensatory changes, including profound reduction in energy expenditure, leptin and cholecystokinin, plus increase in ghrelin and appetite. All these changes promote weight regain. 1 year after initial weight reduction, they followed the subjects, and level of circulating mediators that encourage weight gain did not revert to the level recorded before weight loss. So calorie restriction versus fasting, calorie restriction happens is insulin level preserved. This decreased metabolism leads to weight plateau and weight regain. How does fasting solve this problem? There's hormonal changes happen during fasting is completely different than simple calorie restriction. In fasting, insulin counter-regulatory hormones raises, keeping metabolism high, maintaining lean mass. Body switches, storing fat to burning fat. The effect of fasting on metabolic rate. How does the study show? Study published in American Journal of Clinical Nutrition. The subjects of this study was on test the short-term starvation metabolic rate. 11 subjects been on 4 days fasting period. As we see, at the end, 4 days, weight steadily went down. Resting energy expenditure increased, which is very interesting, 12%. And VO2 measurement, which is exercise capacity, remains unchanged. 22-day alternate daily fasting, another clinical trial published in American Journal of Clinical Nutrition. The objective of this trial was to evaluate the effect of alternate day fasting in non-obese subjects on body weight, body composition, and energy metabolism, resting metabolic rate. As a result, we can see resting metabolic rate baseline after a fed day 22 and after fast day 21 and 22, there were no significantly any difference. A randomized pilot study comparing 0-calorie alternate day fasting to daily calorie restriction in adults with obesity for 8 weeks. As we see, alternate day fasting produced similar change in weight, but composition, body composition lipids at the 8 weeks did not appear to increase risk of weight regain 24 weeks after completing the intervention. So we can see weight loss is almost similar, 17.6 to 18. But if we look at the basal metabolism, then calorie restriction dropped 111.6, and the alternate day fasting, it's only 16. How is the effect of fasting on hunger? In this pilot study, blood samples were taken every 20 minutes during 24 hours fasting period, and total ghrelin level were measured. In multiple day fasting, ghrelin spikes maintaining a meal-related pattern, as we see here. But over the ensuing days, ghrelin goes lower with a linear regression, demonstrating a downward slope for each subject, which was statistically different. As we see, ghrelin does not build up, but gradually goes down. Also, there is a changes in craving during low calorie and very low calorie diet. As we see, craving in low calorie diet, it's slightly different, but when it comes to very low calorie, which is almost fasting, craving disappears. The same thing, craving and here also, same thing. Randomized pilot study comparing 0-calorie alternate day fasting to daily calorie restriction in adults with obesity. As we see, the reduction in calorie restriction is 71.4, and in alternate day fasting, it's only 16. So conclusion, alternate day fasting is safe and tolerable approach to weight loss, and alternate day fasting produced similar change in weight, but body composition, lipids, and insulin index at 8 weeks, and did not appear to increase risk for weight regain 24 weeks after the intervention. One of the myths regarding intermittent fasting is the fear of losing muscles. The same study, randomized controlled trial, comparing 0-calorie day fasting to daily calorie restriction in adults with obesity. As we see, the lean mass with calorie restriction is up to 1.8% versus 0.3% restriction, which means truncal fat is almost 6 times better with alternate daily fasting. The same thing with the lean fat-free mass, which means it's up to 2.2%. This is another study showing the same thing, that fasting does not cause muscle mass at all. I can hear a lot of background noise. I don't know if everybody does with me.
خلاص دكتورة muted.
Okay. I would like also talk about fasting and autophagy as if one of the fascinating benefits of fasting. Basically, autophagy is the process by which cells degrade and recycle their dysfunctional components, provide energy, and to rebuild new components in a way regenerating itself. Fasting, as one of the major activators of autophagy, gained extra interest for more studies and researches after the discoveries of the autophagy mechanism by Japanese scientist Yoshinori Oshimo in 2016, who was also awarded for Nobel Prize in Medicine for his discovery. Autophagy can be induced naturally by fasting as a result of decreased insulin, increased glucagon, and stimulated growth hormone. One of the key regulators of autophagy is the kinase called mammalian target of rapamycin mTOR protein synthesis pathway. Nutrient deprivation, like fasting, suppress mTOR and activate autophagy, whereas eating, another way, glucose or insulin activates mTOR and suppresses autophagy. Studies have linked mTOR to several human diseases, including cancer, diabetes, obesity, cardiovascular disease, autoimmune disease, and neurological disorder. Recent data have also revealed that mTOR is involved in the regulation of lifespan and in age-related disease. Autophagy as one of the fasting benefits, although initially characterized as a basic degradation pathway induced to protect against starvation, today it is clear that autophagy also plays a major role in the homeostasis of non-starved cells and protection against many diseases. So if we compare,
5 minutes to finish.
Yes, almost done. So if we can compare calorie restriction to fasting, we can see hunger increase, metabolism decrease, and weight regained in calorie restriction, whereas in fasting, hunger decreased, metabolism stays stable, and weight loss maintained. As a conclusion, obesity is not a simple calorie imbalance. It is more a manifestation of hormone imbalance. Hormones affect appetite and the way body stores and utilizes energy. Calorie restriction diets ignore the biological principle of homeostasis, the body's ability to adapt to changing environments. Body adapts to calorie restriction and frequent eating by slowing metabolism and increasing hunger. Therefore, it only works in the short term before metabolism falls in response. The beneficial hormonal adaptation that happens during fasting are completely different than simple calorie restriction. During fasting, insulin level drops and counter-regulatory hormones are elevated, keeping metabolism high, hunger controlled, and lean mass maintained. Fasting produces hormonal changes that are productive to weight loss, while calorie restriction does not lead to the hormonal changes, which allows the body to enter the mode of fat burning. In recent years, researchers are focusing on intermittent fasting as a promising and safe alternative to calorie restriction diet for obesity treatment. And thank you very much.
Thank you, Dr. Nariman, for your nice lecture. There is a question here from Dr. Qusay asking, do you advise for morbidity surgery for those who have recurrent increase in their weight, or should they continue on their own regime if there is a recurrent increase in their weight? I think pediatric surgery.
I would just strongly recommend that. I did practice it in my clinic, and I get wonderful results. It really helps to control appetite and it helps their metabolic rate so they don't feel tired and lack of energy. And they express that they don't have that high level of hunger and willing to eat. Yes, I do definitely recommend.
There is a comment from, sorry, Dr. I have one comment. Is it the way to do this intermittent fasting?
Yes.
Is it the timing is important before or after like surgery? Because you know that this can do as a purpose of or part of the physiological treatment is the acidosis, which can suppress appetite. So basically, what your advice for a patient on intermittent fasting or sometimes on keto diet before a surgery, whether elective or let's say bariatric surgery? Do you have any suggestion how many days to stop this intermittent fasting?
Well, timing is very, very important when it comes to intermittent fasting. And usually the studies suggest 11 to 6 or 11 to 5. That is 11 o'clock in the morning to have the first meal, 5 o'clock to have the second or the last meal, which means that to limit the eating or feasting period within 6 hours. In between 2 meals, there's also allowed for a snack. In 6 meals, in 6 hours, if the person eats 2 regular meals, of course, with a decent reduction of calorie, he does lose weight. There is no side effect whatsoever, as far as I know, through my experience. This is what timing is very important in fasting. We already fast at night. From the moment we go to sleep until we wake up, we're not eating. But daytime, we have to limit the timing of eating, feeding, and feasting to allow the body to come out of the anabolic stage and go to the catabolic or fat burning stage, which helps in the long run in weight reduction. I don't know if
There is another comment from Brett Garrett, and thanking you for the lecture and looking for the evidence. Why intermittent fasting not promoted more widely for weight loss nowadays?
There's a lot of ideas about this. One of them, they said it is a more not profitable advice, because people, if they lose weight and their chronic disease get under control, some people will not benefit from it. Otherwise, there's a lot of studies, a lot of scientific studies promoting and advising this type of dieting. One of the fascinating side effects of intermittent fasting is the longevity, the lifespan in people who does this on a systemic way. They can see the difference in their biological aging. It's totally amazing. So I think it's the matter of who is making money and who's not from this process.
Yeah, there is Professor Barbara. She has questions and comment. Do you advise intermittent fasting over a low-calorie diet with your patients? And the second question, in your own experience, do patients who undergo an intermittent fast manage to keep their weight off compared to a more traditional low-calorie diet?
The first question, yes, I do recommend intermittent fasting to a lot of my patients, especially if the patient is a chronic dieter, tried for years losing weight and regaining, and he comes desperate, he wants a way to lose his weight for good. Intermittent fasting is one of the approaches that I do with these patients, and it really works. The second question was, the second part of the question was, I'm sorry.
Yeah.
What was it?
So the suggestion is the first of the question is in the low calorie diet. So patient on low calorie diet, he can do the intermittent fasting.
No, that is not a low calorie diet and intermittent fasting together. It will be very harsh, very hard.
Yeah.
And intermittent fasting, we almost go for like 15 to 20% calorie reduction. But once we limit the eating period to 6 hours, 4 hours, it really reflects on weight. But not severe calorie reduction in intermittent fasting.
In your experience, do patients who undergo an intermittent fast manage to keep their weight off compared to a more traditional low-calorie diet in comparison? Like, of course, you don't have a study, but in your clinic, but at least in your experience.
Yeah, in my experience, I have a lot of patients who's been chronic dieter, lose and regain for years. Once they start intermittent fasting, they do lose maybe a little slower than the chronic crash diets, but they're very able to maintain it. Of course, during this intermittent fasting, I apply also behavioral modification, teach the patient what to eat, how to eat, what to drink. These changes together with intermittent fasting augment the process and helps the patient to lose and to maintain. Yes.
Thank you, Dr. Nariman. I think there is a question from Dr. Debish Betel. If patients do not lose weight after a 16-hour fast, now how feasible is it for patients to fast for longer, over 12 hours, for weight loss and maintenance of weight loss?
Okay, usually if I start intermittent fasting with my patients, I start with 8 hours. If he is a big eater, he got a big appetite, and it's difficult for him to reduce his eating hours. If he eats 12 hours all day from the moment he wakes up until he sleeps, so I reduce that to 8 hours at the first stage. After that, I go for 6 hours and eventually to 4 hours. If he's still not losing weight, I would try with him OMAD, 1 meal a day, and that works with many patients. 1 meal, which is balanced, gives him almost 75–80% of his daily calorie requirements, but 1 meal. Of course, before 5–6 o'clock in the evening. At that time, patients, they do lose weight.
Thank you very much, Dr. Nariman. It is my pleasure now to introduce Dr. Adel. Professor Adel is a consultant pulmonologist in King Abdullah Hospital. He has PhD from Tanta University. In reality, Professor Adel, he has really a lot of interest and research published about the pulmonary disease, including the hypoventilation syndrome. And today he will give us his talk regarding the topic, which is related to the obesity. So, Professor Adel, the floor for you, please.
Good morning, everybody. Thank you, Dr. Asad, for the introduction, and thanks for Dr. Muhammad Salman and Dr. Iman for the good organization of the conference, and congratulations for this great conference. Of course, I am a pulmonologist, and I'm very happy to be invited in this endocrinology event, and I hope my lecture will be interesting for all of you. I'll speak today about obesity hypoventilation syndrome. And the outline of my lecture is about definition, epidemiology, pathophysiology, clinical picture, diagnosis, differential diagnosis, and treatment. Of course, you all know what is obesity. Obesity is excess body fat, which leads to increased weight. It may be central or android obesity, in which fat is more in the upper part of the body or more in the, with more respiratory complication. The other type is the peripheral or gynecoid obesity, in which fat is more predominant in the buttocks and shoulders. And of course, you all know the difference between these types and the grading of obesity according to the body mass index and according to many other classifications known in the literature. So what is obesity hypoventilation syndrome or Bequickian syndrome? Obesity hypoventilation syndrome was originally described like 66 years ago. It was first described in 1955 in subjects with obesity, chronic daytime hypercapnia, hypoxemia, polycythemia, hypersomnolence, and right ventricular failure. Then the second year, in 1956, by a doctor, his name was Burwell. He's a very famous internist. He described this case again, and he named it Bequickian syndrome. And the name comes from a very famous novel of Charles Dickens, The Bosmos Paper of Bequia Club. One of the characters of this novel was having the similar criteria of obesity hypoventilation or Bequickian syndrome. Both describe the case and the character in the novel were obese with excessive sleepiness. Further, Burwell's patients had additional hypoventilation during wakefulness with hypoxemia-induced erythrocytosis, pulmonary hypertension, and cor pulmonale. And he published this in 1956, as I said, 66 years ago. under the name of Bequickian syndrome. And since then, it has this name. Of course, this is the novel and some of the characters in the novel. Usually, patients with obesity hypoventilation syndrome have concomitant obstructive sleep apnea. Some of them have no significant apnea or hypopnea events, but they have what is called sleep hypoventilation, in which there is a period of hypoventilation. During the REM sleep, the stage of sleep in which there is rapid eye movement, the deep stage of sleep. This is called the sleep hypoventilation syndrome. Regarding the epidemiology, about 31% of obese persons having body mass index more than 35 kilogram per square meter have hypoventilation. Hypoventilation means elevated carbon dioxide in the arterial blood, which is unexplained by other disorder. This ratio can reach up to 50% if the body mass index is 50 or more. There is no sex difference for obese hypoventilation syndrome, so males and females are equally affected. There are 4 criteria how to diagnose obese hypoventilation syndrome. Patient must have these 4 criteria. Number 1, body mass index should be at least 30. Number 2, there should be an evidence of hypoventilation. Hypoventilation means increase the carbon dioxide in the arterial blood more than 45 millimeter mercury all the time. So usually we will measure it on during the daytime by taking arterial blood gas to confirm the diagnosis. Number 3, associated sleep breathing disorder, like obstructive sleep apnea or even sleep hypoventilation or even both. Number 4, which is very important, we have to rule out or exclude other causes of chronic hypoventilation. For example, COPD and neuromuscular disorders, and they will explain what are the different causes. So again, chronic alveolar hypoventilation means a sustained elevation of arterial carbon dioxide tension more than 45 millimeter mercury. These are the list of the causes of chronic hypoventilation. We have to exclude all of these when we are dealing with a case of hypoventilation. So before saying it is obesity hypoventilation syndrome, you have to exclude COPD, you have to exclude other obstructive sleep apnea, other airway diseases, other myopathies, other neuropathies, other neuromuscular disorder, and this big list should be excluded. Regarding the clinical picture and diagnosis, patients with obesity hypoventilation syndrome may present with unexplained hypoxemia or even with a broad spectrum of symptoms ranging from hypersomnolence, dyspnea, up to the degree of right side heart failure. There should be evidence of a sleep-related breathing disorder with exaggeration of hypercapnia and hypoxemia during the sleep and the frequent arousals. Of course, you will find daytime fatigue, hypersomnolence, mood disorder, morning headache, loud snoring during sleep, nighttime choking and gagging. It's very common. Obesity hypoventilation syndrome is under-recognized and under-treated because sometimes doctors will depend upon measuring the oxygen saturation by pulse oximetry only as a sole tool to diagnose, which is not enough. So as a result, the patient may be inappropriately treated with supplemental oxygen alone, which doesn't reverse hypoventilation. These patients usually have hypoxemia during the night, but the treatment with oxygen only is not enough because it will not reverse the hypoventilation, even it may cause worsening of hypoventilation. If you take the history and the examination and do physical examination, this will help for differential diagnosis. You can see, for example, some mechanical limitation because of underlying lung disease, kyphoscoliosis, myopathies. You can find some neurological disorder indicating some neurological disease as diaphragmatic paralysis, neuropathies, and the neuromuscular disease. You can find some central control abnormalities like patient with severe hypothyroidism, some CNS disease, suggesting a diagnosis other than obesity hypoventilation syndrome. Conditions that aggravate chronic hypoventilation should be identified and treated. Of course, patient if using drugs like sedatives, hypnotics, taking alcohol, using narcotics, all these items should be identified and corrected before starting management. arterial blood gas analysis is very important. It is indicated for patients with morbid obesity with unexplained hypoxemia or having signs of core pulmonale or right side heart failure. The findings are daytime hypercapnia. As we said before, it should be above 45 millimeter mercury, plus or minus hypoxemia, and also there is compensated respiratory acidosis. Some laboratory testing can be done, like CBC. You can find erythrocytosis because of the chronic hypoxemia, serum electrolytes, including the phosphorus, creatinine phosphokinase for some respiratory muscle problem, thyroid function, and many other laboratory investigations. Pulmonary function testing to rule out other specific causes of hypoventilation, because we said before, some pulmonary disease can cause hypoventilation and should be excluded before saying the patient having obesity hypoventilation syndrome. So we will do spirometry, we'll do lung volumes, bronchodilator response test, we'll do maximum inspiratory and expiratory pressure, and also supine vital capacity if the diaphragmatic paralysis is suspected. Patient should be referred for nighttime polysomnography or sleep study. Sleep study is very important. We have to identify the underlying sleep disorder. If the patient has sleep apnea or sleep hypoventilation or whatever the disorder he has, because we will determine according to that what is the proper device that will fit him. He will need CPAP, which is a continuous positive airway pressure, or BiPAP, which is a bi-level device, or even he may need a more advanced non-invasive ventilator. We have like 20% of patients with obstructive sleep apnea have obesity hypoventilation syndrome. So one in each 5 patients with sleep apnea has obesity hypoventilation syndrome. So it is recommended to measure the daytime ABG in obese patients with obstructive sleep apnea, especially if polysomnography show periods of non-apneic oxygen saturation. Usually you find the oxygen drop during the apnea time, but if there is low oxygen saturation during the period there is in which there is no apnea, you have to check for obesity hypoventilation syndrome. Pathophysiology or underlying mechanisms that cause obesity hypoventilation syndrome are not clearly defined, but a lot of theories has been put. So the most common form, number 1 is the impaired respiratory mechanics, number 2 abnormal central ventilatory control, possible sleep disordered breathing, because the sleep disordered breathing by itself can cause affection on the respiratory drive, and some neurohormonal abnormalities. We'll start with the impairment of the respiratory mechanics. Like there is significant impairment in the respiratory system mechanics is evident in individuals with hypoventilation syndrome. Patients with more upper body fat distribution tend to have more severe derangement in lung volume. So with obesity and excess fat in the body, this leads to reduction in the diaphragmatic excursion. Diaphragmatic excursion means the up and down movement. So there is limitation of the diaphragmatic movement, plus there is chest wall compliance reduction. Both these together will lead to reduction in lung volume, especially the total lung capacity, functional forced vital capacity, functional residual capacity, and residual volume. The reduced lung volumes plus the reduction in chest wall compliance will lead to impairment of the respiratory muscle strength, and this will lead to a reduction of the exercise capacity. Also, the reduction of the chest wall compliance plus the respiratory strength weakness lead to increase the work of breathing, which will lead to shortness of breath or dyspnea in this patient. So this is the respiratory mechanic disturbance that can lead to obesity hypoventilation syndrome. We have also what is called the maximum voluntary ventilation, or MVV, which is a measure of ventilatory endurance. It is also reduced, and you can measure it during doing the lung function test. The second mechanism is abnormal ventilatory control, because some patients with obesity hypoventilation syndrome, if you ask them to do hyperventilation, voluntary hyperventilation, he will do, and if you measure the blood gas at that time, you will find the CO2 return back to normal. So not only the mechanical factor is the cause, we have to search for another ventilatory control, the respiratory center itself. So abnormalities in both hypercapnic and hypoxemic ventilatory response are found in obstructive obstructive hypoventilation syndrome patients, including abnormal ventilatory control. The respiratory center is blunt. It is not responding well to the lack of oxygen or increase in the carbon dioxide. The best test we are doing to assess that is called the response to the EMG, diaphragmatic EMG, in response to elevated carbon dioxide, which is the delta EMG over delta BCO2 test, which is a direct measure of respiratory central control. Patients with simple obesity usually have augmented response, but patients with obesity hypoventilation syndrome, this response will be reduced to be similar to the non-obese patient. This means that the patient, the normal obese patient without obesity hypoventilation syndrome, has an increased central ventilatory drive. His response to the respiratory center response is very well, so that he will not have hypercapnia. But the patient with obesity hypoventilation syndrome, this compensatory mechanism is impaired, so that he will have a poor respiratory drive and the poor response in front of the high carbon dioxide in the blood, so obesity hypoventilation syndrome will develop. The third mechanism is the sleep breathing disorder or sleep disordered breathing. There is significant relationship between obstructive sleep apnea and the obesity hypoventilation syndrome, as it is well known as the obstructive sleep apnea can depress the ventilatory response. So it has an effect in the respiratory center by itself. Despite this, it is not clear why only 15 to 20% of patients of obstructive sleep apnea develop hypoventilation. So it needs a lot of research in this point just to explain why some patients are affected and the others are not. We have some examples for that. For example, chronic exposure to hypoxia and sleep fragmentation in normal person lead to a reduction of the central respiratory drive. Another example for healthy subjects in chronic exposure to hypoxemia, or for example, going in a high altitude in a big mountains, they have reduced the hypoxic and hypercapnic ventilatory drive. Also, sleep deprivation in healthy volunteers decrease the hypercapnic ventilatory response. The final mechanism is the hormonal pathway. The most important hormone is leptin. Leptin is usually present in obese patient more than the non-obese patient, and it leads to hyperventilation. It stimulates the respiratory center, leading to hyperventilation to compensate for the impaired mechanic. In patients with obesity hypoventilation syndrome, usually will find like leptin resistance. The leptin level is high, but there is leptin resistance, which is similar to insulin resistance in a way, but it leads to improper effect of the leptin on the respiratory control. Treatment of obesity hypoventilation syndrome starts with weight loss, which is very important. By different means, of course, the endocrinologists are the expert to tell us what are the different ways, either by regimen, either by surgery or whatever. But weight loss markedly improve the obesity hypoventilation syndrome. For example, if the patient loses 10 kilograms, it results in a significant improvement in vital capacity, maximum voluntary ventilation, and a significant reduction in carbon dioxide. Weight loss has also been shown to be significantly increased central ventilatory drive. But it is not only the only treatment. Weight loss seems to be the optimal treatment, but of course it is slow to occur and difficult to achieve. Furthermore, an optimal amount of weight loss has not been studied. A lot of studies also needed in this point. We need to know how much weight loss we want to achieve the good control of obesity hypoventilation syndrome. The most appropriate treatment we describe to patients is the devices, the CPAP and the non-invasive ventilation. CPAP means continuous positive airway pressure. It gives a continuous positive pressure during the respiratory cycle, during inspiration and expiration. The aim of that is to open the airway, especially the upper airway, eliminate apneas and hypopneas, and correct hypoxemia and hypercapnia. And you can connect this device to the patient with several types of masks, either nasal, total face mask, oronasal, and so on. Patients with obstructive sleep apnea, some of them are not responding to CPAP, and they may require non-invasive ventilation. Non-invasive ventilation using the BiPAP machine. BiPAP machine is the same like CPAP, but the pressure delivered during inspiration is higher than the pressure delivered during expiration to give good compliance to the patient. It is more expensive, but the efficacy is very good. Some patients even will not respond to the BiPAP, and they will need a volume-controlled device, which is called non-invasive ventilator. So lack of response to CPAP is multifactorial. In some patients, despite the high CPAP airway patency is not established, these patients may need higher peak inspiratory pressure, which is only can be achieved, as we said, by the volume ventilator. Other patients may have concurrent sleep hypoventilation syndrome, which necessitate non-invasive ventilation. And also some patients, there is intolerance to the device itself. In patients with impending or even impending respiratory failure, such as uncompensated respiratory acidosis or severe hypoxemia or mental status change, immediate hospitalization is indicated because this patient may require invasive ventilation for some time until control. The hormonal therapy with progesterone has been tried, but it is not now approved in all the guidelines because it has many side effects and it is not very effective. My conclusion, not all obese subjects have obesity hypoventilation syndrome. Obese person should be assessed for sleep-related breathing disorder and obesity hypoventilation syndrome. Reducing weight is very crucial, but it is not the only treatment. Non-invasive ventilator device as CPAP and BiPAP are very helpful, and also optimal treatment is essential to avoid respiratory failure. Thank you very much.
Thank you, Professor Bedawi, for really interesting topic. And until we get questions, I have some inquiries. What you can summarize the alarming or signs for your patients to go for investigation in the one who visit your clinic? So any sign can give you a hint for a patient with the hypoventilation syndrome.
Yes, of course. Very good question, because it is very common in the obese person. We have to assess and to do a questionnaire for everybody having a body mass index more than 30, a questionnaire about the sleep status. He has snoring, he has sleep apnea, he has nighttime awakening, he has morning headache. So we have already a questionnaire for that. It's called Epworth Sleepiness Scale or questionnaire. It should be distributed in the all obesity-related clinics, because we have to assess all patients for the presence of sleep apnea. If the patient is having some symptoms of this sleep apnea or the score is above 10 out of 24, we have to refer him for polysomnography, for sleep study, which is very important step. If the patient have obesity plus obstructive sleep apnea, the third step, we have to assess the arterial blood gas during the daytime. And we have to stress upon the carbon dioxide. If the carbon dioxide is more than 45, means the patient now is having all the criteria of obesity hypoventilation syndrome and should be sent for a pulmonologist for further management, because this is very serious condition. It can lead to severe respiratory failure and ICU admission and even death in some cases. If we treat these cases very early, the results are very promising and the patient will have very, very normal life.
Thank you very much. Dear speakers, if you can mute your voice during the lecture because of the noise that comes, especially panelists. Thank you for Professor Bedawi for this lecture.
Thank you, Dr.
Now
Assad.
we will, thank you very much. We will shift for the next session, which will be chaired by Dr. Ghazi Al-Mahrous. Dr. Ghazi is a consultant.
Dr. Assad, we have a break. Dr. Assad, sorry, we have a break now for 15 minutes.
Okay, so there will be
12:30 to
chance
12:45.
for a break. Then we will start with the next session. Thank you very much for audience for being patient and sitting with us all morning session. Thank you, all of you. Good afternoon, ladies and gentlemen. It is my pleasure to start again with the new session and introduce the next speaker, Professor Inas Sheltout. Professor Inas, she is the Professor of Internal Medicine and Diabetes in the and Diabetes Chairman of Internal Medicine Unit, Faculty of Medicine, Cairo University, President of Arabic Association for Study of Diabetes and Metabolism, and the Chairman of Arab Association Study of Diabetes Conference. She's honorary tutor in Cardiff University, England. Professor Sheltout, very active in doing the activities for public, for scientists and clinician. I would like to congratulate her for the continuous activity, and this is the good opportunity to have you with us in our faculty. Professor Sheltout, the floor for you.
Thank you very much, Professor Asad, for the kind introduction, and thank you very much for your invitation to a valuable conference, and congratulations to the board for doing an excellent conference. And let me start with this presentation. I'm going to talk about women and obesity, what lies beneath. And more than 100 years ago, obesity in females was a sign of beauty. But in 2015, the WHO latest report said that we are having more than 2.3 billion adults living with overweight, and at least 650 million adults are obese, and the majority of them are females. And this is the global prevalence of obesity: 650 million people living with obesity, and 2.8 million die each year as a result of obesity, and this is alarming. From 1997 to 2001, obesity rates worldwide are increasing, and this is happening in different regions of the world: Africa, Asia, some parts of Europe, and some parts of North and South America. We are living in an obesogenic environment for females due to urbanization, sedentary lifestyle, private cars, television, and household appliances, less physical activity, high caloric and fat intake, and women are more likely to be overweight and obese due to cultural norms and perception of appropriate female behavior and occupations inside and outside the home. Let me give you an example about lifestyle of Egyptians. We find that Egyptians taking 5 servings of fruits and vegetables per day. In males, the percentage is 21%, in females, 22%. So only 21% of the Egyptian population eat 5 servings of fruits and vegetables per day. For those who are doing the least duration of daily activities, we find 57% of females are doing the least activity during the day, and males, 45% of males are doing very minimal physical activity during the day. So the percentage of overweight and obesity in the Egyptians: for females, 72% are overweight and 39% are obese. 60% of males are overweight and 21% are obese. This is the definition of obesity and statement about obesity, which is recognized as a disease and a health issue by different international organizations. For the World Obesity Federation, The statement is obesity is a chronic relapsing progressive disease process and need immediate action for prevention and control of this global epidemic. For the American Medical Association, obesity and overweight is a chronic medical condition and urgent public health problem. And for the Royal College of Physicians in UK, it's important to the health of the nation that we remove the stigma associated with obesity. It's not a lifestyle choice, but it is a genetic influence and risk factors. For the Canadian Obesity Association, obesity is a progressive chronic disease similar to diabetes or high blood pressure, which is characterized by abnormal or excessive fat accumulation that may impair health. For the European Association for the Study of Diabetes, of the obesity, obesity is a progressive disease impacting severely on individual and society alike. So obesity is a chronic disease and chronic health issue. Let me start with discussion about complications of obesity, especially in females, and the clear and present danger. Obesity can cause cardiovascular disease in the form of coronary artery disease, angina, myocardial infarction, heart failure, arrhythmia, and sudden death, hypertension, and for every 10% increase in weight, this will lead to increased 6 millimeter mercury in the mean blood pressure, and reduction of body weight will lead to decreased blood pressure. Deep venous thrombosis, respiratory complications, and we just had an important lecture, the earlier lecture, about the sleep apnea, the impaired respiratory functions, Pickwickian syndrome, and this is the picture of Mr. Pickwickian in Charles Dickens' novel, and another picture with a patient suffering from sleep apnea. Another group of complications, hepatobiliary complications, fatty liver, hepatitis, NASH, calcular cholecystitis, arthritis, especially of weight-bearing joints, cancers, breast cancer, colonic, prostate, uterine, ovarian, and others, diabetes mellitus. 80% of diabetics are obese, hyperlipidemia, especially hypertriglyceridemia, infertility, abortions, and birth defects in obese women with body mass index more than 30, and increased mortality with body mass index above 30. Life expectancy is decreased when BMI increases, and for those having BMI from 30 to 35, there is reduction of life expectancy of 3 years, and for those with BMI between 40 and 50, there is reduction of life expectancy between 8 to 10 years, and for each 5 kilograms per meter square higher BMI, there's 40% higher mortality rate for ischemic heart disease, strokes, and other vascular disease. This is the relationship between some chronic diseases and obesity in males and females. And for women, obesity is very much associated with the occurrence of diabetes, and followed by cholecystitis, hypertension, and coronary heart disease. This is very important figure comparing those with BMI above 35 compared to those with BMI less than 22. And in females, there is increased incidence, 93 times occurrence of diabetes in those having BMI more than 35 when compared to those having a BMI less than 22. In males, this is also, it was apparent that there is increased incidence, but 42 times in those males with BMI more than 35 when compared to those males with BMI less than 22. Obesity is linked to at least 9 types of cancers in males and females: breast cancer, colonic, uterine, gallbladder, ovarian, prostate, upper GIT, pancreas, and renal cell carcinoma. Another group of complications of obesity, physical complications, a continuous sense of tiredness, breathlessness, varicose veins, headache, edema, cellulitis, sweating, intertigo, stress, incontinence, and social complications. Obese persons may feel isolation, unemployment, family or marital stresses, financial stresses or burden, and depression. Let me now speak about the abdominal obesity and the cardiometabolic risk. And in HOPE study, there was increased risk of cardiovascular events associated with increased waist circumference, and the all-cause deaths was increased. The myocardial infarction was increased, and the cardiovascular deaths was increased in those having increased waist circumference. Abdominal obesity again was associated with increased risk of type 2 diabetes. And in the Paris prospective study, abdominal obesity predicted adverse outcomes such as sudden death, and abdominal diameter was proved to be a better predictor of the risk of sudden death than BMI. There is increased risk of coronary heart disease associated with waist circumference, and waist circumference was independently associated with increased age-adjusted risk of coronary heart disease even after adjusting BMI and cardiovascular risk factors. Females are usually before marriage slim and maybe 10 years after marriage they become obese. The twin of obesity and type 2 diabetes epidemic are on the rise. From 1986 to 2000, the prevalence of BMI 30 was doubled, and BMI more than 40 was quadrupled, and extreme obesity of BMI 50 increased 5-fold, and this is alarming. Increasing prevalence of obesity among children, suggesting that the epidemic will continue and worsen. Again, in morbidly obese population, the average life expectancy is reduced 9 years in females and 12 years in males. Women and obesity, it's more than an issue of size. We need to change the priority physicians give to obese women, and it's more than an issue of size. There is greater health consequences, greater psychological consequences, and specific female issue like fertility issues, polycystic ovary syndrome, pregnancy complications, influence on fetal development, complications related to menopause, and female cancers. Obesity affects women disproportionately, and in an obesogenic environment, women are at greater risk for obesity, and especially severe obesity as compared to men. Female obesity, lifelong medical risk, starting from infancy and early childhood to adolescence, to young adult period, to childbearing period, to older adults, then to geriatric age. From adolescence to adulthood, obese young females may suffer from psychological health consequences and reproductive health issues. Fertility with assisted reproduction, the pregnancy rate is halved in the presence of obesity, whether assisted reproduction or percentage achieving at least one pregnancy in obese females is reduced. And this is the infertility with polycystic ovary syndrome is increased in obese females, and even it's increased without the presence of polycystic ovary syndrome. During pregnancy, during early pregnancy, the medical complications are miscarriage and twinning, and technical complications, different ultrasound due to obesity. During the antenatal care, there may be pregnancy-induced hypertension, preeclampsia, gestational diabetes, and venous thromboembolism. Intrapartum, higher rates of induction of labor, planned and acute cesarean section, assisted delivery, vaginal tears, and technical complications, operative complications, higher rate of cesarean section, infection, bleeding and thrombosis, and anesthesia complications. The postpartum, increased incidence of postpartum hemorrhage, infection, and venous thromboembolism. And fetal complications, macrosomia, congenital abnormalities, fetal distress, perinatal morbidity and mortality is increased, and technical complications in the form of birth injury. Gestational diabetes, overall gestational diabetes occur in 4% of pregnancies, but overweight females have 17% risk of gestational diabetes. So the intergenerational effects of obesity on uterine development, babies may have complications later on in life, maybe obesity, diabetes, type 2 diabetes, hypertension, and metabolic consequences. On aging women, obesity leads to increased risk of obesity-related complications with aging, type 2 diabetes, hypertension, cardiovascular disease, and increased almost all types of cancers, especially uterine, kidney, breast of the postmenopausal type, and cervical cancer. And these are the most common cancers occurring due to obesity, and we can find that uterine cancer is the major problem due to obesity, followed by the cervical cancer and the breast cancer. There is increased risk of cognitive dysfunction and dementia with aging, with negative implication on life expectancy. And this study showed that there is increased incidence of Alzheimer's dementia in females with metabolic syndrome versus those without metabolic syndrome. And this correlation was not seen in obese males. Obesity is an independent risk factor for Alzheimer's disease, and studies showed obesity-associated increased risk of dementia and Alzheimer's disease and temporal lobe brain atrophy in CT scan in obese females. So it is a life cycle of consequences and complications starting from infancy and early adulthood to maternal age, to older women, and even effects on the offsprings and effects on the males. It's not impossible to get rid of obesity. This is a famous Egyptian celebrity before and after weight loss, and another nice-looking Arabic celebrity before and after weight loss. And thank you very much.
Thank you, Professor, for your nice presentation for interesting topic. I can see that you comment nicely about the obesity in women. Do you think that the women character can affect the patient's interest to lose weight rather than male side?
I think now females are aware of the obesity problem more than in older generations, and they need to be slim. They like to be slim, and this is the concept now, even for young adult females. But like I said, it's an obesogenic environment for females. Especially those who are not working, because staying at home most of the time, taking a high calorie diet with junk food and with soft drink and sweets and desserts, this is challenging that females not working, how to lose calories. So it's preferred that they engage in daily physical activity sessions, even at home. They can do the sessions even at home in front of YouTube or something, because we can't leave these females eat like 2,000 calories per day. How they are going to lose these calories while sitting at home? So they, any female who is not working should be engaged in an exercise program.
Thank you very much, Professor, for your nice lecture. And now it is my pleasure to introduce.
Hi, if you don't mind, I just want to ask Dr. Inas,
yes.
Professor Inas, that's from today's morning sessions, we have been talking about women and obesity and how to do intermittent fasting, and really a lot of focusing the light on women. And I feel that they've obese women, if just to say that they feel, I think, pressured with their increased weight, and a lot of media influencers and the new shape now of healthy women, or how to look fabulous in skinny jeans and all that. I feel, isn't it a lot of pressure on ordinary women who don't know what to do? I feel they need support. I know it should come from within. They should start, but I feel some of them find it difficult to start on their own, or they need guidance. Maybe they will need a support group or encouragement from somebody in the family and so on. What do you think, Professor Inas?
Your comment is very important, Professor Iman, and it is a family decision to have a lifestyle. All the family should be eating healthy food and trying to exercise if they are not doing excess effort during work. So they should be engaged in exercise sessions. It's a family lifestyle, and I usually say so to my patients, especially if one of the family is having disease linked to obesity, like diabetes or hypertension. So the whole family should adopt a healthy lifestyle, healthy eating, and healthy lifestyle in the form of exercise. And usually the mother in the family is the mainstay. She is the most important person who can influence the family through cooking and through engaging the children to healthy lifestyle and exercise. So it's not impossible, but there should be a will and education to the people that diabetes and obesity and hypertension, these are chronic complications that sometimes can be preventable by lifestyle. So we should let them aware that obesity is a chronic disease. Like all international organizations said, obesity is a chronic disease. It's not just like an image or so.
Dr. Madiha, you have a question?
Yeah, I would like to add something. Hello, Dr. Inas. I heard your lecture was very amazing. This is a very important topic, and I would like to throw some light that it is easier, I think, much easier to motivate young women or who are married or who are having kids than elderly females, because to them they think that their whole life is surrounded by the household chores and doing everything around the house, and they think they're doing enough activities. It is very hard for them, especially the elderlies, to tell them go to the park, have a walk, reduce your weight. It is very hard. How do you help or how do you suggest us to motivate them? Because to the females we can say, okay, go with your kids, have some activities, play, but to elderly they don't have any motivation to go.
You are talking about very important topic, Professor Madiha. We usually urge younger females to lose weight before becoming older females, or sometimes their movement is not easy, or sometimes bedridden, because they are not going to lose weight easily if they are older, having heart disease or joint disease. So it's better to work for prevention of obesity in males and in females also. Not to leave patients until they are having chronic diseases that limit their movement. So it's better to be preventive. But for older individuals, it's not too late to adopt a lifestyle, a healthy
I have, I can just ask Dr. Afaf if she can give her a comment about ladies coming to the clinic with the obesity. Dr. Afaf.
Thank you, Dr. Asad. Yes, we have this problem. And as Dr. Inas mentioned earlier, it is very, very difficult for women once they reach menopause and above to lose any weight, either because of disability of walking or doing exercise, or even their metabolism and their lifestyle becomes more stable, and they cannot really lose weight. And I think I am one of them. I mean, I'm trying, but because I did not do good work before reaching that, it is becoming extremely difficult for me to lose weight nowadays. I fully agree with that, but what we can do? I mean,
you have my number, Dr. Afaf.
Sorry? No. I will not go for that. Sorry, Dr. Amr. I will never think of that, and I will never go for that. I'm sorry, but this is my own opinion. I try to do whatever is possible, not to increase, I will not say, but not going through any of these operations. No. Thank you very much.
Dr. Dalal,
thank you
any
very much for your talk. It was very interesting, and I thank you and thank Dr. Asad and all those present with us for making IMDO 5 very successful.
Thank you, Dr.
Thank you, Dr. Asad. I just wanted to send a very warm welcome to Professor Inas. It's so nice to see you. Brilliant talk as usual. Very nice points to discuss.
Thank you very much.
Okay, Dr. Amr.
Yeah, sure.
Dr. Amr,
thank you very much for this
comment.
wonderful lecture, Professor Inas. I just have one question. I mean, over the literature and since in your presentation as well, it was highlighted that there are discrepancies between males and females when it comes to obesity, especially when you look at longevity. So mortality rates for females are different from their counterparts, despite being of the same BMI. Moreover, in the surgical literature, we've noticed that even the weight loss itself, if we look at males versus females of the same BMIs, the weight loss is not the same. And also the failure, weight regain or failure of operations. Do we have any insight to why this is? I mean, is it hormonal related, or is it the nature of the disease, or is it the nature of let's say the movements or eating habits of females? Do you have any insight regarding that?
For lowering the lifespan difference between females and males?
Yes, especially when they go higher, and why when males and females lose weight by using the same method, for example, bariatric surgery, males tend to lose more weight than females, for example.
For males to lose more weight, I think it's a working condition and lifestyle of males, because more males are working compared to females. Males spend too much hours outside their homes than females. Females usually stay at home for many hours of the day, and sometimes for a whole week the female doesn't leave the house except for working females. So the energy expenditure in males is more than the energy expenditure in females. For the life expectancy, I think it's related to comorbidities of obesity on males. I think more cardiovascular complications maybe. This is expected, that they have more cardiovascular complications, so the lifespan is reduced more in obese males than in obese females.
Thank you very much.
Thank you, Professor Shelto. Thank you, Dr. Amr. I think this is the time to shift for nice presentation from Dr. Spadrion Truz. Dr. Truz, our friend, he's a consultant physician in internal medicine, and he is graduated honors degree in medicine from La Sapienza University of Rome, Italy. Is in the Faculty of Medicine and Surgery Internal Medicine Specialization Board in University of Athens, Greece, and he's earlier managing director for Babco, currently working in UK. Dr. Truz, he will talk today about the digital platform and e-clinic. And we used to have different and really specular and unique presentation from Dr. Truz. Dr. Truz, floor for you. I think you record the lecture, or Dr. Truz?
No.
Yeah, Dr. Truz, yes.
You can see me?
Yes.
Yes, we can see you.
Yes. Just you can
Assalamu alaikum. Assalamu alaikum to everybody.
Alaikum assalam.
Yes.
Your Excellency, Dr. Wahab, Dr. Assad, the organizing committee, Educational Plus, Dr. Amin, and special regards to Dr. Iman and Ahmed for all this collaboration during this time. The Nahra, Dr. Mariam, the Bahrain Diabetes Society, Dr. Mariam, all the sponsors, dear colleagues. It's a great pleasure to be with you. It's very honor for me to be together with all my colleagues from Bahrain, and it's 1 year from when I had COVID last year and I couldn't attend, and this give me a great pleasure to present this. It's a special topic, and we all need to know about what is changing in our life. I discussed earlier one day with Dr. Assad about COVID, frontline workers, and all the medical teams and the working in the hospitals in the health sector. And I really want to congratulate them from this panel, because we have to honor them for their great work. To be honest, COVID affected me quite a lot. I have a long COVID syndrome, and it's been quite difficult. And we discuss it, probably we need to invest on post-COVID syndrome clinics. They are already started in UK, and I believe is the time to support patients with long COVID. I heard the discussion earlier about the obesity, and obesity, unfortunately, give a lot of effort to COVID to make obese and diabetes to be the first patients to probably even lose their life. I would like to start my presentation. Is a little bit of a difficult topic about digital platforms in medicine. Like Dr. Assad said, I spent 11 years of my good life in Bahrain, and I missed Bahrain very much. Of course, working now in frontline in the NHS as a consultant physician in internal medicine is very challenging, especially during the pandemic, and have the experience with how our lives change and how the digital world affecting us. At least we can be online and communicate with each other, which is very important. And having all these e-conferences and e-learning is very important for all our colleagues to have the challenge for this time. We need to clarify what digital medicine is. And like the American poet Maya Angelou said, if you don't know where you come from, you don't know where you're going. Is the field concerned with the use of technologies as tools for measurements and intervention in the service of human health?
Sorry, Dr. Truz, you shared your screen, or because
Dr. Assad, we are sharing the slides. We are sharing the slides now.
Yeah.
Okay. Yes, sure.
Dr. Iman will help me with that, because with a workload to prepare everything is very difficult. But I think Dr. Iman will.
She will share. Yes.
I can continue.
Yes, Doctor, proceed. Yes, thank you.
Proceed, Doctor.
On 1897 is the first documented telemedicine happened, a telephone consultation with a physician to diagnose croup. Then we have, during the second half of the 20th century, we have the development of the ultrasound imaging techniques, artificial organs, and the DNA sequencing. With a boom of 80s and 90s, we all know how technologically improve and how the digital medicine is part of our life. Historically, you can go to the next slide, please. Historically, a patient received the test result or piece of evidence every couple of months. Then human readable test results be interpreted by human, and human shared results shared from one human to the other, and more often in person and in an environment with space for context and questions. Now we change. We have flows, data can come in by the minute or milliseconds. Non-human readable results produced from algorithms, and machine share. An algorithm shares a digital results, limited context exists for a human to correct false positives. I need to do the categorization. You can go to the next slide, please. And the digital health industry categorization is digital health, digital medicine, and digital therapeutics. Next, please. With the 7 key areas of opportunity, we have more systematic high-quality care, use clinical information decision, support and knowledge management tools integrated into standardized workflows. Second, more proactive and targeted care, real-time monitoring and powerful analytics to deliver more proactive and targeted care, reducing costs and improving outcomes. Better coordinated care, attack the cost. Everything has to do in these 2 points with cost. And reducing cost is a health minister and everybody who's offering care, they want to reduce the cost, and the digitization reducing cost. Improve access to specialist expertise. This is one of the important things happening in the digital era. Use telehealth to reduce costly referrals, avoid admissions in hospital and unnecessary appointments, and improve the ability of professionals to get things right first time by providing access to specialist expertise. I will share later on with you what's happening. Creating patients' engagement, reduce transaction cost, and rewrite the relationship with patients and carers. Providing tools for patient engagement and self-management that allow more meaningful participation in care. This can help as well obesity. They have now a lot of startups or different things happening with great results. And the digital world gives us data to analyze, and I believe in the next few years we're going to have huge data to analyze between us. Improved resource management brings to bear the tools used in other sectors for improved resource management to plan staff rosters and patient flow, match capacity to demand, and improve scheduling. 7, system improvement and learning. That's what's happening today with IMDO 5, continuity of learning and sharing learning and knowledge between colleagues from different parts of the world is very important and give us the opportunity to be all together, even if we are different places. The next, please. We can define digital health and what happened with digital health during the pandemic. During the pandemic, we had the opportunity to use digital health to help patients probably to stay home, to monitor during lockdowns, to be in touch with them, different system, create better policies, guidelines. It is a little bit anthropophobic, means people sometimes they like it or they don't like it. We face a lot of security problems, cyber attacks, and one of the issues we always have is confidentiality. We need to secure the system. It is very, very important to secure the system. We notice in the digital health needs more expertise. We're lacking of expertise in all the sectors, but currently in the digital health, we need more expertise. We built the e-learning with virtual conferences. IMDO is one example, but of course it was live in the beginning and now continue to be virtual. I hope next year it will be live again, and then we all can meet again and share our experience closer. Something I would like to share with you is how I can see the future in medicine out of our experience, and we need to continue to investing on humans. Without the doctors and without the health carers, you can have the best systems in the world, but if you don't have the human touch, something is missing. And we don't want to, of course, we're going to have the robotic time, and we have robotic surgical interventions, but we need always guided by humans with ethics and respect. The medical schools need to have more digital discipline, and we all be asked by our patients about Dr. Google. Our knowledge needs to be up to date. We need to continue training, continue to be in conferences, continue to have accreditations, continue to search and investing on research. Dr. Google always give to our patients some notifications. Of course, if you say something to one patient, he's going to Google it and come back to you. And we all face that. We need to be up to date and challenge Dr. Google. Without us, Dr. Google is nothing. Creating strategy. One of the my advice to all health providers, they need to have strategic plans. I put a strategy for 2025. I know we all have strategy for 2030 and 2050, but what's happening is very, very challenged and is run quickly. To be honest, the global strategy on digital health is to promote healthy lives and well-being for everyone, everywhere, at all ages. This is all our vision. We all hope everybody, everywhere on this planet have excellent health. And we are challenging everyone to try to invest on themselves, to start with education from the schools, school programs, and that's how we can have better health systems if we take the responsibility, the personal responsibility. I'm going to use the knowledge I have from NHS, and NHS is a great organization, and investing on digital health leadership. This is, I just put it to share it with you. You know, that NHS Digital Academy providing programs for innovative postgraduate diploma and masters in digital health leadership in the world-class training course. And it's very important. Sometimes health providers should have all this knowledge. We all been in touch what we call electronic health records. In our hospital, in our, can I have the next, please? In our hospital, we have, or the Ministry of Health trying to provide electronic card, and it's all the data of the patient, and it's easy to have to move all this data. One of the challenge I always said is to be careful with the confidentiality and the cyber attacks. Need to improve. Of course, I'm not an IT professional, but and this is up to IT experts to resolve it with our guidance, but the confidentiality is very important, and is something I put an emphasis on it. I'm going to share with you some what's happened during this time. A lot of startups, and they use the big data we have, and the big you can see is diabetes and diabetic patients, and how to improve their daily life by using different startups. I just choose some of them. You can improve and follow up their side effects, and you can monitor their blood sugar and connect it with the relative doctor. And especially if you have organized preventive medicine clinics, the doctor who's looking after 100 diabetic patients, 200, 500, he can monitor and be up to date with his patients. And it's all these startups that can help to a better quality of life. I use always this word of investing on better quality of life. Even in obesity, you're going to have chronic problems, and behind obesity, we like it or not, is depression. And we concentrate on the obesity and we don't cure the depression. I'm putting an alert to all our colleagues. They have to concentrate on the resolving the problem behind the obesity, and it's why a patient needs to eat more and why he's choosing to eat junk food and not healthy food. Everything has to do with his back of depression. Great initiatives in startups helping patients and health professionals. This is the life in our century. We're going to see a lot of them coming up. My next slide is nothing to do with commercial. Is just putting what different startups they want to use and how they can help. This is what happened. Can I have the next one, please? The next one. The rise of digital health technologies during the pandemic help us to improve the policies and the data collection. And coronavirus has accelerated the rise of digital health. We have to admit that during the pandemic, the digital health help us to prevent remote monitoring, help everyone to give and provide better care. We monitor patients remote and follow up with them, how they're feeling, and that follow up every day, or the GPs that follow up with them, they didn't need to be hospitalized, and they didn't need to follow, the guidelines and avoid to be in the hospital. Something is booming, and I believe I would like to share it with you. Is a lot of happening with nanotechnology, and this is part of our digital era, and how we're going to see in the next 10 years, 20 years, we're going in our jobs and in our profession, what we want to minimize the mistakes. We don't want to, as much we can, we can provide earlier care and good care, and we can have the best results, especially in cardiology, in immune system, in cancer. The nanotechnology play important role, and we're going to see a huge development, and I hope we can see that something in Bahrain. I'm always happy to be with all our colleagues and share our experience, because I believe Bahrain is one of the best countries in the region, providing excellent health care. We and all of you have excellent standards. I work with most of you together, and the vision of the leaders in the country, again, excellent hospitals in the public and private sector, needs to invest a little bit with the knowledge of the new technology for the years that are coming. We need to, not huge investments, in collaborations, to be in the best. I always believe Bahrain is an excellent place to an excellent care, and the location of Bahrain is always excellent. We have in this, and I have the next ones, please. This is someone what we can see with all his gadgets going around, but I don't want to be like this, all digitalized, because sometimes we say we digitally connected and emotionally disconnected. I like digitalization, but to a certain level, to be able to use the digital information, to use it correctly, and to use it correctly, we need training, we need e-learning, we need what we have in this time to use all these facilities we have for our benefits. But again, it's need an HRA, the ministry, to be in the level to accredit it and continue to have this accreditation. A lot of different companies in the sector provide all this. I believe as well Educational Plus help this sector for continued education, and all these excellent conferences you made all over the year. I would like to share just a couple of pictures with the digital hospitals and how I can see Bahrain Diabetes Society with excellent work of Dr. Mariam, Dr. Dalal, and Professor Dalal, and all the team. They're working together to provide awareness. And we like it or not, awareness is through these gadgets. Everyone has a mobile phone, and we have somehow to arrive to each patient, to each member of our society with this mobile phone, and share that information, give the right information. Always, I believe, we are the responsible to give the right information. Otherwise, they are going to get the wrong information, and for different reasons, they're not going to follow up the advice we are giving. Excellent work from Bahrain Diabetes Society, and I believe is always an opportunity to congratulate them. Of course, the hospitals in Bahrain, they improve in the with artificial intelligence. You can see King Hamad, BDF, private hospitals investing more now in, and I believe with a cancer center, they investing more on robotic surgery and robotic expertise in the future. They're going to share this excellent service in Bahrain. The future is in our hands, and I totally believe Bahrain to become the future digital medical hub. With all your great work, I really want to thank you for giving me this opportunity to be with you today and share some information, because the digital medicine is, we can stay whole, we can have a special conference for digital medicine and challenge everyone how is going to be the future. And I believe the future is in our hands, it's in the hands of all the expertise in Bahrain, and I have full trust in all of you of the great service you're offering. Thank you for having me with you. Thank you, Dr. Assad, and thank everybody.
Thank you, Dr. Trues. It's really interesting topics, and you give a summary about the health system in Bahrain and how to go in the system of the digital e-clinic. We have now questions. Anyone can share the question, type it. They are sending thanks for you from Bahrain, Nisha and Bijoy. I think some people also, they comment about the lecture, and it is very awesome, interesting lecture. So is there any chance to start and develop the, we can say, milestone for e-clinics in NHS, and is there any progress in this section?
Yes, it's a great, they're starting, and like I said before, I take the opportunity about, because we all experience the COVID and the post-COVID time, and with long COVID syndrome, and creating clinics, because you don't need to see patients, you need to support them. This is more management with a multi-panel team, physiotherapists, psychotherapists, and to treat all this long-term syndrome, you need to have this type of clinics. And NHS have quite few clinics with virtual consultations. But I think they're working on new projects. I use a lot of time NHS as a model because it's one of the oldest health models in the world, and as strategically they are doing very well. But of course, you know, everything has to be cost effective, and the digital world, like I said, give cost effect to a lot of services. But my always alert is to be human guidance. You know, not everything you put it in all the data and everything is one algorithm and follow algorithms. I think we have to have always the human touch, and the patients need to see a doctor, not only to have a virtual consultation, they need to see a doctor. I'm a little bit old school for some things, but I believe in the personal touch with your patients. Even we use the technology, but I still believe in the personal touch.
Thank you, Dr. Truth. If there is no more question, we will go for the industry symposium for Novo Nordisk lecture.
Excellent.
It is one of the interesting lectures would be the next one. Is there anyone over here?
Dr. Asad, Miss Mary from
Yes.
Novo Nordisk, she's going to introduce Dr. Nasreen Sayed. Please welcome for the
So Mary, floor for you.
Ahead.
And welcome for one of the outstanding, interesting lectures from Dr. Nasreen. Thank you for support and for participation.
Thank you, Dr. Asad, for your invitation and for the outstanding version of IMDO this year. First of all, good afternoon, ladies and gentlemen. On behalf of Novo Nordisk, I'd like to welcome you all to our lecture for this afternoon, entitled Semaglutide, Glycemic Control and Beyond. First of all, I'd like to welcome our renowned speaker, Dr. Nasreen Sayed, who is a consultant endocrinologist and lipidologist at Gulf Diabetes Center. Dr. Nasreen, she's a board member and past president of Gulf Association of Endocrinology and Diabetes. So without any further ado, I'd like to welcome Dr. Nasreen to the stage. And the floor is yours, Dr. Nasreen.
Thank you very much, Mary, for this kind introduction. Good afternoon, everyone. It's a great pleasure to be with you here today. I would like to thank the organizing committee for organizing this outstanding Congress, and I hope you are enjoying it so far. So this part of today's industrial symposium is going to be a very interesting and fascinating class of agents that we use to treat diabetes, the GLP-1 receptor agonist. Particularly today, the focus is going to be on semaglutide and its glycemic control and beyond. So just a quick outline on today's talk is we're going to just shed some light on the burden of cardiovascular disease and type 2 diabetes, followed by a holistic approach for type 2 diabetes management, and then the semaglutide once a week, an innovative option for type 2 treatment. And then finally, a very fascinating part of this talk today is the oral GLP-1 receptor agonist that we have been eagerly waiting for. So we know as clinicians, we are facing major challenge in treating diabetes in clinical practice. And it seems that we're not doing that great job because we still see diabetes remaining as the 9th major cause of death globally. 54% of patients have microvascular complications and 27% macrovascular complication and 25% diabetic kidney disease. And if we look at the cardiovascular disease, particularly in patients with type 2 diabetes, from the systemic literature review of scientific evidence over a period of 10 years, you can see that the cardiovascular disease presents about in 32% of diabetic patients, with the 21 to 29% of this is contributed to atherosclerosis and coronary artery disease, and stroke being 7.6% and heart failure by almost 15% in diabetic patients. And as you can see from this study, looking at different sort of cardiovascular endpoints, whether cardiovascular death, coronary death, or cardiovascular hospitalization, you can see that over the past 2 decades, there is a trend or a decline in the incidence of these cardiovascular endpoints. But you can see still a gap between diabetic versus matched controls and red lines, as you can see. So we're still having this gap, and still diabetics considered at higher risk for these cardiovascular complications. So we all agree, and based on most of the international guidelines, that multifactorial approach improves definitely the outcome and prevents complications, especially cardiovascular complications. So we know that the focus on glycemic control, lifestyle modification, blood pressure lowering, and dyslipidemia control are the mainstay to overcome these adverse outcomes. And that would set sort of targets for the clinicians to achieve in their clinical practice. Based on most international guidelines, you have target sets for the HbA1c below 7%, physical activity more than 150 minutes per week, and blood pressure below 140/90, and of course, strict lipid targets for these diabetic patients. Now, looking at the guidelines, and most recently the updated 2022 ADA guideline, it's more or less basically the same as the 21 or 2020 guideline, but you can see that the statement at the beginning, it's sort of more flexible approach. So we do all agree that lifestyle modification is a very important step in treating diabetic patients. But now they are telling you that metformin generally should be included in the treatment, but not necessarily a must as a first-line agent. So they look at individualization. So the first question you need to ask yourself when you treat patients with diabetes, you need to categorize them. Does your patient have any evidence of cardiovascular complications or cardiorenal complications? If not, then you go to the right side of the algorithm, and then you would decide the treatment option based on your concerns. If hypoglycemia is a concern, or weight gain is a concern, or cost is a concern, then the agents are giving you agents of choice. But let's look at and focus on the left side, which is the patients with high cardiovascular disease and heart failure and chronic kidney disease. So basically, and based on the cardiovascular outcome trials for the agents available for patients with evidence of cardiovascular disease or who are at high risk for cardiovascular disease, of course, the GLP-1 receptor agonist or SGLT2 inhibitors are in favor here. And if patient presents with heart failure, then the preference is here for SGLT2 inhibitors. And if you have evidence of CKD with albuminuria, then SGLT2 with proven evidence would be preferable. And if you have a low GFR, but without albuminuria, GLP-1 receptor agonist with proven benefit would be preferable. So the interchange between GLP-1 receptor agonist class and the SGLT2 is the primary sort of your initial step in these high-risk patients. So looking at the effect of GLP-1 receptor in the body and mainly the pharmacological effects, it actually works on different sites in the body. And that's the fascinating aspect of these agents. So at the pancreas level, GLP-1 receptors increase beta cell function and increase insulin biosynthesis. And at the liver, it decreases hepatic glucose production and increases hepatic insulin sensitivity. It reduces lipotoxicity, and at the brain it works on satiety center, increasing the satiety, then decreasing food intake and thereby lowering the body weight. And at the GI tract, it slows down the gastric emptying, and at the kidneys it increases actually natriuresis and slightly diuresis and decreases inflammatory markers. And that's why sometimes you would see that your patients would report polyuria or increased urinary frequency after using these agents. Also, it affects or works at the muscle level by increasing insulin sensitivity. Now, the PK profile for this class is very smooth, and if we look at semaglutide, it stands out for its very nicely PK profile with a T-half of 7 days and a T-max of 1 to 3 days. That puts us put it as a very interesting and practical agent to be used as a once-a-week injection. Now, looking at the primary efficacy endpoint in most of the trials, and we're looking at head-to-head trials for GLP-1 receptor agonists in terms of reduction in HbA1c from the baseline. So this slide shows you the comparison between injectable semaglutide once a week, the lower dose of 0.5 milligram and the 1 milligram versus other GLP-1 receptor agonists. So looking particularly at the SUSTAIN-3 trial, for example, where the blue bars actually represent the semaglutide. So the light bar is the 0.5 milligram dose and the dark blue is the 1 milligram dose. So in SUSTAIN-3, the 1 milligram dose was compared with exenatide 2 milligram. As you can see, significantly difference in terms of HbA1c reduction from baseline, with 1.5% reduction from baseline for the semaglutide versus 0.9% reduction for exenatide. And if we look at the SUSTAIN-7, in which the lower and higher doses of semaglutide were compared with lower and higher doses of dulaglutide, you can see that it was statistically in favor for semaglutide with 1.5% reduction in HbA1c from baseline compared to the lower dose 1.1% reduction for dulaglutide. And if we look at the higher dose, 1.8% reduction from baseline versus 1.4% reduction for the dulaglutide. And in SUSTAIN-10, it was actually the higher dose 1 milligram was compared with liraglutide 1.2 milligram. And again, you can see more significant A1C reduction, reaching up to 1.7% reduction from baseline compared to 1% achieved by liraglutide 1.2 milligrams. Now, in terms of the head-to-head trials looking at body weight, and that is the very interesting aspect of these agents, because you're not even using them just to control diabetes, but causing weight loss. And that is the typical beneficial additive effect that you would see, especially in diabetics with underlying, overweight, obesity, fatty liver, insulin resistance. So looking and comparing, and we know that this is a class effect, but if we look at the comparison between semaglutide versus other GLP-1 receptor agonists in terms of weight reduction. So SUSTAIN-3 compared again with exenatide, a significant reduction from the baseline for semaglutide. So 5.6 kgs versus 1.9 kg for exenatide, and SUSTAIN-7 when it was compared with dulaglutide, again, significant reduction for the lower doses, 4.6 kgs versus 2.3 for dulaglutide, and at the higher doses, 6.5 kgs weight loss versus 3 kgs for dulaglutide. And in SUSTAIN-10, when compared with liraglutide. So liraglutide was the one of the leading and initial GLP-1 receptor agonists that we were using to treat diabetes and obesity. But look at this fascinating result, 5.8 kg weight loss for semaglutide, 1 milligram versus 1.9 kg weight loss for the 1.2 milligrams liraglutide. And in terms of the cardiovascular outcome trials, that is very important. We know that this class proven not their cardiovascular safety, but they have shown also positive outcome. And if we look at the semaglutide injectable, in particular in SUSTAIN 6 trial, it showed actually beneficial effects in terms of 3-point MACE and non-fatal stroke, as well as non-fatal MI. So it's showing the cardiovascular protection that you get with these agents, placing them as the priority in the guidelines to treat patients with diabetes and evidence of cardiovascular disease. So now looking at the once a week, this molecule was, several changes were made at the GLP-1 molecule to make it as an analog as once a week. So the amino acid substitution at position 8 and at position 26 resulted in like sort of 94% homology to human GLP-1 and a T-half of approximately 1 week. And if you look at that, a beautiful PK profile of semaglutide that is very nicely sustained over a period of 1 week, giving it a T-half or mean or max between about 149 hours. And very importantly, the way that it acts, it was shown actually in mice when were injected with semaglutide intravenously that the molecule acts centrally in the brain stem and hypothalamus by affecting actually the food intake pathways and acting on the satiety center and thereby increasing the satiety level. And this is what we see, one of the driving factors in the weight loss and with these agents. And also semaglutide reduces energy intake and expenditure. You can see a little bit on the expenditure side, but mostly on the energy intake side, with a significant reduction in total intake during ad libitum meals. And also, very importantly, the semaglutide has this anti-atherosclerotic effect that we have seen it in the cardiovascular outcome trial, but also proven in the mouse models, as it was shown that it causes sort of attenuation of plug lesion in areas of atherosclerosis, as was detected in the mouse models. So when we look at this agent, this injectable once a week semaglutide compared to the other agents, whether the GLP class or even other antidiabetic agents, we can see that evident from the different trials conducted for this molecule on the SUSTAIN 1 to 5 and the SUSTAIN 7 to 10. So firstly, you can see compared to the other GLP-1 receptor agonists in terms of HbA1c reduction, I have shown you in the earlier slides the significant reduction in HbA1c compared to the exenatide, dulaglutide, liraglutide, even if added to other anti-diabetic agents. So still, semaglutide was doing really significantly better with overall like about 1.5 to 1.8% reduction in HbA1c from baseline. Not only that, when we look at oral agents compared to sitagliptin and canagliflozin, when added to other agents in terms of treating for improving diabetes control, you can see that semaglutide was able, even the lower dose of 0.5 milligram resulted in 1.3% reduction in HbA1c, and the 1 milligram resulted in 1.6% reduction in HbA1c compared to 0.5% reduction for sitagliptin. And when we compare it to the canagliflozin, again, more significant reduction in HbA1c, 1.5% versus 1% for canagliflozin. And very importantly here, as you can see, add on to SGLT2. This was one of the agents of the class that was really looked at as an add-on to SGLT2 versus placebo. And you can see a significant reduction in HbA1c, 1.5% from baseline. And what about weight in comparison with other agents? Again, looking at the other GLP receptor agonists I showed you earlier, and even when these agents were added to other anti-diabetic medications, you can see still semaglutide at different doses, the 0.5 milligram and the 1 milligram, was achieving better weight reduction, reaching up to 6.5 on average kgs reduction in weight from the baseline compared to the other GLP-1 receptors such as exenatide or dulaglutide or liraglutide even. And when we compare to the oral agents, like for example, sitagliptin, you can see that there is a significant weight reduction compared to sitagliptin, again reaching 4 kgs weight loss for the lower dose and 6 kgs weight loss for the higher dose compared to 1.9 kg. And for the canagliflozin, canagliflozin is a SGLT2 inhibitor. So we know that SGLT2 inhibitors, they cause some weight loss, but when compared to semaglutide, again, the 1 milligram dose was significantly better, achieving weight loss compared to the canagliflozin. And as an add-on to SGLT2 versus placebo, beautiful reduction in weight, as you can see here, almost 5 kgs from baseline. Now, SUSTAIN-6 was the cardiovascular outcome trial, looked at the dose of 0.5 milligram and the 1 milligram versus placebo, and the primary outcome or key points in this trial were time to first occurrence of death from cardiovascular causes or non-fatal MI or non-fatal stroke. And as I have alluded earlier, that this trial was actually, it met its primary endpoint, and it showed a statistical significance for non-inferiority and also superiority, causing reduction in the primary endpoint, more significant for semaglutide compared to placebo. And not only that, for the nephropathy outcome, the semaglutide also did better compared to the placebo, and primarily the result was driven by the reduction in the persistent macroalbuminuria that was seen in the study. So what is next? And that is that we have been really waiting for. Most of you know the fascinating results for this class, and we are very happy in terms of the glycemic control achieved and the weight reduction. But again, sometimes you do face some resistance from your patients refusing injectable therapies. And this is what we have been waiting really eagerly for the oral forms of GLP-1. And here I'm showing you the only and the first oral GLP-1 receptor agent is the oral semaglutide. So maybe most of you know that oral semaglutide was FDA approved and is being marketed in several countries in the world, in some countries in the region, not yet in Bahrain, not yet registered in Bahrain. It's a fascinating and innovative approach to diabetes treatment. And most of you are really eager to know whether we are seeing similar benefits to the injectable form with the oral agents. This is what I'm trying to show you now. So oral semaglutide is a novel tablet developed for treatment of type 2 diabetes and first GLP-1 receptor agonist for oral administration. This treatment delivers new possibilities of earlier diabetes management with significant improvement to glycemic control, weight reduction, and low risk of hypoglycemia. So based on this molecule, an established safety profile and favorable cardiovascular risk-benefit profile. And this actually molecule, it comes in three doses, the 3 milligram, 7 milligram, and 14 milligram doses. It gets absorbed very well in the stomach, and the absorption method requires actually a co-formulation with SNAC. SNAC is the sodium hydroxybenzoyl caprylate. And the SNAC causes a local sort of increase of pH, leading to higher solubility and protection from proteolytic degradation. So looking at this like pharmacokinetic profile of this agent and knowing that we have it now in 3 doses, as I mentioned earlier, 3 milligrams, 7 milligram, and the 14 milligram taken as once a day. And looking at the trials conducted, so we had the sustained trials for the injectable form of semaglutide, and these are the pioneer trials for the oral form of semaglutide. And of course, in these trials, because it was an oral agent, it was compared with other oral anti-diabetic agents in terms of primary endpoint HbA1c reduction. So looking at the Pioneer 2 and Pioneer 3, very fascinating results. So when compared with empagliflozin, an SGLT2 inhibitor, the higher dose 14 milligram and the higher dose of the EMPA 25 milligram, the oral semaglutide actually resulted in better glycemic control with a 1.3% reduction in HbA1c from baseline compared to 0.9 with empagliflozin. And in Pioneer 3 trial versus sitagliptin, you can see that the different doses did, actually the 7 milligram and the 14 milligram doses did better than the sitagliptin with a reduction 1 to 1.3% in HbA1c from baseline compared to sitagliptin. And comparing it with liraglutide, so this is liraglutide 1.8 milligram. And remember, we were using initially liraglutide to treat our diabetic patients with obesity for weight loss as well, and the glycemic control. So look at the oral semaglutide 14 milligram causes 1.2% reduction in HbA1c versus 1.1% for liraglutide. Similarly, when added to insulin therapy, there were a significant reduction in HbA1c from baseline. 1.3% reduction from baseline for the higher dose. Now, when we look at the body weight and compare it to the other agents, again, empagliflozin, a class of agent that causes weight loss, again, the semaglutide higher dose was slightly better in terms of weight loss compared to the empagliflozin, and versus sitagliptin, definitely significantly better than sitagliptin in weight loss. You can see an average 3 kgs from baseline for the higher dose. Similarly, when we look at the liraglutide, that's very interesting. Compared it to 1.8 milligram liraglutide, the oral semaglutide 14 milligram resulted more significant weight loss, almost 4.5 kgs compared to 3.1 with liraglutide. Similarly, when added to insulin therapy, you could achieve further weight loss in insulinized patients, reaching to 4 kgs from baseline. And in terms of number of patients achieving target HbA1c below 7%, more patients were able to achieve target HbA1c in the oral semaglutide arm compared to the other oral agents. Similarly, even when compared with liraglutide and when added to insulin therapy. And with that, I would like to conclude my talk on this fascinating drug, compared to you the injectable form versus the newly released oral semaglutide form. And thank you very much for your attention. I would be happy, I guess we have 10 minutes for some questions. Thank you.
Thank you, Dr. Nesreen, for this amazing session. It was great, actually, and very comprehensive. I believe till I receive some questions, maybe I will start by asking you. Doctor, do you think what are the benefits that patients can get by using these newer agents, GLP-1 or SGLT2s, in the earlier in the course of type 2 diabetes?
So based on, as I said, the evidence, the cardiovascular outcome evidence that we have, and even if you look at the guidelines, the pathway in terms of even in patients without underlying cardiovascular outcome, and when your primary concern is to treat diabetes, along with treating, causing some weight loss, these agents are really the priority. So you could achieve cardiovascular protection based on the outcome results that we have. You could achieve renal protection based on the nephro outcome that we have. And at the same time, in addition to powerful glycemic control, we could achieve a significant weight loss, as I showed you in the slides.
Thank you, Doctor. I believe this is a fair answer. Doctor, we're receiving a question regarding in your practical or in your practice, how do you consider patients for GLP-1 or these newer agents?
Yeah, so again, maybe in a clinical practice, now speaking, from my personal view, I'm practicing in private sector, so maybe these choices are coming to us more readily, but we know that in the government and public sector now, these agents are now being available, and some of them are available. And I think that patient individualization is very important. So as I mentioned earlier, the first thing that you would ask yourself, the patient that's sitting in front of me, I would do a full evaluation. Does this patient have any evidence of cardiovascular disease, heart failure? You check the renal parameters, albuminuria, kidney disease. The patient is being overweight or obese. All these factors really would be the driven factor to consider these agents. And the second thing is that you need to have sort of a discussion with the patient, and this is like a shared decision. You need to discuss whether the patient would be okay with injectable therapies. Is the medication available? If it is available, is it reasonable for the patient? Can the patient afford it? And whether the patient really prefers oral versus injectable. And that's so fascinating now that we have the oral GLP-1. You could really very flexibly, offer that to your patients. We are not any more strict just having the injectable forms of the GLP-1 anymore.
Yes, I believe that would be a real innovation when it comes to Bahrain. Another question, Doctor, seeing the results of adding GLP-1 to SGLT2 and supported by the newest guidelines, there would be any expected side effects or something when adding both together?
Now, in terms of the side effects, we know that the side effect profile for each of the classes is a bit different, even though that we know that the GLP-1 receptor agonist might cause some natriuresis. And when we give the GLP-1 actually as a single agent or an add-on not necessary to SGLT2, some patients might experience slight increased frequent urination, and we do explain to the patients that this is sometimes expected. This might be a bit augmented when you do a combination with the SGLT2, so educating the patient is very important, and this would be probably more noticeable at the beginning when the HbA1c to start with is high, but once you are achieving near normoglycemia, this sort of increased urinary frequency might be lowered. But educating the patient, advising them to have plenty fluid intake. And we know the GI side effects of the GLP-1 receptor, they are there, still possible. Even if you combine it with the SGLT2, it might be there and it needs to be addressed with the patients, making sure that if they minimize fatty food intake and carb intake, these side effects would be actually less. The more they take more sort of carbs or fatty food, it would sort of exaggerate these side effects.
Thank you, Doctor. I don't know whether we have more time, Dr. Asad, for questions, or we're... behind time. That's okay.
I think there is 2 questions you can.
Yes, I'm trying to search for them, but
you have 2 questions. You have 2 questions and
okay.
the question and answer.
Yes. Okay. Yes. Okay. Got them. Okay, Dr. Nasreen, there is a question about oral sema. It will be given daily or weekly?
Yeah. So the oral semaglutide is given as a daily dose, and it is given more or less similar to thyroxine. So we prefer that it should be given on empty stomach and with a little sip of water, and the patients need to leave a gap of at least 30 minutes, minimum 30 minutes, and then they can have their meal.
Yes, and actually this answered the second question. This was what the second question about from Dr. Rami. Thank you, Doctor, for this amazing presentation, and also for taking all the questions and answering them in very comprehensive way. Thank you, ladies and gentlemen, for attending our session. See you all soon in our next symposium. Thank you.
Thank you. Thank you very much. Thank you for having me. Thanks.
Thank you, Dr. Nasreen.
Thank you, Dr. Mary and Dr. Nasreen, for your presentation. Now we will have the, we want to present next lecture. It will be Dr. Regina Patrikeva, I think. We will get it earlier until Dr. Ghada join our team. Dr. Regina is there?
Yes, I'm here.
Yes, okay. So, Dr. Regina, it is really nice again to introduce you. She's a consultant endocrinologist, and she has been a teaching assistant in St. Petersburg Medical University, founder of educational web resources for patients with the diabetes, senior lecturer for postgraduate courses, European Association for Study in Diabetes. Dr. Regina, she will talk about the hypoglycemia and diabetes type 1. And it is really interesting topic to talk about it, because the risk of hypoglycemia still we need to look for, and teaching the patient, keeping them aware about the complication, how to deal with it. All we will see with presentation of every time. We know that Dr. Regina, she will stress on very important and tricky points. Thank you, Dr. Regina.
Thank you very much for a kind introduction, Dr. Assad. It's a great pleasure for me to be here again. I will try to share my screen now. Just a second. Can you see it now? Is everything okay?
Yes, we can see.
I'm very happy to speak here about one of most important topic in diabetes field. Why? Because the problem of hypoglycemia is still a great thing in diabetes care, because for all of our patients living their lives with type 1 diabetes, their life is really as an art of balance. Why? Because all these 3 crocodiles, hypoglycemia, quality of life, is a dangerous situation for them to work with. And of course, hypoglycemia, especially recurrent hypoglycemia, is still the major limiting factor for the glycemic management of type 1 and type 2 diabetes. But today we will concentrate on type 1 diabetes, because for these people is really an issue to work with. Everybody knows the classification of hypoglycemia according to the International Hypoglycemia Study Group. And of course, we know hypoglycemia alert value. We have here numbers in milligrams for deciliters and in millimoles per liter. Clinically significant hypoglycemia and severe hypoglycemia without any specific glucose value. And it's necessary to remember it. What is pathophysiology of hypoglycemia? Of course, there are a lot of things here, it's problems and issues with blood coagulation, with levels of fibrinogen, prothrombin, factor 7, platelet activation, aggregation. Of course, it's about white blood cell amount, mobilization and activation. It's about processes of inflammation and a lot of cytokines around this process, about free fatty acids, about endothelial dysfunction, and about cell adhesion. And a lot of molecules are known here, and there are so many publications in this field for now that I don't have enough time to discuss everything, but the major key factors are shown here. What is also important to keep in mind is that we need to remember about assessment through the lifespan, through lives or our patient with type 1 diabetes. And of course, if you're talking about hypoglycemia, it's a very great problem in infants and preschool children. But since school age, we need to try to teach our children with diabetes to recognize hypoglycemia, because school environment can be very dangerous from that point of view. And of course, for adolescents and for young adults, it's also can be a great problem. But I just want to emphasize here that we, even through the 7 years old or 6 years old, it's a good time to start education about recognizing hypoglycemia, symptoms of hypoglycemia, and especially about reasons of hypoglycemia occurrence. And that's why it's also very important to remember that the amount of hypoglycemia really matters, not only HbA1c level, and the good conception which we need to remember is conception about time and range. And it's impossible to discuss any severe conception in diabetology without taking good care about hypoglycemia amount. That's why it's very strictly recommended to have time below range, less than 3.9 millimole per liter, less than 5% of average day during the usage of CGM or flash monitoring, and even for not only for type 1, but also for type 2 diabetes patients. And of course, it's a very useful tool just for everyday care of our patients with type 1 diabetes worrying about hypoglycemia. What are the well-known causes of hypoglycemia? Of course, it's increased insulin sensitivity, decreased insulin clearance, and we need to remember about renal failure here, about inadequate exogenous carbohydrates amount, about increased carbohydrates utilization, about inappropriate insulin injection, about injection technique or insulin infusion technique usage, about decreased endogenous glucose production. And very important from the clinical point of view is also to remember about symptoms of hypoglycemia, because of course there are so many factors which can influence on that, not only alcohol or drugs, which are well-known factors, but also aging, sleep quality and amount of sleeping hours, posture, physiological things, distraction, knowledge about hypoglycemia, and psychological issue. And of course, also very important to understand that there are so many symptoms of hypoglycemia, especially in elderly population, which can be very, very close in cognition of the patients to hypoglycemia symptoms, but for example, be from neurological part of their diseases. For example, of course, we all know about neuroglycopenic symptoms, about autonomic symptoms, but if you just go through neurological symptoms of any neurological disease, especially for older people with vessel problems, atherosclerosis, of course, it can be also very, very close in symptoms to hypoglycemia, and it can be very dangerous for these patients. What about current data, which are published not very many years ago? Of course, hypoglycemia remains a relatively common adverse effect, and of course, aside from the immediate cognitive and emotional impact of acute hypoglycemia, impaired hypoglycemia awareness is a consequence of repeated exposure to hypoglycemia. We will talk later about it. That carries a high risk for severe hypoglycemia, and here is a great dangerous situation for our patients. And epidemiological and preclinical research also indicate that recurrent hypoglycemia may exacerbate chronic hyperglycemia due to increases in oxidative stress and inflammation. And there was a very recent publication about it. What we know about potential mechanism underlying the development of impaired awareness about hypoglycemia, of course, change in glucose transport, about alternate fuel use, glycogen storage, lactate delivery to neurons, about glucose sensing, about neurotransmitter release, and there is recent data about glutamate here, about glial transmitter release, cytokines, chemokines, ATP, and about peripheral signals with opioid, steroid, and cytokines. So there are so many things which are involved in this process. And it's a very great publication, and I also very recommend you to find it and read it. And if you cannot find it, just send me a mail. I will send you this paper, because this schematic understanding that all recovering from the hypoglycemia can also be very dangerous for patients, because it can be close to a patient to chronic inflammation, oxidative damage, and even mitochondrial dysfunction. Again, what we need to think about when we just trying to understand what are predictors of recurrent severe hypoglycemia in patients with type 1 diabetes, and it's a great publication about adult population living with type 1 diabetes. And it was very beautiful, showing that recurrent severe hypoglycemia was associated with higher intervention severe hypoglycemia rate, fear of hypoglycemia, and even neuropathy. Of course, it's understandable, because the symptoms of hypoglycemia can be less understandable for patients here. But if you will just keep in mind these conditions, maybe we will at least try to predict recurrent severe hypoglycemia in our patients. What is also very important to remember about hypoglycemia, especially about recurrent hypoglycemia, I think it's a main message for you here, that the person behind the numbers, because the glucose levels and even behind the numbers from continuous glucose monitoring, from insulin dosage, is much more important. Because of course, what goes on in a diabetic head every second, it's very difficult to understand, even for us clinicians who are working every day with patients with type 1 diabetes. But here, of course, there are an issue with psychological consequences of hypoglycemia, and we can divide them to short-term consequences and long-term. And here we need to remember about anxiety, cognitive dysfunction, aversion, depersonalization, loss of control, guilt, frustration, embarrassment, dependent on others, accidents, and long-term, which are very important: stress, avoidance behavior, obsessive self-monitoring, because it's a understandable possibility to control their disease, relationship conflicts with families, with close friends, again, frustration, work, school problems, and social isolation in some cases. Of course, everybody knows this. High hypoglycemia can occur suddenly, even if the patients are very well controlled, has very well controlled diabetes at any time of the day or night. And unexpectedly, hypoglycemia may result in numerous potential negative consequences, and they're all, not all of them, but most of them are written here. These consequences can induce fear, a common and natural reaction to a threat, and enable a timely reaction. And of course, controversy and properly low levels of concern about hypoglycemia, because it's very difficult for patients to be concentrated on this problem every second of their life. Why hypoglycemia is feared? Of course, because it's loss of control, it's personal embarrassment, it's unpleasant symptoms and effect on mood, risk of losing consciousness, risk of injury to self and also to others. And there are so many situations which I discussed with my patients during their life about it. Potential dependence on others for help, risk of occurrence during sleep, warning symptoms may be inadequate or even absent, potential impact on daily activities. And of course, because of all these things, we need to think what we can do for patients with fear of hypoglycemia. And well-known strategies are shown here: frequent self-blood glucose monitoring, one glucose level less than 4 millimole per liter, set the right target range, appropriate treatment for every hypoglycemia, SAP, of course, insulin analogs, and education of patients and family members. And it's also very important to remember that there are very popular understanding that we can use term problematic hypoglycemia, and use this very understandable model about what we can do for patients with problematic hypoglycemia, and recurrent hypoglycemia for sure is problematic one. So we can just go through all these steps step by step and reassess every 3 to 6 months. And there are some steps from structured education. It's the beginning of every problem in diabetes care, or hypoglycemia specific education, we'll discuss it later, to insulin pump usage, or even with real-time monitoring or flash monitoring, low glucose suspend or closed loop system commercially, which is possible to use now, or even pancreas transplant. And if it's just trying to go to put everything in one therapeutic guideline, of course, it's very published a lot of times, and we can avoid episodes of hypoglycemia by reduction of risk factors, and we discussed it before, with establishing individual therapeutic goals, use of insulin analogs, and all these technology things. But I want to concentrate here to this therapeutic education concern, because of course frequent measurement and understanding what's going on here, even during nighttime, is very important for our patients. And not only just using simple use of continuous glucose monitoring, but very important word here is effective use. So patients need to have enough knowledge to understand what they can do with all these low numbers which are written on continuous glucose monitor system. Adjustment of insulin dose to meals, physical activity, lifestyle, and of course here it's again about education and causes, understanding of causes and symptoms of hypoglycemia, which we discussed before. Maybe a training and perception of hypoglycemia here can be useful, and of course psychological support, because we discussed psychological consequences of hypoglycemia. And a good example of what we as clinicians can do with very easy therapeutic education sessions with our patients. And if we compare here red and green lines, it's very understandable that structured training course on glycemic control and severe hypoglycemia rate is very, very effective. You can see here the amount of patients who were involved in this educational activity. So no concerns, we need to go through this advice and educate our patients in the proper way. So here we can just understand there are a list of programs which is possible and very easy to find information about all this program, and almost all these programs due to COVID-19 situation were performed online during the last couple of years. So just put this abbreviation to Google and you will find information about lessons and everything. If you will not find this, just ask me. I will help you in finding this. And just to be sure that we have the common thinking about the hypoglycemia importance, as you know, this year the consensus report about type 1 diabetes care was published, and it's a consensus report for ADA and ESD together. And even here we can find information about hypoglycemia for discussing about beta cell replacement therapy in people with type 1 diabetes. So the issue is huge. The topic is very big and very important, even for guidelines. And I still need to remind you that there are many options now for our patients. They still can draw their diaries in a paper way, like my patients here from the right side of the screen, or during usage of flash monitoring system without any hypoglycemia. As you can see here, successful treatment of diabetes. They can use insulin pump or even do-it-yourself system with very strict control of diabetes. It's a story about pregnant women with type 1 diabetes without any hypoglycemia, so it's very successful. But the main idea here is to understand that if you just can dream about life for our patients with type 1 diabetes without any hypoglycemia, you can do it. So dear colleagues, dear friends, just do it for our patients, because of course, despite significant technological advances in insulin therapy over the last 20 years, hypoglycemia continues to be a major barrier to the effective treatment of diabetes. There is the reasonable evidence from both RCT and observational studies that structured education can help us. Emerging evidence suggests that individuals with IAH without not appropriate avoidance of hypoglycemia at high risk of severe hypoglycemia benefit from specific educational intervention, and we also need to perform it. And this particularly applies to structured approach that target both education and also psychological issues, because we always need to remember about person behind the numbers. So prevention of hypoglycemia is important, and everyone, and you also personally, can decrease the amount of hypoglycemia with knowledge, understanding of patient's needs, attention to patient education, and attention to the patient's family needs and fears. Thank you for your attention, and thank you for all my patients who inspire me every day during my practical work. If you need something from presentation, again, just email me. I will send you this slide or whatever you want to have from me. Thank you.
Thank you, Dr. Regina. Now, I think also Dr. Ghada joined us. Welcome, Dr. Ghada. And regarding the, we are looking for the question until that time. So basically, I observed that many of patients with type 1 diabetes, they used to have hypoglycemia, and they used to reduce the sugar by different mechanism. As I surprised that some patients, they keep sugar after meal very high, and then they want to just reduce it by fast-acting insulin to normal. And then, of course, they will get sometimes hypoglycemia and hectic, hectic level of glucose. So basically, is there any way in your practice to deal with this, young boys, and try to keep them in a way to follow what we are suggesting to them, the best way of giving insulin, taking meals and snacks? So is there any procedures you try to tackle this problem in your practice?
So adolescents with type 1 diabetes are my favorite group of patients, because you will never know what you can need with every person who just come into your office, because all of them are so interesting, and new generation, they differs from us, so it's every time like a puzzle. But what we need to understand here about young people with type 1 diabetes and teenagers, that they have psychological issues from their part of typical psychological development. So from the psychological point of view, they need to be independent from our opinions. So we have authorities for them. They need sometimes to ruin the authorities, doctors, such as doctors, and the parents, of course. And understanding of these psychological issues can help us to work with them, because it's impossible to say to teenager or to young adult, just do it like I tell you. It will not work, never, because they just want to show their own world with people who are close to them. And maybe the first advice here can be to use authority of their friends, of their social group, I don't know, web resource, or some sort of physical activity things. Maybe because we can use, for example, in Russia, possibility to have diabetes camp for our teenagers, and they can discuss in the group all these things around diabetes. Second advice, I calling it like parentectomy, to talk not with parents and young person with type 1 diabetes, but face to face only with the patient, because sometimes for a young person with type 1 diabetes, it's very difficult to communicate with parents because they depend on their opinion. And so first one, social things with friends and their close ones. Another one, parentectomy. Third thing is to work with psychologists, because for sure teenagers nowadays know about possibility to have a contact with psychologists or psychotherapist, even sometimes a psychiatrist, because it will help to understand. Because without these three steps, it's impossible just to say to a young person, oh, hi, you need to be educated in diabetes field, and welcome to lesson to our diabetes school or something. I will discuss with you everything about possibility to use insulin in a proper way. It will not work. So maybe to have some sort of another types of education for teenagers, like online lessons, something in social media, you know, like I don't know, streaming about something in a proper way, because they will not listen to you in our, you know, boring doctor's way with discussion of lecture or something. Maybe it should be like short videos about insulin analogs or timing of injection or necessity to decrease glucose level. So we just need to find some solution around understanding of psychological parts of their life. So maybe it will be the main advices. Short question, long answer, sorry.
Thank you. It's really a challenge to accommodate the sugar and diet control as we request to our patients. We know that it's difficult with the insulin pump and sensors. It helps a lot. And even with the using of the fast-acting insulin and rapid action, or even the other things that should be different. I think by this, just we look if there is any question. And as you say, maybe some people shying. So again, the
I just want to, can I add something to your last comment? For me, from my point of view, it's we are not always right when we are thinking that insulin pumps and sensors will help everyone. Because for some people, again, due to psychological reason, it will not help, maybe just disturb them more than before. So it's also, you know, a room for improvement here is to work in the proper way with psychologists, because sometimes to understand that you need strict control is very difficult for patients living a lot of years with type 1 diabetes, for example, or for teenager, because when you just go in every day, every second of your life with some sort of medical device on you, it's impossible to hide your diabetes from you. So you will always remember about your chronic disease every second of your life. When you just go in and use all these things like syringes or pens, you can just easily hide them, and no one will know that you have diabetes. And it's impossible to do this insulin pump or sensor, which will be for doing something like this, and everybody will understand that something is wrong with you. Sometimes for young, especially patients with type 1 diabetes, it's very difficult. So I think the technology could help us a lot, but it's not a decision for everyone still. So again, psychological issues and person behind the number.
Thank you really for this nice lecture. Now it's my pleasure to introduce to Dr. Ghada Al-Khafaji. She's Associate Professor of Medicine, Genetic Department of Molecular Medicine at Jawhara Center for Molecular Medicine and Genetics, Director of Personalized Medicine Master Program at the College of Medicine, Arabian Gulf University in Bahrain. She has PhD degree in molecular genetics from King's College London, University of London, UK, and she's assistant professor in molecular genetics at the College of Science, University College Kingston, UK, and authority in the area of molecular genetics with the several publications in mitochondrial DNA mutations and mitochondrial dysfunction in human disease, non-invasive test, biomarkers for genetic disease. And Professor Ghada also, she is a member of our scientific committee for the consecutive IMDO conference. Now a floor for you, Dr. Ghada, please.
Thank you very much, Asad, for this nice introduction. And I'm so sorry for this mess because the internet cut in my office and I had to rush back home. And I thank Dr. Evgenia that she presented before me. Thank you very much. Let me just share my screen. Okay. Okay. Is it clear? Can you see it?
Yeah, everything's okay.
Yes, Doctora.
Clear, yes?
Yes, yes, please proceed.
Yes, so my topic is about mitochondrial diabetes. I'll take you a little bit into genetics and basic science a bit, and then we'll talk a little bit about this association with the clinical of mitochondrial diabetes. So If we look at the etiology or the development of diabetes mellitus, is known to be actually a result of genetics, epigenetics, and environmental factors. In genetics, there are several mutations and single nucleotide polymorphisms that play a role. Epigenetic factors like DNA methylation, microRNAs, and histone modifications, and environmental factors like nutrition, toxins, and other factors all interact together to produce the phenotype in some types of diabetes, which are polygenic. So if we look at this, we see that genetic component is nearly always present. In some types of diabetes, there are monogenic types, and I'll explain this in a minute, where there is an effect, a large effect of a single gene, which will lead to a clinical phenotype, whereas some types are caused by polygenic and multifactorial, with a small effect of multiple genes, plus the environmental factors and epigenetic factors. So again, for the polygenic diabetes, which are the most common one, here we have, there are lots of genes or multiple genes with low penetrance risk, and they modulate the susceptibility of an individual either to develop diabetes or sometimes to protect against the disease. Polygenic diabetes is also multifactorial, which means multiple factors are also involved, and it is a complex types of diabetes with no single cause and with no clear pattern of inheritance. Examples, of course, you all know type 1 and type 2 and gestational diabetes. These are the most common types of polygenic multifactorial diabetes mellitus. And then we have the monogenic diabetes, which are really rare, but caused by mutations in single genes. And these genes are high penetrance genes, which will lead to forms of monogenic diabetes, including MODY, which is maturity onset diabetes of young, and neonatal diabetes. Both of them are inherited as Mendelian inheritance, as here as an autosomal dominant transmission in MODY, and autosomal dominant or recessive in neonatal diabetes. Then we have mitochondrial diabetes, which is the focus of my talk today, which is inherited in maternal transmission, and I'll go into this in a minute. So a little bit about the mitochondria before I go into mitochondrial diabetes. We all know that mitochondria are organelles, intraorganelles in all cells except RBCs. They are maternally inherited. So all our mitochondria comes from our mothers. Unfortunately, males, they don't contribute to mitochondria. They got it from their mothers, but they don't give it to their offspring. The main function of mitochondria, of course, energy production, but there are lots of other functions, including generation of reactive oxygen species, oxidation of fatty acid, and many other factors, some of them also related to or closely related to diabetes and its complication because of the effect on beta cell function. Because mitochondria are the main site of energy production and are the major source of intracellular rust, they're also prone to oxidative damage by ROS. Coming to the mitochondrial genome, there are many unique features of the mitochondria that they have their own DNA. So we have basically 2 copies of our chromosomes in the nucleus, but we have several copies or multi-copy genome, which is the mitochondrial genome, and we have around, of course, this depends on the cell, but thousands of copies in each of mitochondrial DNA in each cell. This mitochondrial DNA encodes important component, although only 37 genes are encoded by the mitochondrial DNA, but these are all important protein subunits of the electron transport chain. And 22 transfer RNA and 2 ribosomal RNAs, all of them are important in the function of mitochondria. Another unique feature of mitochondria is that the component of mitochondria encoded by 2 genomes. So the nuclear genome and the mitochondrial genome, many of the complexes of the electron transport chain are encoded by nuclear genome. Actually, most of them are encoded by the nuclear genome, and as I explained, only 13 are encoded by the mtDNA, and this complicates the diagnosis of mitochondrial diseases, including mitochondrial diabetes. The other feature, which is also unique, is the presence of something called homoplasmy and heteroplasmy. As I mentioned, there are thousands of copies of mitochondrial DNA in each cell. So some mutations can affect all copies of the mitochondrial DNA. We call them homoplasmy. This we call the mutation is homoplasmy because all copies of the mitochondrial DNA are affected by the mutation, whereas in some other situations, some copies are affected but present with the wild type copies of the mitochondrial DNA. We call it heteroplasmy. So this is a very unique feature for the mitochondrial genome, which is related to what I'm going to be talking about in the coming slides. And the distribution of the mitochondria, it's random during cell division, and the level of this heteroplasmy will vary among individuals, even in different tissues of one individual. And this will lead to variable expression of several symptoms or phenotypes, because we don't know which cell will get more mutated mtDNA, which cell will get less mutated mtDNA, and actually the proportion of mutated DNA molecule will determine the severity of the disease. So if there are most of the mitochondrial DNA copies are mutated, so there is highly affected people, and so on. If it is a little bit less, there will be intermediate level of mutation and will be low level. So this will lead to variable expression of the phenotypic symptoms of individuals who are having mitochondrial diseases. So most of mitochondrial diseases are caused by mutations in the mitochondrial DNA itself, and this is maternally inherited, and all of them are associated with defect in oxidative energy metabolism. What are other mitochondrial diseases are caused by mutation in the nuclear DNA, and as I told you, the component of the mitochondria are encoded by both mtDNA and the nuclear DNA. And in this case, if the disease is caused by mutation in the nuclear DNA, of course, it will be inherited as Mendelian inheritance. Whereas if there is a mutation in the mtDNA, the disease will be inherited as maternal inheritance. So all mitochondrial diseases are rare, including mitochondrial diabetes and heterogeneous, affecting, of course, organs which are highly dependent on the energy and aerobic metabolism. And the symptoms can vary, depends on the mutation and the mutant load, as I explained, with heteroplasmy and homoplasmy, and depends on the tissue that is affected. And this heterogeneity actually complicate both diagnosis and management of mitochondrial diseases. The consequences of mitochondrial DNA mutations always viewed as impaired energy production and increased oxidative stress. So always when there is a mutation in the mitochondrial DNA, this will lead to reduction in the ATP production, and increased generation of ROS, which will affect the tissues in different ways. So the main talk here is the mitochondrial diabetes, which is, of course, in diabetes mellitus is the most common endocrinopathy reported in all mitochondrial diseases. So this is caused by poor functioning of insulin-producing cell in the pancreas, and also insulin resistance as part of the mitochondrial disorder. Also, as I mentioned, increased ROS production from mitochondria may cause further cellular damage, and this ROS production or increased ROS production plays actually an important role in the pathogenesis of diabetes and its complication. And as you all know, there is a big role of the mitochondria in insulin secretion from the pancreatic beta cell, and this is explained in this figure. So mitochondria produce ATP that is used to activate the transport potassium out of the cell through the ATP sensitive potassium channels, and then this will cause depolarization of the membrane and opening of voltage grade calcium channel, and this the calcium influx will into the beta cell will stimulate the release of stored insulin from the cells. So any alteration of the ATP generation in the pancreatic beta cell is thought to result in diminished insulin secretion, and this ultimately lead to beta cell apoptosis or dysfunction. The most common, or one of the actually only few types of mitochondrial diabetes are diabetes types are caused by mitochondria, and the most common one is maternally inherited diabetes and deafness, MIDD, and this is a subtype of monogenic diabetes which is associated with mutations in the mitochondrial DNA. It's very rare, accounts for 0.5 to 3% of all cases of diabetes. And the age of diabetes onset here in this type usually younger than what happened in type 2, and the average is about 38 years. Sometimes it occurs in different ages, but this is the average age of diabetes onset in MIDD. You know, as all mitochondrial diseases, MIDD is a multi-systemic disorder characterized specifically by diabetes and hearing impairment. Also, other symptoms like maculopathy and several other clinical manifestations, like some of them cardiac problems, end-stage renal failure, and also some other features like short stature. For diabetes in MIDD may present as variable phenotypes. Either it can be either type 1 or type 2, and this depends on the severity of reduction of insulin, and ketoacidosis is also observed in some cases of MIDD. Those patients are often present with normal or low BMI. So unlike type 2 diabetes, which are mostly associated with high BMI, here most of them are, most patients with MIDD are either normal weight or low BMI. Typically, hearing loss occurs before diabetes in this type of diabetes, and macular dystrophy and pigmented retinal lesions can occur in majority of patients, in about 80% of patients, but those patients, they don't have visual symptoms, and this could be incorrectly confused with diabetic retinopathy. But diabetic retinopathy in this type of diabetes is less frequently compared to type 2 diabetes, and this is maybe due to lack of combined hypertension. Short stature is also a common feature of MIDD. And of course, as I mentioned earlier, organs with high metabolic activity like muscles, myocardium, kidney, and brain are frequently affected, and this will lead to several other symptoms like GIT symptoms, neuropathy, and cardiomyopathy. The disease is inherited as maternal inheritance. This means that in maternal inheritance only the mother will contribute, as I mentioned, the mother only contribute mitochondria, and if she's affected, she will give the mitochondrial DNA mutation to all her kids, males and females. Whereas the males, sons will not transmit the disease, only females will transmit the disease. If the father is affected, none of his kids will be affected. So what causes MIDD? In most cases, point mutation in the mitochondrial gene MTTL1, and this gene encodes for transfer RNA for leucine. So this mutation also associated with another type of mitochondrial disease, which is MILAS, mitochondrial encephalopathy lactic acidosis, stroke-like episode syndrome. And in rare cases, also there are other mutations cause this type of the disease. This mutation only one. I think maybe to mute. So only one substitution, only one change in adenine to guanine, this will lead to this mutation, which will cause this big disease. And this mutation can lead to dimerization of the mutant transfer RNA and impaired aminoglycylation. This will result in increased degradation of encoded proteins. The mutation will also lead to reduction in ATP and also increase ROS production. And as I mentioned, this is why I mentioned about homoplasmy and heteroplasmy. This mutation is present as heteroplasmic state, and it coexists with other wild type or normal mitochondrial DNA copies. And this is caused the variable expression of the disease. Some individual will express the disease in very high way. Others will be mild or even less expressing the symptoms. So it depends on the mutation load. The expression of the disease will be affected. So how this will be related to diabetes, or how this mutation can lead in the pathophysiological mechanism to diabetes. Diabetes associated with this mutation characterized by both impaired insulin secretion and insulin resistance. So the mutation, as I said, decrease ATP production, and this will impair the mitochondrial function and will affect insulin secretion by the pancreatic beta cell, which will lead to beta cell dysfunction. And also studies have shown that this defect in glucose-stimulated insulin secretion is the early primary abnormality which occur because of this mutation. The mutation can also lead to to alteration in glucose metabolism of muscle and deregulation of hepatic glucose production. And this what happened in dysfunction of mitochondria in the muscle is expected to lead to higher lactate flux to the liver, and this will fuel the gluconeogenesis. Many studies showed the effect of this mutation, and this is one of the study by Masin et al. In Diabetes Journal. They showed the reduction in insulin secretion in patients who are carrying, those are the patients who are carrying the mutated DNA, particularly this mutation 3243AG, compared to patients who are non-carrier. So the importance of genetic testing here for this type of diabetes, I'm just going to present some cases which I took from this case report. Here we have, this is the proband that we are talking about, is 20 years old, medical student female who incidentally diagnosed with type 2 diabetes when they were taking tests for OGTT. So this is the proband. Here we have it. She is presented with low BMI, and she had deafness, which occurred prior to diagnosis of diabetes. And then if we look back at the family history, she has strong family history of diabetes, but not with deafness. Here, deafness, her mother is diabetic and the kids are diabetics, and she got diabetes and deafness. She was treated with oral anti-diabetic agents, and then before she was put on insulin before her pregnancy, but she during her pregnancy she got microalbuminuria, also hypercholesteremia. And then at the age of 37, you see she was 28 when she was diagnosed with diabetes. At the age of 37, she underwent genetic testing, which confirmed the presence of MIDD. And following this, she was referred for retinal screening, and her children also underwent genetic testing to see if they inherit the mutation. Another case here, again, here we have the proband is a 36-year-old female diagnosed also with diabetes during a routine checkup, and her BMI was 23, which is normal. And also she had deafness prior to the diabetes diagnosis. She was also treated with, before metformin with lifestyle interventions, and then with insulin at the age of 55. Then she had history of also microalbuminuria and other complications, osteoporosis, glaucoma, and other things. And then after she did a genetic test, she was diagnosed with MIDD. If you look at her mother, she's diabetic also. She's diabetic, she has diabetes and deafness, and her daughter and her daughter kids were all receiving genetic counseling. So in the case of MIDD, genetic testing is very important to confirm the disease. This is why I'm talking about the genetic testing, because the clinical features of MIDD are variable, and maybe it's misdiagnosed as type 1 or type 2 or even monogenic diabetes. So for the distinguishing these later forms of diabetes, this could be provided by the absence of autoimmunity and obesity and the presence of maternal inheritance. This is in association, of course, with deafness and other symptoms if there are symptoms. So the diagnosis of standard type 1 and type 2 are excluded by the presence of deafness, low body weight, macleopathy, and evidence of maternal transmission. And final approval of this should be through the genetic testing, which would confirm the presence of the mutation. The early recognition of this type of diabetes, MIDD, is important for the management of associated conditions, and of course, screening of maternal relatives can be implemented in this case. So for the management and the treatment, management is symptomatic. For diabetes, of course, those patients with this mutation present with lower BMI, as I said, and they will progress into the impairment of insulin is very progressive, and they will eventually treat it with insulin. Patients with a type 2-like phenotype can be initially treated with diet or sulfonylurea, because sulfonylurea, which is the first line of therapy here, because we don't care about the weight gain, they are already have low BMI, but of course, a risk of hypoglycemia is still here. Why sulfonylurea is the first line? Because metformin should be avoided because of the potential risk of lactic acidosis here, because metformin-related lactic acidosis mainly is due to inhibition of hepatic gluconeogenesis. For other symptoms like hearing loss, they can be treated with hearing aids or ocular implant. Also, those patients with all mitochondrial diseases, not only MIDD, they are treated with coenzyme Q10. And this is very important because it is known to act as an electron carrier of the respiratory chain in the mitochondria and improve the mutation associated with reduction or dysfunction in the respiratory chain. And of course, the treatment of MIDD should be initiated at an early stage, because complications could lead to also MELAS, because this mutation, as I explained earlier, is also causing MELAS syndrome. So to summarize, MIDD or maternally inherited diabetes and deafness is a rare form of diabetes that is often accompanied by hearing loss and macleopathy, and sometimes other clinical manifestations. It's commonly caused by a point mutation in the mtDNA encoded transfer RNA gene. And the diagnosis and differentiation of MIDD from other forms of diabetes are important for the implication of treatment and for identification of family members at risk of the disease. And actually knowing the etiology of DM should promote family screening, genetic counseling, screening of associated comorbidities, avoidance of metformin, and also caution in using statin, because studies have shown that statin therapy may exacerbate electron transport chain dysfunction and increases the rate and severity of symptoms. By this slide, I'm reaching to the end of my talk, and thank you very much for your listening.
Thank you, Professor Ghada, for your nice presentation. I think the way you present the lecture, it's been understandable for most of audience, and how we can translate the science to a clinical practice, although rare disease, but again, to keep the mind open for diagnosing and treating rare or sometimes a bizarre presentation or abnormal presentation of diabetes. So we'll give chance for questions, and I think we should be also looking for the way that some scientists looking for the mitochondrial as a treatment of diabetes, and many research and even clinical trials had been shown that mitochondria can be a source for or point for a medication to be for another way to treating diabetes. For the questions over here, we have, they are thanking you also for your presentation. And this is one question, but they are asking, what is the cost of doing genetic testing in Bahrain? Dr. Nagish Babu.
What is the cost?
Cost. I mean, if you want to do, yeah, usually you have, you talk about the SNPs, I think, or maybe, yes, the cost of genetic testing for this diagnosis.
To be honest, I have no idea how much it costs, but they are doing it for, I think, Salmania. They have the genetic, in the genetic department, lots of mitochondrial diseases, not only maternally inherited diabetes and deafness. They do these tests, and I'm not sure if they do it indoors or they send it outside, but they have this big department. With the new advances in technology, also cost has been reduced a lot. And in Al Jawhara, we are dealing with other types of genetic testing, not for this type, because this is mainly in Salmania. I'm not 100% how much, but I don't think it's very expensive.
As I understand, Dr. Ghada, there is we can say a national program for genome in Bahrain.
Yes.
So do you have any idea, is there any, if you communicated with the team there, is there any chance to look for the diabetes genetics in their screening?
What I understand so far, they are doing, they collected from healthy controls and I think cancer patients. They didn't start with diabetes, did they? They didn't, I think.
No, I'm just really asking, and then if we have chance to communicate with them in a way, so we can include your suggestions of doing again, looking for diabetes, since it's prevalent again in the Gulf countries. So basically cancer is important to look for, but of course, if we look for...
I think the start with cancer, Dr. Amani Al-Hajari, maybe she knows better in this, but we are going to give some lectures related to this Bahrain Genome Project. We are involved, all the Jawhara faculty are involved, but for the actual work, what I know so far, they are doing it for cancer, and they collected from cancer and healthy controls. They did not start with it, maybe later on. Yeah, maybe
Any
later.
comment from faculty speakers? Okay, so
I just want to say one more thing, because I didn't want to complicate my talk with other things, as you mentioned with the SNPs, because, and also your very nice elaboration about the treatment, mitochondrial therapeutic agent for diabetes, because what I was talking about is inherited type of mitochondrial disease. In type 2 diabetes, there are many, how do we call them, single nucleotide polymorphisms, which are SNPs. They are not inherited, they are somatic mutations. And they also contribute to type 2 diabetes. So this is another one thing where mitochondrial function will be important to be improved on all types of diabetes.
Thank you very much. Now it is the time to, and the pleasure for me to introduce Professor Asmina Metrikova, Professor of Internal Medicine, Diabetes at University of Athens, head of the Diabetes Metabolism Unit. And she had been trained in Mayo Clinic and University of Petersburg. Professor Asmina has mastered the isotope dilution technique in order to study the physiology of glucose metabolism and counter regulation. Special research interest in the pathogenesis of type 2 diabetes and impaired glucose tolerance, the physiology of postprandial glucose hemostasis, mechanism of hepatic glycogen repletion and physiology, and pathophysiology of glucose counter regulation. She's author of more than 85 original papers and more than 10,000 citations and impact factor of 42. Professor Asmina tackled a lot of topics, and really we are looking for her lecture. Professor Asmina, floor for you. Professor Asmina. Yeah. Hello.
Hello. I have sent it recorded.
No, that's okay. You send it recorded.
Yes.
Dr. Iman.
Dr. Asad, we're doing it. We're working.
Yes. Okay.
Thank you. But I'm around.
So if you want a comment until they start the lecture.
Well, I'm enjoying so much. I'm enjoying so much your meeting.
Dr. Asmina, just put your camera on, please. Put your camera on.
Okay, let me see how I do it. Zoom open. Confused. Okay, now.
Dear all, I'm very pleased and honored to be among distinguished friends.
Here.
I would like to congratulate Dr. Assad and the faculty team for the excellent program, as well as Dr. Eman and Dr. Ahmed for their support. I'm going to present to you remote glucose monitoring during the COVID-19 pandemic. And I'm Mina Mitrakou from Greece. Nearly 2/3 of COVID-19 hospitalizations in the US could be attributed to obesity, diabetes, hypertension, and heart failure. Almost 10 to 20% of the patients hospitalized during COVID-19 have diabetes. The bad news is that mortality is 50% higher in people with diabetes, both in men and women, actually mostly in men. And if you look at type 1 diabetic patients, they have even higher mortality if you take them at the age of 50 and over. The prevalence of severe disease in hospitalized patients is even more greater in people with diabetes and hyperglycemia, even if they didn't have diabetes before, compared to the people who did not have hyperglycemia. You know, among 1,000 patients in 88 US hospitals, the COVID-19 patients with diabetes and or uncontrolled hyperglycemia had a longer stay in the hospital and a higher mortality than patients without diabetes or uncontrolled hyperglycemia. Actually, patients with uncontrolled hyperglycemia had a particularly high mortality rate. Moreover, admission blood glucose is associated with severity of COVID-19 outcomes, and the higher the blood glucose on admission, the higher the severity of the disease during hospitalization. No matter what the blood glucose, the higher the blood glucose, the higher the severity. So there was no differences in mortality rates within category by blood glucose levels in patients with or without previous history of diabetes. Thus, it is recommended that healthcare systems should ensure that inpatient hyperglycemia is safely and effectively treated. First, the Diabetes UK came up with guidance on how to manage inpatient hyperglycemia. Anti-hyperglycemic therapy is personalized in critically ill patients with type 2 diabetes during the COVID-19 pandemic according to the degree of their glycemia. So either if they have low, moderate, or high hyperglycemia, insulin is recommended as a treatment. But mind you, 4 or more capillary blood glucose measurements per day are typically recommended for patients receiving multiple daily injections, but hourly glucose measurements are recommended for those receiving intravenous continuous glucose infusions, like in patients with critical illness, diabetic ketoacidosis, or hyperosmolar hyperglycemic state. Incredible pressure has been forced on healthcare systems worldwide by the coronavirus 19 disease and has led to a crisis situation. Emergent changes in hospital patients' care have been made. First, large number of hospitalized patients have diabetes and COVID-19, burn out healthcare workers, and third, and very serious, a lack of resources of personal protective equipment available to healthcare workers, forcing healthcare workers to choose between providing necessary bedside care and maintaining their own personal safety in light of extreme limitations in available equipment. These circumstances have raised concerns regarding the most appropriate way to address glycemic control during the public health. Not optimizing glycemic control due to clinical inertia driven by the fear or lack of supplies may lead to poor outcomes in patients with diabetes and COVID-19. Thus, there is a transformation of care, and we have to use continuous glucose monitoring. We have 2 types of continuous glucose monitoring, the real-time ones and the intermediately scanned. The real-time monitors, and I'll show you 3 of them at the bottom, the Guardian by Medtronic, the Eversense by Roche, and the Dexcom 64. It measures and displays glucose levels continuously, provides alerts and alarms for low and high glucose levels with individualized lower and upper limits. On the contrast, intermediately scanned CGMs measure glucose levels continuously, but displays glucose values only when stripped by the reader on a smartphone, requires a conscious decision by the user to obtain glucose information by scanning the sensor, and to do so at least every 8 hours to avoid data gaps in the glycemic data archive. This is what the CGM consists of. It consists of an auto applicator, a sensor and transmitter, and the smart device that receives the data. A CGM device is usually placed on the abdomen of the patient and a smartphone next to the patient's bed. The real-time CGM measures and displays glucose levels continuously, provides alerts and alarms. Using commercially available software applications, glucose values are sent through Bluetooth from the CGM transmitter to the smartphone located next to the patients, and from there, wirelessly, to the tablet or any other device with internet connection. An iPad can be located next to the clinician or the nurse at the nursing station and serves as a monitoring device presenting real-time CGM glucose values. With a protocol in place, staff can, by following specific instructions, hypoglycemia or hyperglycemia alerts, immediately react to correct the extreme glucose values or significant trends. First of all, the credibility of the CGM was tested, and it seems here that the correlation coefficient between POC, blood glucose measurements, and the sensor glucose values was 0.927. Mean absolute relative difference marked was 9.77, very good, and 85% of the sensor values were in Clark zone A and 100% in zones A and B. Thus, the remote glucose monitoring has been used in hospitalized quarantine patients with diabetes and COVID. And here is the use of the Medtronic system, a use of the CGM transmitters, the Guardian Connect by Medtronic, connected to glucose sensors, the Enlight Medtronic, transmitting glucose values every 5 minutes through Bluetooth connectivity to designated mobile devices that upload data to the web through a Guardian Connect application was used. Real-time glucose monitoring was viewed continuously by the team in a viral-free area, and to allow data visualization of several patients at the same time, the CareLink personal websites were assessed via different browsers and minimized to allow a view of real-time continuous glucose levels of up to 4 patients on a single screen. Remote glucose monitoring has been used in patients with diabetes and COVID-19 in hospital, not ICU, just in the wards. And it seems that with less finger tips, we concluded to better glycemic control. As you can see, blood glucose levels were lower, variability was lower in those using the CGM, and most importantly, time below 54 milligram per DL was almost very much minimized, almost zero in 3 of the 4 patients tested. Continuous glucose monitoring has been used also in critically ill patients with COVID-19. And this is the Dexcom CGM. This is the smartphone next to the bed, and this is the screen at the nurse's area. And as you can see, the blood glucose levels in red were very much similar to the blood glucose values that we obtained by the CGM. Moreover, using the CGM in critically ill patients and monitoring their blood glucose had as a result minimizing hypoglycemia. So less people got blood glucose values below 70, and less people got values below 54. And time below 54 was lower, and time below 70 was lower, and time below 54 milligram per DL was very much minimized. I'll show you the Greek experience with real-time CGM. We use the Menarini glucomen real-time CGM, which is very similar to the Medtronic and the Medtronic because these were the ones provided to our hospital. These are the mean glucose values in our patients during their stay, and they are almost all within range. Range was obtained was almost 60% during the whole stay. And here you can see during cortisone infusion, the blood glucoses were higher, but still within range, no hypoglycemia. And as soon as cortisone was stopped, then you can see the hypoglycemia. You have to react very fast there because glucoses go down very fast. And you can see we had a high rate of hypoglycemia in the beginning, and we corrected afterwards, but time in range was almost 70%. This is a study where they used computerized insulin infusion, almost like a closed system. So they used CGM, the glucose values, and they used computerized insulin infusion to correct the glucoses. And you can see it went very smoothly. And the blood glucose values measured by the nurses were very similar to the blood glucose obtained by the CGM. But of course, the CGM had to stop in certain circumstances, like during a cardiac arrest or during a compression of the patient when we had to turn him upside down. And we also used Libre and telemetry for people with type 2 diabetes and COVID. And Libre has been used in a single center cohort of 60 adult patients with type 2 diabetes or hyperglycemia and COVID-19 infection treated with basal bolus regimens. Glycemic control was assessed with the use of intermittent freestyle Libre glucose monitoring during the hospital stay. And the use of CGM improved their metabolic control, reaching time in range, low glycemic variability, low rates of hypoglycemia, similar to previous studies done with Libre monitoring. In addition, this study showed the time above range in these patients, especially those with hyperglycemia with no known diabetes, was very much correlated with the heart complications of the patients. Libre is not for use on dehydrated, hypotensive, or in shock hyperglycemic in hyperosmolar state, with or without ketosis, neonates, critically ill patients, or for diagnosis or screening diabetes. In early April 2020, the Food and Drug Administration did not object to the use of CGM devices in the inpatient setting in response to the COVID-19 pandemic. Thus, Abbott and Dexcom offered to supply hospitals with CGM systems to help monitor glucose levels remotely and help hospital clients learn how to use these systems. The appropriate implementation of CGM may help decrease the burden of inpatient diabetes care. Thus, we have come to a remote patient monitoring area, and that works nowadays. You have the patient and you have the recording of their blood pressure, the AKG, the SpO2, the temperature, plus the glucose value. So you get them all in a control, and this is transferred to the devices, to the smartphones, and then from there, the doctor can get the information, even if he's on the other side of the United States. If this happens here, he can get the results there immediately, and he can immediately respond by phone, mail, or SMS to correct the values. It is important to see that blood glucose monitoring, blood glucose values have been incorporated in the monitors, which shows that glucose becomes the fifth vital sign of our patients. The COVID-19 crisis has brought to light a number of challenges and opportunities regarding the management of our patients. We are faced with the opportunity to adapt digital technologies to follow up our patients and to improve the quality and reduce the costs of healthcare services, and perhaps even to improve access to healthcare while increasing the burden of medical visits. So through digital technology, we can restrict the risk of COVID-19 infection from patient to patient, from patient to caregiver, which is very important for this pandemic. It increases the efficiency of diabetes care. It decreases the waiting lists in the clinics, giving the priority only to those with urgent needs. Moreover, we were limited in the number of patients that we were allowed to see in the outpatient clinic. That helps a lot to follow up the already known patients by telemedicine, and it increases the productivity of the patients because it decreases the time they spend to come to the clinics and wait in the waiting list. But since glucose levels upon admission is related to the severity of COVID-19 infection, we have to prevent hyperglycemia. We have to prevent hyperglycemia by improving glycemic control of our patients through telemedicine consultation, along with what we have to teach them to keep distances, wash their hands, wear their mask, and keep up on their medication on pressure and lipids. So prevention means that we have to keep blood glucoses between 72 and 144 milligram per DL, hemoglobin A1C below 7%, time in range above 70%. We have to keep up with blood pressure control and lipid control. And mind you, we have to take care of the hydration of our patients because fever and diarrhea are early COVID symptoms. Real-time CGM has been used in the community during the lockdown, and there are several studies looking at real-time CGM in the community. I'm going to show this one because it has the more data of all, and this is a study done in 3 different areas in the US, in Illinois, Los Angeles, and New York, and you can see the people who were monitored by CGM or followed up by CGM, they had more time in range in all areas, and lower blood glucose levels in all areas of the US. This is a study done in people with type 1 diabetes in Italy. The study shows that during the lockdown of COVID-19, young patients with type 1 had improved glucose control indicated by increased time in range, reduced glucose variability, and reduced hyperglycemia and severe hypoglycemia. These findings are somewhat unexpected, considering that because of lockdown at home, patients had no access to outpatient diabetes clinics, although interacting with their diabetes team by teleconsult. CGM cloud platforms provide new metrics of glucose control, including glycemic variability, which is important for our patients. Remote application and use of real-time continuous glucose monitoring has been used also in type 2 diabetes in a virtual diabetes clinic. It is feasible to remotely prescribe and mail real-time CGM devices to people with type 2, and for participants to successfully insert sensors and use real-time CGM without in-office training. CGM was well received by the patients, who reported high satisfaction with real-time CGM as an educational tool that positively influenced their perception of diabetes self-management. The use of real-time CGM was associated with a significant improvement in hemoglobin A1C at 10 months in those not meeting the ADA treatment target, independent of insulin use. So the highest the hemoglobin A1C before, the lowest was after using CGM remote counseling. Thus, the benefits of telemedicine diabetes care is that it limits face-to-face exposure, provides personal connection with the patients, allows for data monitoring and review, allows for treatment adjustments, presents an opportunity for more patient education, and gives patients more control over their disease. The challenge, though, of telemedicine diabetes care is obtaining current data is not always possible. Patients may struggle with technology, not possible to conduct physical examination to our patients. Patients are responsible for reporting to us their weight and blood pressure. Support staff is not easily integrated into care, and primary clinician is responsible for more things. How to overcome these challenges? Support the staff to call the patients in advance for clinical appointments to help with data download. Help the patients use their device, upload data, use the phone, tablet, computer to virtual appointments. Visual appointments can be used for additional education to the patients, and utilize technology to review data, titrate insulin, or make other medication changes. Your role will include sharing information between patients, families, and doctors, so your ability to communicate effectively will be the key for better diabetes control. And yes, we can do it. Thank you very much for your attention.
Thank you, Professor Asmina, for your nice lecture. Yes, Dr. Asad.
Yeah, thank you, Professor Asmina. It is really very nice topic, and hopefully we can day by day succeed to control the sugar and help our patients to keep the sugar in the control. And now we are looking for the questions over here. Yeah. So I will start with my question. Professor Asmina, do you using Libri with the what we call it, this one, the new generation or the old generation?
It's the old generation, so it's not very helpful in inpatient situations. Usually the people who already wear the Libre, we keep them on Libre during hospitalization, but only in people who are conscious and they can sweep their telephone over the sensor. Otherwise, if they are unconscious, we cannot use it anymore.
Yeah, because there is one, they call it a Miu card reader, and some of my patients, they can give the feedback directly to the even parents sometimes, which
Oh,
can...
we don't have that yet. We don't have that yet,
yes.
Dr. Assad. We have Menarini and actually we only have Menarini and Medtronic in Greece.
You're right. It's really, the topic is important because we know that I have pregnant ladies and we try to control their sugar within normal range, and hardly we control it without CGM or even actual, I mean, whether insulin pump or CGM, which is very important to look for the parameters.
Well, it was amazing during the COVID period when the patients were put on cortisone. It was so easy to control them. I mean, the doctors had to go home at night because they were burned out, and they were following the patient on cortisone from home. It was amazing, and we achieved pretty good. Yes, we didn't have at least values above 250.
You're right. You can access the data, and then you can talk with your patient remotely.
Yeah, yeah.
I see that. Thank you very much. And by this,
I appreciate
there is
it.
no more questions. Then we are really thankful for you, and we will have a break for 15 minutes.
Thank you very much, Dr.
Thank you
Assad.
very much,
Congratulations to all of you.
Thank you.
Μπορείς να ξέρουμε όμως θα σας πω για την Βουτσινά.
Good afternoon, ladies and gentlemen. Thank you back for the IMDO conference, surgical and obesity surgery part. This session will be chaired by Dr. Amr Darazi and Dr. Ali Al-Hamadani. And now I can just present Dr. Amr Darazi. Dr. Amr is the consultant pediatric surgery in Salmania Hospital, and he's working currently as a private section in Middle East Hospital. He's well known in Bahrain in doing research and conducting surgery for pediatric patients. He's the chairman of emergency unit in Salmania Medical Hospital. Dr. Amr Darazi also is very interested in obesity, but beside that, he's doing a lot of on-call surgery. So, Dr. Amr, floor for you to introduce Dr. Ali and to chair this session.
Thank you, Dr. Asad, and the organizing committee and Mr. Abdul Wahab for having me again in this conference. I mean, right now, I started marking my calendar each year for this conference. It's becoming part of my yearly ritual. And it's always good to see my colleague, Dr. Ali. We always meet in this month in this conference. I hope we meet some other time as well. It gives me great pleasure to introduce Dr. Ali Al-Hamadani, who is a consultant bariatric surgeon from London for the last 13 years. He has performed more than 3,500 bariatric and revisional procedures and holds an MD in molecular biology from the University of Wales. He's well published with more than 300 publications and presentations in national and international conferences, and is considered one of the leaders of international teaching fellowships in association with Oxford University and international bariatric societies. With this, the floor is all yours.
Thank you, Dr. Amir, for that. That's very kind of you. Can you hear me clearly?
Yes, Doctor, loud and clear.
Perfect. Thanks a lot for that. So I'm just going to maybe share my screen now. So give me 1 second. Share screen. Can you all see my screen, please?
Yes, yes, Doctor. Just keep it in slideshow, please, format.
Yeah. Give me 1 second as well. Yeah. Thanks again, organizing committee. It is lovely to be with you again. It's as I said, I put it in my now yearly calendar, waiting for that day. Even it's virtual, but it's lovely to see you all. It's my pleasure and honor to present here. So many thanks for giving me this chance and to present here again. So thanks a lot. So I'm gonna start. Obesity, is it patient's fault? I think I maybe should ask for hand raise. Who should think this is a patient's fault? I'm sure majority might say yes. Anyway, so I work in these places in London, thank you. And this is my case mix. I do about 20% revisions and about 80% primary procedures. Now, this is a bit of a controversial slide. Is the benefit of obesity surgery. We always know about the risks of obesity, but is anyone benefiting from obesity surgery? Is anyone benefiting from the point of having this common view? Obesity is the life choice. It's a patient fault. Well, yes, there are people actually who are benefiting from that. The food industry, for example, it's only growing within the current few years because of that. The gym industry, the diet and gym industry, is only present over the past 60, 70 years. Before that, it was not present. What about the pharmaceutical industry? Well, I'll give you an example. The statin sold all over the world, and it cost 30 billion only per year to sell the statin. Don't forget, with these type of massive spending, these organizations actually have a massive power to publish in favor of their products. This may be a bit difficult now because of the scrutiny in publication, but this was very easy over the past 60, 70 years ago to say about, to promote their publications. And give you another example is, I mean, we all know that fat is bad for you, but who said that? Who said this fat is bad for us? We know that recently one of the most common diets, which is becoming very well known worldwide, is the keto diet, which is mainly based on fat. So that's what I'm saying. There's a strong lobby to promote obesity worldwide. Obesity in UK, and you can see that actually the trend is only increasing in the 4 countries in the UK, Scotland, Wales, and Northern Ireland and England. For example, Scotland, it was about 23% the adult obese in 2003, and now it's about 29-30%. And that's the same rhythm in all the 4 countries in the UK. What do patients say? So that's exactly what the patients say. The patients say, I can lose the weight, but I cannot maintain it. I think I have a very slow metabolism. That's what my patient says to me. I think it's all in my genes. I have tried many diets, but they don't work. And I gain weight always after each diet. I mean, the question is, do we listen to our patients? I think obesity is a multifactorial reason between psychological factors, social factors, and biological factors. I'm not going to go into details for each of one, but I'm just going to maybe give 1 or 2 examples of these causes. How do they work together? So biologically, this paper showed that there's about 100 genes responsible for obesity. These genes had effect on controlling appetite, people appetite, behavioral, have effect on the people interest in certain type of food, even have ability to change when the patient is fully full and or not. Even these genes have effect on the emotional eating. Now, this study shows, it's a very interesting study, is the effect of ghrelin hormone which is the hunger hormone. So this line here, if you can see my arrow, this is the middle line. It shows that patients' ghrelin hormone after each meal. And you see that the ghrelin hormone increases before breakfast, and when patient eats breakfast, it decreases down. Similar in lunch, it increases and decreases after eating, and increases before dinner because the patient is hungry, and then decreases afterwards. Now, not surprisingly, this is the last one, is the effect after gastric bypass, and you can see it's very low down. But the most interesting part in this actually figure, if you see the top line, this actually patient who are on diet, and you can see is the highest. So the ghrelin hormone is highest for the patients who take the diet. And now if you go back to my previous slide saying what the patient is saying, they're saying actually they feel more hungry after each diet. And this explains why they, for example, they feel hungry. And maybe the best way to explain more about biological factor is to maybe see this. How can we actually exactly explain how the best way to decrease to treat obesity works, which is maybe one of the operations, gastric bypass. So how does the gastric bypass work? What is the gastric bypass? So maybe there are different forms of gastric bypasses, but the most common one is the Roman Y. And it's called Roux-en-Y because the Roux is the surgeon who did the operation in Switzerland who put the name there. And then the Y configuration of the small bowel, which I'm going to explain in a second. So what we do with the bypass? We separate the stomach into small parts. So top small part there, the pouch, and the remaining big part. And the bottom, we separate these completely away. And then we connect the top small part of the stomach directly with the bowel, with the small bowel. And then we create this Y configuration. So you have an alimentary limb, which is carry the food, going to be mixing with the biliopancreatic limb, which is containing the bile, to form the common limb, where actually the food is mixed with the bile, where the absorption is start. And the way I explain to the patient how this works is, I said it's a combination of restriction and malabsorption. That's what we usually tell to our patients worldwide, not only with me. So restriction, because it's a small stomach, so therefore there's a restriction. And then we say also malabsorption, because we're going to bypass the stomach and part of the small bowel there. There was no mixing of the food with the secretions, and therefore there will be some malabsorption. That's what I say to my patients. But actually, after the operation, on day 1, we stop the insulin because the glucose level goes back to normal. Day 1 after the bypass. So at day 1, there's still no restriction. There's still there's no malabsorption. The patient had not lost any weight. So why do we stop? Why this all hormonal changes happen? Why do diabetes cure on day 1 after surgery? That's the question. There is no malabsorption. There is no restriction. So how exactly does this work? And maybe simply to say, maybe until now we don't know. There's only theories behind that. So I'm going to give you maybe 1 or 2 theories about it. So one of the theories is the effect of bile acids. So what I have done in this operation, which is the Lero group in Northern Ireland, what they did here, this is a rat. And what they did here, they disconnect the bile duct from its common origin in the duodenum, and they reinsert it down in near the distal ileum. They change nothing in the anatomy of the patient. They still have the rat. The rat, they still have the normal stomach, the normal small bowel, no change in that at all. Only they change the insertion of the common bile duct. And what that make, the mix between the bile acids and the food will gonna be less, and the level of the bile acid in the blood will be high because it's going to be quickly absorbed from the distal ileum. As we know, the bile is absorbed in the distal ileum. And then they feed these 2 types of rat, the one who had the operation and the other one who does not have the operation. And they found that the rats who did not have the operation, the weight is obviously increases, and the rat who had the operation, their weight does not increase, just by changing the bile acid concentration in the blood. And look into that further. What does the bile acid do if it's increasing concentration in the blood? It causes decrease in the glycogen synthesis. It will cause increase in the glycogen synthesis, so decrease in the glucose synthesis, sorry. So less glucose, more glycogen, more protein. That's its direct effect on the liver. Now, it also, on the same time, has a direct effect on the L cells in the intestine, in the small bowel. And what that cells does is increase the production of GLP-1, which is actually promote production of insulin. And if you remember from type 2 diabetes, the main reason for the type 2 diabetes is the decreased sensitivity of the cells towards the insulin by increasing by the increasing of the glucose level. And this exactly by increasing the bile acid, it will destroy this method. It will increase the glycogen, decrease the glucose, increase the protein. Just the effect of bile acids. Another method is that, another theory, sorry, that is the effect of the bacteria of the small bowel. And what this study shows that in the 12 months where the patient has lose the maximum amount of weight after the bypass, the consistency of the bacteria inside the small bowel is completely different. And during these 12 months where the patient loses the maximum amount of weight. And this changes back to normal after 12 months. And after that, the weight stabilizes. The patient does not lose weight anymore. It only loses weight where these 12 months in these 12 months where the bacteria changes in the small bowel. And hence, there's a new treatment now going for to induce weight loss. For example, patient given certain type of yogurt with certain bacteria in them, and the other patients given even bile acids, try the effect of bile acids. And again, that just gives us the idea that this is not a patient-induced phenomena. It's a disease, and therefore these treatments are. And you can also see that over the past 10 years that the idea of obesity surgery as a name of obesity has changed into something called metabolic syndrome. And even that name, that's actually a better name to describe obesity. But even that name, and still now we call it syndrome. We don't call it specific other name. We call it obesity, we call it metabolic syndrome, because until now we don't know the actual causes for it. But this is just the three most recent theories about how this exactly the bypass work and how can we explain obesity on this concept. Fine. Few maybe points to say about the other factors, which is the social factors. Stress can reduce the activity on the prefrontal cortex, and that's responsible for patients' behavior. It makes more likely that people will eat more even when they're not hungry, and that's what we call compulsive behavior in psychology. What about psychological factors? I think the common view that obesity is a patient fault is not only at the individual levels. So, and not only between lay people, you can even see it between doctors. My colleagues told me that obesity, of course, it's patient faults. Of course, it depends on the patient choices. So this common view is not only at the individual level, but actually at the group level, also at the organization level. And this creates certain type of bias and discrimination against this category of patients. And it's created this, what I call it, the circle of shame. The patient feels guilty, he feels he's a failure, there's depression, there's low self-esteem, there's poor body image, even suicidal thoughts. And we can see, for example, in children, they stop going to the schools because they just don't want to show their body image to their colleagues. They prefer sitting at house and eating because that will soothe the effect. And again, weight will increase, more discrimination, and so on. So this is the effect of the psychology, and maybe it will give us the idea of how to understand this globally, how to try to find a solution for that. So we definitely have to understand that this common concept of making the patient as his fault, this is the reason for the patient fault. This is a common concept. We have to understand that these patients have tried different diets and they always fail. They reach a stage that actually their weight now, after they try different diets, is much, much higher than they start. It's really double the amount of weight, of the normal weight. And it's become so difficult for them to go back to where they are. So become unachievable, become difficult, become impossible for them. And therefore, the treatment should be multidisciplinary. So we should address all these factors. And therefore, the treatment should be, again, following the multi-hit hypothesis. So we have to treat all these factors together, not only one. For example, psychologically, find the reason for stress. Is it family? Is it job? Is it finance? Try to address that. Give the patient a new startup point. There's different techniques like mindful eatings. For example, taking a deep breath, use the energy to do something else instead of going for food, going for shopping, for example. That's maybe not very good for husbands. Eat with the family. Because then you're going to force the self to cook something instead of buying from a junk food or from a junk food shops. Physically, we have literally to control the insulin cycle, the cortisol cycle, and maintain the muscle mass. So what I meant by controlling the insulin, we can have 3 meals a day. That's not the problem. I mean, we said everyone knows about the full English breakfast. That's fine, but it should not be with bread. It should not be with sugar. Have 3 healthy meals. Lunch with meats and fresh fruits and vegetables. Cortisol, how to control that? Sleeping well, that's really important. Maintain the muscle mass by doing the 90 minutes of exercise every day. it's not a heavy exercise. The point is to maintain the muscle mass. The point is not to build the muscle mass. So to conclude, obesity is not a patient fault. Obesity is a disease and it's a consequence of a combination of biological, social, and psychological factors. And the way to treat it is to follow the multi-hit hypothesis, is to treat all the causes that actually can result in obesity. And thanks a lot for listening. Thank you, guys.
Thank you, Dr. Ali, for this insightful presentation. I love your philosophy. I mean, I do agree with you. I mean, obesity is not the patient's fault. It is a chronic disease as defined by most of the societies right now. However, not doing something about obesity is the patient's fault. Patients need to do something about it. So not doing something about it is their fault.
Good idea. Good idea. I think maybe all of us need to do something about it. I mean, again,
absolutely. I mean, at least they should look for help. I mean, you alluded to the circle of shame. Yes. I mean, once you go into the circle, fine. Maybe you cannot do something about it alone, but you should seek help from your family, your spouses, or medical care practitioners.
Yeah.
And I think one of the research shows that I don't remember the exact figure, but it's less than 20% of GPs talk to their obese patients about their weight problems. I mean, if you see these GPs, once they see an obese patient come in for headache, they will just treat the headache. They will not talk about the root cause, which is the obesity, and ask them control their weight in order to prevent.
Yes, totally agree. Totally agree. I mean, I just had a patient. I'm in the clinic. I'm sitting in my clinic now, and I just had a patient actually who came to me now, and she's literally in tears. Her body mass, not her weight, her body mass index is 90, and she just been attacked by even doctors telling her when she walks in the hospital, what is that? Why you're overweight? So you can just sympathize with her, really. You know, apart from giving her the treatment, you can just sympathize with her. Her BMI is 90.
Thank you, Dr. Ali, for your nice presentation, and nice to meet you virtually again. I have a question, if you will, Dr. Amr, allow me.
Yeah, go ahead. Sorry, I disconnected from my side. Go ahead, Dr. Asad.
Okay, Dr. Ali, you know that multidisciplinary team is practicing in every hospital. So basically, it's the problem in the private section. Sometimes you cannot get the team to deal with the cases in a proper way. Maybe some colleagues, like they try to gather, as I think Dr. Amr, we discussed last week committee meeting, they can just have a network of a team. So in a private section in UK, do you have a network of multidisciplinary team in a private sector, or you have only on NHS?
Thank you. Really important subject. Really important question. Habib Dixaris. I really appreciate that. It's my private practice is a photocopy of my NHS practice. So I do all the steps exactly. I have a full MDT in my private practice. So I have a psychologist, I have a dietitian, and I have obviously the anesthetist is also involved in the high risk cases. And we also have an access to gastroenterologist, endocrinologist, if we want and cardiologist, and respiratory physician, if you want their help. So we have exactly the same access as and privately as in NHS. And I think this is really a must, because you cannot cut corners. The result will be bad. The surgery is not the tool. The surgery is only part of the solution. And if the patient is not 100% addressing the surgery with its all other aspect, the failure rate would be very high, and you don't want that to happen, really.
I think I second what you said, Dr. Ali, and I think we have a great example here in Bahrain. I mean, a lot of people say, "Oh, we have people that did sleeves elsewhere in other countries, neighboring countries, and came back and they regained their weight." The reason being is that when they go to these countries or to these hospitals, there are hospitals that have multidisciplinary teams, but then there are commercial hospitals in which the patient goes in, have the surgery, second day they kick him back to his own country, and they come here without any plan of diet or follow-up, etc., etc., and they end up regaining weight. And we have a massive number of patients of this sort, and this highlights the whole issue with multidisciplinary team and preparing these patients before doing the surgery. And I totally agree. Surgery, I mean, it just helps. It's not the main tool. I mean, it's a catalyst. It helps, but I mean, there needs to be other solutions to the problem.
I totally agree. Totally agree. I mean, literally for the last 6 weeks, I have literally 4 patients coming from outside the UK with massive complications. They just have surgery and just come to the UK with complications. So literally one of them arrived at Heathrow Airport. She had the surgery on Wednesday. On Friday, so after 2 days, she didn't even stay in that country. She went back to UK, and from Heathrow Airport, she came to my hospital with a big complication. So I think this medical tourism, I understand there are advantage of it, which was financially, at least for the patients, but it have to be governed by rules, at least by the IFSO or by the local bariatric regional bariatric center in that place. It cannot just be done without governance, really, because it's really unacceptable for the patients to come that sick in the plane after 2 days from the surgery. I totally support you as well with this.
Dr. Asad, do you have any other questions or any questions from the audience?
I don't think there is more questions, but I have one question for Dr. Ali again. So basically, it is really very fast and short question. Is the way you deal with the patient directly? You meet the patient, or you send him earlier with the GP to discuss earlier? Because usually pediatric surgeon, they are very busy schedule. So the first visit will be with the GP, and then they schedule appointment for you, or it will be referred from endocrinologist or others, or he can come directly to the pediatric surgeon.
He can't come directly. He can't come directly to us, obviously, but we have the tier management services in UK. So tier 1 is social. So tier 1 is the social help, like diet, exercise, or whichever. Tier 2 is the GP, we've taken after his care. Tier 3, we have something called multidisciplinary care, medical multidisciplinary care, and tier 4 is the surgery in the UK. So we have these 3 tiers in the UK. So patients should pass from tier 1 to tier 2 to tier 3 to tier 4. However, as you rightly said, I have patients coming straight forward to tier 4, which is the surgery. And at that stage, we implement the MDT meeting. So the MDT meeting comes and say, okay, this patient is missing, for example, respiratory assessment. So he go back one step backwards to the medical MDT to have his respiratory assessment and his CPAP, and then he come back to us and so on. So this is roughly the management in the UK. It's not as that clear, optimal, but it's usually should be under that pathway, let's say.
Okay, thank you. I think now Dr. Amr, he will present. Yes.
So I present Dr. Amr. He's,
yes, okay. Yeah.
He's a lovely colleague of mine. I know him from Bahrain, at least for the last 4 years now, since I started to attend the IMDO conference. He's a consultant general bariatric and advanced laparoscopic surgeon. He works in Slimania Medical Complex Center. He graduated from University of Alexandria, Egypt, and he's got clinical fellowship in general surgery at McMaster University in Canada. So plenty of an experience on board, and I cannot recommend him enough. And I cannot wait to listen to his talk. So please, all yours.
Thank you very much. Thank you very much, my friend. Okay, can you guys see my presentation?
Yes, yes.
All right, so I'm going to have a talk today about metabolic surgery. I'm going to talk a bit about the evolution and efficacy of metabolic surgery. So it's not just bariatric, but we're going to focus a bit more closely on surgery to treat diabetes. So these are my disclosures, nothing disclosed except being speaker in some of these companies' events and being a member in their advisory boards. First of all, this is the agenda. We're going to talk about the evolution, as I said, and the effects these surgeries have on type 2 diabetes, how safe they are, and just a fast word about the types of surgeries available. So, in order to understand where we are, this is just a fast recap on the surgeries that are out there right now. Roy gastric surgery is the gold standard. Sleeve gastrectomy was the new kid on the block. Some other surgeries came later. Bands were used in the 2000s, and then we abandoned them. And finally, the PPD, which is the most active procedure. So bariatric surgery has been there since the 50s. I mean, every decade there is some sort of an evolution. We started with intestinal bypasses, open gastric bypasses, gastroplasties, and then towards the end of the decade, the end of the century, we started doing laparoscopic surgeries, started with the bypasses, sleeves, and now we're moving away to non-surgical treatments. So this is bariatric surgery. Where did metabolic surgery, when did it come into the picture? Well, this is the paper that started it all. Basically in the year 95, this paper by Forrest addressed the issue of glycemic control after bariatric surgery. What they did is that they were doing a paper on their experience in bariatric surgery, and they noticed that people with type 2 diabetes, after undergoing their bariatric surgery, their need for hypoglycemic agents reduced or stopped in some instances. And that's when they started to wonder what's going on and what can these surgeries do to diabetes. Of course, this was there since the 95. However, the major explosion started of metabolic surgery started in the mid 2000s and started to gain momentum in 2010 with a lot of societies adopting this type of surgery. So, in short, I remind you that we started with doing bariatric surgery to make people thinner. Initially, the aim was they're very fat, let's make them thinner. Then we noticed that making them thinner improves their life, the quality of their life. They get rid of some of a lot of their comorbidities. They feel better about themselves. Less stigma, as Dr. Ali mentioned earlier, so they feel better about themselves, they get outgoing. Then we noticed that these surgeries actually improve the longevity of these patients. So obesity increases the mortality, morbid obesity increases the mortality of these patients. And when we do surgery, they live longer. And finally, we started noticing the effect on diabetes. So the way I think about it is that diabetes and obesity are like pieces in a puzzle, and they both fit in that same area. There is a huge overlap between these two conditions, and this is where we can actually focus our treatments. So what's the difference between a pure bariatric procedure and a pure metabolic procedure? Well, bariatric procedure can be performed for somebody without diabetes, in which the BMI is high. Then we have the overlap. We're talking about BMIs of between 35 to 40 with comorbidities and diabetes. So here we can call it bariatric or metabolic surgery. And then we have the pure metabolic surgery. And here we're talking about patients that are not obese, but are suffering from type 2 diabetes. So the aim of doing this type of surgery is not to make them lose weight, but treat or actually induce remission. The right word is induce remission in their type 2 diabetes. So how does it work? How do these surgeries work? Well, this is basically from my friend Carl Leroux. This is an article he published in Nature, in the journal Nature. So basically, they discussed Roux-en-Y gastric bypass in specific and how it actually improved the glycemic control. So basically, when we do gastric bypasses, we are creating a small gastric pouch, which increases the gastric emptying. So basically, any food that's ingested will move all the way into the jejunum. And this, in turn, will increase into the ileum, I apologize. And this, in turn, will increase a number of hormones, GLP-1, PYY, and it will induce changes in bile acid, the changes that my colleague talked about earlier. Moreover, it will alter the microbiota, the microbiome theory that we talked about earlier. So this is the first step. Second step, basically, what will happen is these hormones will start acting on the pancreas, and it will increase the insulin release. Moreover, the weight loss will, especially in the early part, will reduce glucose output from the liver. Finally, these hormones will affect adipose tissues. So in the white adipose tissue, there will be reduction in the pro-inflammatory condition. And in the brown adipose tissues, there will be increase in the diet-induced thermogenesis. All these put together will improve the glycemic control and in turn affect the brain, which will reduce food intake and food reward and increases energy expenditure. So in short, just to highlight the time frame of these events happening, again, from early to initially what happens in the early days, as Dr. Ali said, we stop insulin from the first day until what happens later. So the first thing is the energy restriction reduces the hepatic glucose production. After a while, the effect on the hormones that I talked about and the pancreas happens in the intermediate phase. And the final phase is when the actual weight loss happens, and this happens later after months. Here, improvement in the peripheral tissue sensitivity occurs. So when do we do metabolic surgery? I mean, metabolic surgery is recommended almost in all bariatric surgery guidelines, international ones, whether European or North Americans. And again, as I said, we talk about above 35 the obesity with comorbidities, or above 30 with pure diabetes, with type 2 diabetes that's not controlled. And this is a schematic on what I said. So who is candidate for metabolic surgery? I mean, we should consider metabolic surgery for patients that met the previous criteria, and they should have an acceptable risk-benefit ratio. Again, I echo that these patients are morbidly obese, a lot of them. They have a lot of comorbidities. So these comorbidities need to be assessed by the multidisciplinary team and to make sure that surgery or anesthesia will not pose risk on them. They need to have a good cardiovascular reserve status. Keep in mind that baseline BMI does not predict the success of metabolic surgery. A lot of people used to think that the heavier a patient is, the more likely that they will get rid of their diabetes when they lose weight. This was simply just not true. When we do metabolic surgery, I mean, and this is an issue that we still do not agree on. There is a lot of debate on this. When we do metabolic surgery to treat diabetes, what would be our measure of success? Will it be, is it going to be the weight loss, actual weight loss? So if somebody loses all their weight, but the control on their diabetes is not so great, is it a successful surgery or not? Or be it the resolution of diabetes. So if we do metabolic surgery and the patient, the diabetes resolves, but the patient did not lose as much weight, is that successful or not? We still don't agree. There are others that actually talk about a more comprehensive evaluation of a patient's global health and the improvement of all the other risk factors. So, I mean, we as bariatric surgeons, we need to come together to talk about what constitutes a good result or what is success in metabolic surgery. Even the cutoff points of HbA1c. Some people talk about 7, others talk about 6.5, others talk about 5. They think that needs to be more stringent than the normal. So even the level of HbA1c that constitutes success, we're still debating what is the best cutoff point. One of the things that we need to do is we know that not every patient with type 2 diabetes will improve after metabolic surgery. So prior to embarking on performing these surgeries, we need to do some sort of scoring. There are a lot of scoring schemes out there. The diagram scoring scheme is one of the best. We have also the ABC, which is developed by one of my dear friends and colleagues, Dr. Luigi. So with this scoring system, we look at the age, HbA1c level, what the patient's taking when it comes to diabetic medications, and if they're taking insulin or not. And we give them, according to the different variables, we assess them a number, and then we add all these numbers. So a total of 22. So the smaller the number, the higher the chance of type 2 diabetes remission after surgery. And as we see, the higher the number, the risk drops. So what is the effect on type 2 diabetes if we do these surgeries? First of all, we look at the weight loss. I mean, this is from the SOS study, the Swedish obese study, which looked at patients over 20 years. And it demonstrated unequivocally that surgery drops the weight when compared to diet and exercise. Some surgeries actually are more effective than the others. What about type 2 diabetes? This is a compilation of a number of observational studies that looked into diabetes resolution. They looked into a maximum of 10 years. So if you can see with time, for the individual studies, at 2 years, the percent of resolution of type 2 diabetes varies between 70 to 92%, which is still very good. But we can see with time, it drops a little bit. So it drops to around 30 to 40% after 10 years, which again, you're talking about 10 years of no oral glycemics and then restarting them gradually. I still think it's a win. Then came the landmark study by Felshauer, the Stampede trial. So the Stampede trial was basically randomized people into intensive medical treatment, gastric bypass, and sleeve gastrectomy. And it unequivocally demonstrated that even after 5 years, surgery reduced the HbA1c level more than intensive medical treatment. So the superiority of surgery was demonstrated by this trial. A number of other trials looked into the same matter, and this is a meta-analysis basically by Robino that looked into 11 trials that compared surgery, metabolic surgery versus intensive medical treatment. And it clearly shows that surgery is favored, and it's a very high odds ratio, one of the highest I've seen actually. What I like about this is that if you can see, they divided the studies into patients with less than 35 BMI and more than 35 BMI. And as you can see, the results are the same. So this goes to the point that I said earlier, that the BMI does not predict the amount of type 2 diabetes remission. So the result of this meta-analysis that metabolic surgery was associated with greater weight loss, higher remission rates of type 2 diabetes, higher remission rate of metabolic syndrome, better lipid profiles, improved quality of life, and substantial reduction in medication requirements. Hence comes the DSS, which is the Diabetes Surgery Summit, and this will be referenced in every single guideline out there. So DSS Summit compiled of 48 international clinicians and societies. I mean, they're on the right side. Some of them are from the Gulf region. Most of them were non-surgeons, and they looked at the evidence regarding metabolic surgery. And they ended up putting the recommendation that I will show you later. But they basically came up with this graphs to show that surgery in general drops HbA1c by 2 points in average, while medical lifestyle doesn't, or intensive medical treatment. The individual studies, some of them showed that the changes are up to 4 points of HbA1c. So this was the recommendation of the DSS, which is the same slide I showed you earlier. This was the first time that we talked about metabolic surgery for people with between 25 to 30 BMI with inadequate glycemic control. We should consider them for surgery. So we know that surgery drops glucose level, but what about complications of diabetes? These are complications that happen years and years later. What are they affected or not? So these are a number of studies looked into that. And again, this is the same population. It's the SOS, Swedish Obese Subject Study. So here, patients were for 20 years. So these are obese patients compared to their counterparts that underwent surgery. And as you can see, here we're looking at microvascular complication. There is a vast difference, which becomes apparent almost 10 years down the road. Vast difference in the incidence of nephropathy, retinopathy, and what else is there? Neuropathy, yes. Another study published in the JAMA that looked into a combination of micro and macrovascular complications. Still, we can see a difference between the two groups. Surgery is much favored, and it definitely reduces these complications. The same paper, when they divided the microvascular and macrovascular complications, we can see that the difference in the microvascular complications on the left side is apparent from year 4, whereas the macrovascular complications start to become apparent at 15 years down the road. Macrovascular complications, we're talking about diabetic foots, cardiac problems, and brain problems. This is another study that looked into the microvascular complications, and here they looked into the individual ones. So here in this graph, we see all microvascular vascular complications put together, a definite difference. Neuropathy, yes, there is also a difference in the incidence of neuropathy. Surgery improves it. And then here we look, nephropathy and retinopathy. Same result with this paper, but the reason I love this paper is twofold. Number one, they segregated, this is the overall microvascular complication, and then you can see that the retinopathy is the commonest complication of all these micro complications. That's one thing. The other thing I love about this paper is that it demonstrated something called the legacy effect of surgery. Remember what we said earlier, that surgery, initially 2 years after surgery, almost between 70 to 90% of diabetics will have remission, and this number will drop by year 5, which means that some people will have their diabetes recur. So the question was, when these patients have their diabetes recur, does that mean that the protective effect on their micro and macro vascular complication disappeared? This paper answered it, and it showed that there is a definite protective effect that continues even after the recurrence of the diabetes. So even if we induce remission for as little as 3 to 5 years, the long-term protective effect on micro and macro vascular complication persists. And this is very important. What about the effect on mortality risk? Again, there is a definite reduction in mortality by doing these surgeries. If these patients continue to be obese, they have a high risk of mortality. Doing surgery reduces their relative risk of death by 89%. So obese subjects, in the SOS study, for example, the obese subjects that did not have surgery had a 6.1% chance of death, compared to less than 1% in those that had surgery. So how safe is surgery? This is a question that I have every day from my patients coming to my clinic. Doctor, are we going to die from the surgery? The newspapers have been, especially in our part of the world, have been notorious by putting all these complications, patients dying. Yes, there may be 1 or 2 patients that die, but keep in mind, there are tens of thousands of patients undergoing this type of surgery. So 2 out of 10,000 is nothing. Yet people don't understand this. All they care about is the 1 or 2 that die. So let me just highlight that there has been a number of longitudinal assessment studies in the US They looked into databases of hundreds of thousands of patients. They estimated that the risk of mortality in Roux-en-Y's, for example, is less than 1%. Again, another study of 85,000 patients that undergone bariatric surgery, less than 1% mortality, less than 0.5% actually. What this study did is that they looked into their database of all types of surgery for diabetics, and they calculated the mortality risk. And they, the complication. Here, before we were talking about mortality, now we're talking about complication rates. So they compared the different type of surgeries, the complication rates in diabetics. And as you can see, gap cabbage was the highest, knee arthroplasty, and then you see the Roux-en-Y gastric bypass in the bottom at 3%. Bypasses had less complications than lap choles, than lap appendectomies, which are one of the commonest surgeries performed in the world. Same thing. So I'm not going to go in detail in this unless somebody has a question, because this is mainly for surgeons. I mean, how we prepare patients. There are two types of bariatric surgeries. We have the restrictive procedures, and we have the malabsorptive or combined procedures. An example for restrictive procedures are gastric bandings and sleeve gastrectomies. Examples for restrictive and combined procedures and malabsorptive procedures are gastric bypasses and duodenal switch. The only thing I want to emphasize is that combined restrictive and malabsorptive procedures have the better metabolic profile. So if somebody was to do metabolic surgery and they're interested in the highest chance of remission of type 2 diabetes, they have to go for this group. We talked about the different types. Just schematics about sleeve gastrectomy. We remove almost 3/4 of the stomach. You're patients left with a small part. So restriction plus reduction in ghrelin hormone causes weight loss. Roux-en-Y, my colleague Dr. Ali talked about it earlier. New kid in the block from the bypass group is the single anastomosis gastric bypass, MGB, and then duodenal switch and statins. As we can see from left to right, the complexity of the operation increases. So does the effect on comorbidities. So the least effect on diabetes is in the last laparoscopic gastric band, and the most is by the PBD and SADIs. But that comes at the expense of side effects as well, because the least side effects is in the laparoscopic gastric band, and the highest side effects and complication is with the PPD. Just a fast talk about complications before I end my talk. I mean, keep in mind, these surgeries there is no surgery without complications. These surgeries are notorious. We're talking about risks of leaks, 1 to 2%, bleedings, which can be intraluminal or extraluminal. The #1 cause of death after these surgeries is DVT and PE. It's rare to happen, but that's what kills these patients. They're morbidly obese, and they have a very high risk of DVT. That's why we give them anticoagulation. Nutritional deficiencies is prevalent, especially in the malabsorptive procedures. That's why we need to follow these patients up with regular blood checks. Dumping syndromes, ulcers, and gallstone disease. Almost 1/3 of patients that undergo bariatric surgery and have massive weight loss will end up with gallstones that may need, and they need to have lab coats. Some of the nutritional deficiencies, I mean, I'm pretty sure Nagam will talk about it in her talk. So in short, this is what I would like to leave you with. Metabolic surgery should now be considered with adults, even for those with lower BMIs, with type 2 diabetes. Metabolic surgery provides the following benefits. They give significant reduction in long-term mortality risk. It aids in remission of type 2 diabetes. And it definitely lowers the overall incidence of microvascular and macrovascular disease, complications of diabetes. Planning of metabolic surgery requires careful assessment of the functional status for these patients. Thank you, and I'll leave you with this beautiful slide that I found. And again, it talks about the mechanism of how these surgeries prevent diabetes. And the floor is open for questions.
Thank you. Very, very nice presentation as always, Dr. Amir. Really nice. Perfect, excellent. So maybe a quick comment and maybe a questions after that. So for the metabolic surgery, obviously this is the new concept, and the new surgery is called metabolic surgery. The new weight loss surgery, let's say, is called metabolic surgery. One of the studies shows that actually by doing the metabolic surgery, patients gain 10 years of their life back.
Absolutely. It's actually, the studies show that it was in bariatric surgery, actually, bariatric patients. So it was, not all of them were diabetics. It showed that patients in average gained 8 years. The effect of longevity was different between males and females. It was more pronounced in males. And the mechanism by which this happens is preventing the cardiovascular complication and preventing the micro and macrovascular complications that I talked about in diabetes that I talked about.
That's absolutely right. So maybe the question is, Dr. Amir, is in UK, we're still having difficulty in actually offering metabolic surgery as such. Maybe part of the reason is funding, because the NHS is already inundated with waiting lists, specifically with the current COVID. Our waiting list in the normal bariatric surgery is more than 2 years. But from the metabolic surgery in Bahrain, what is the cutoff point, the lowest cutoff point for the BMI? What is the lowest BMI you've done patients with BMI? Sure. With metabolic surgery? And is there any specific guidelines for metabolic surgery in Bahrain yet, or what's the plan for that?
So basically, we have a national bariatric surgery guidelines, and within that guideline, there is a section about metabolic surgery. So currently, for metabolic surgery, we consider as low as BMI of 30. So between 30 to 35, with uncontrolled, with poor glycemic control, we can consider these patients for metabolic surgery. Above 35, even if they have good glycemic control, we can consider them for metabolic surgery. We started metabolic surgery a few years back. Our colleagues in Eastern Asia, Dr. Weiji and in Japan, Takiso and Mufti in India started the concept 10 years ago, and they go as low as a BMI of 27. However, in Bahrain, our guidelines are a minimum of BMI of 30.
Thank you.
And before embarking, I mean, again, it goes back to what Dr. Asad was saying. We need our endocrinologist to be on board. And it's actually the endocrinologist that makes the recommendation, not the surgeon. So the endocrinologist will try to control the diabetes. And if they feel that the glycemic control is poor and these patients are able for complications, then they refer them to us and then we embark on the surgery.
الحين ما ادري والله. الحين 55.
Just one thing, Dr. Ali, regarding NIH funding for these surgeries. I think you guys need to start doing cost-effective studies, because if you do the cost-effectiveness study for an obese patient that's not diabetic versus an obese patient that's diabetic, the return of investment for the insurance companies is much better for the diabetics. On average, they get their money's worth within a year and a half to 2 years for diabetic patients versus 3 years to up to 4 years in non-diabetic patients. So it's more cost effective for the payer to fund these surgeries for metabolic surgeries, because they're going to save on the medications and treating the complications, which I've shown you that you're going to save, you're going to have less amputations for diabetic foots after 10 years. You're going to have less cabbages to do because of diabetes after 10 years, less lasers, less retinopathies to deal with after 5 to 10 years. So from a payer's perspective, you just need to show them that it's cost effective. Somebody needs to do that study, and I'm pretty sure at one point they will tell you that they will cover only surgeries for diabetics. And that's what happened in Dubai. In Dubai right now, the local insurance favors doing these surgeries for diabetics over non-diabetics.
Yes, amazing.
I think Dr. Amr, if you can introduce Dr. Or Dr. Ali.
Sorry, there are two questions. There are two questions.
Two questions.
Okay. Dr. Amr, you can see the questions?
There were questions, sorry.
If you want me to read it for you.
What should a GP do in the treatment and management of obesity? Well, the role of the GP is, number one, to advise these obese patients to lose weight. I mean, again, we do not jump into surgery right away. There needs to be trials of lifestyle modification, changes in diet, maybe trying some medical treatments. There are a number of medications out there now. There is raliglutide, there is semaglutide, other medications that are out there. I mean, this all goes into the realm of GP. Once the GP recognizes that these modalities are not working, then they should refer to a bariatric surgeon. I think that's the role of the GP, and probably after bariatric surgery, because these patients will not follow with the surgeon for all their life. They go back to their GP. The GP should have a working idea about the complications that can happen and how to screen and do regular blood work for these patients. I hope that answered the question. So there is a question, how to treat relapse of weight or diabetes after sleeve gastrectomy. So weight regain or relapse of diabetes after sleeve gastrectomy is multifactorial. What I would say is that the patient needs to be re-evaluated by the multidisciplinary team all over again. Hormones need to be checked, gastroscopy and contrast study performed. A dietitian needs to review the dietary habits of the patient. It may be a problem with the food he's eating or he or she is eating, maybe a hormonal problem. It may be a technical problem in the surgery. So each scenario will involve a different treatment modality. But it's fair to say that a fair chunk of these patients will require revisional surgery. Any other questions?
I think no more questions.
All right, I think I'll introduce the next speaker. I mean, I think Dr. Hani does not need an introduction. He's my colleague and brother. We've worked hand in hand in Salmonia for the longest time since our residencies. Currently, he's a consultant surgical oncologist and laparoscopic HBB surgeon in the Bahrain Specialist Hospital. Extremely highly specialized in general laparoscopic surgeries. He does extreme complex surgeries that even I do not know how to. This is the new generation, and inshallah, a bright future for Dr. Hani. Dr. Hani, floor is all yours.
Thank you, Dr. Amr. Thank you, ladies and gentlemen, for giving me opportunity to give this talk today. Hope you can help me through how to share my screen. Okay, which I would do now. And all right. Am I shared now? All right. So,
yes, doctor.
So I will talk today about the bariatric surgery as selection and concept of better outcome. So I would like to talk about the bariatric surgery and bariatric and metabolic surgeries, our group of operations for weight loss that include combination of volume restriction, intestinal and hormonal alteration, and nutrient, how we can say malabsorptive procedure that effectively can cause satiety, malabsorption, and increase the insulin sensitivity to achieve good glycemic control and sustainable weight loss. So bariatric surgery is more effective than conventional therapy for control of obesity, and it's associated with comorbidities. Bariatric surgery is more effective than a non-surgical treatment for obesity as well, with a reduction in overall mortality of 30%. So different types of bariatric operations or surgeries are successful in resolving those comorbidities like diabetes, as you know, hypertension, and dyslipidemia. So what are the cornerstones for a good selection for better outcome and the best results? So we depend on multi-factors, which BMI can play a role, comorbidities, and any previous weight loss attempts. So here it's very important to know how we would select our candidates. Based on BMI more than 40, they would be a surgically bariatric surgery candidates. Our BMI about 35, and one of obesity-related comorbidities or complications like type 2 diabetes, uncontrolled, or people with high risk to develop type 2 diabetes, or uncontrolled hypertension, NASH, which is non-alcohol steatohepatitis, which eventually can cause liver cirrhosis, patients with obstructive sleep apnea, osteoarthrosis or osteoarthritis, and urinary incontinence. However, we have to be aware of enemies of bariatric surgery, those which are contraindications, and maybe there is no absolute contraindication, but some of those cases are relatively contraindicated and certain behavior disorders. In collection, as first stage, can help us how to delineate the pathway for better outcomes. So we start with candidate selection. Then, after finishing a stage of candidate selection, then we have to shift to a stage of multidisciplinary team interaction and evaluation for a selected candidates. Those patients, they should go through a thorough psychological assessment, dietitian review to see any the eating behavioral disorders as well, eating disorders, compliance with the diets. They should go through a good endocrine assessment, like assessing of the thyroid function test, serum cortisol, like adrenal function, to see other cofactors which could lead to increase weight or preclude a weight loss after bariatric surgery. And then a thorough medical assessment, and of course, at the end, the anesthesia, which plays an important role of how the patient would go through the OR for safe anesthesia. So after that, we're gonna assess here, or we're gonna pass, and we establish a physical fitness, psychological fitness for such a procedure, and assess the compliance of those patients post-op. Then classically, as many other surgeries, we would evaluate the perioperative risks and versus the benefit, and what would be the post-operative risks and how we would deal with them. We finish that stage of evaluation, then we go for matching. I think this is my talk today. So what would be the best procedure for the best candidate? Is it a sleeve gastrectomy? Is it type of bypasses, either Roux-en-Y gastric bypass or mini gastric bypass, which is single anastomosis bypass? The answer of this question is really not clear. But however, on the practical point of view, we could triage the patient for the better theoretically outcome. For instance, a patient with a transplant who develops, patient with transplant who depends mainly on anti-rejection medication, I would not indicate an absorptive or malabsorptive procedure for that patient. In other hand, a patient, for example, with a connective tissue disease who would take a non-steroidal for a long time or maybe steroids, I would prefer not to have an excluded stomach like in the bypass. I would go for a single stomach which would be a sleeve gastrectomy here. In some areas, for example, high prevalences of gastric carcinomas, say in Japan or northern Iran or in Oman as well, which is a neighborhood here, the prevalence of gastric cancer is high. So those patients, you would not like to have them to have an excluded stomach, rather than you would like them to have a single luminous stomach for surveillance, for checkup, and etc. So I would not go for bypass procedure. There are many other factors which plays here. The other factors is the patient volume eater or sweet eater. Does he have any diabetes? Is he a high BMI or just average candidate BMI, like a class 1? Or is he from those big BMIs which they need a mainly, I would say, restrictive and malabsorptive procedure? So what are the common procedures which is very popular in the bariatric world? I would say laparoscopic sleeve gastrectomy, laparoscopic Roux-en-Y gastric bypass, or a laparoscopic mini bypass, which is a one anastomosis or single anastomosis gastric bypass. The other procedure which is less commonly done nowadays are the adjustable band or the one type of the biliopancreatic diversions like scopineuron, etc. So let's concentrate I would talk about the restrictive malabsorptive procedure like Roux-en-Y gastric bypass or one anastomosis gastric bypass, and comparing that to the sleeve gastrectomy, which are two popular procedures in our region. So basically, with the gastric bypass, we don't resect anything. We don't take out anything. The only thing which we do, we're going to rearrange things in an effective way to have a better weight loss, and we would have better sensitivity or less resistant to insulin. Yeah. So in gastric bypass, we create a small pouch which would not accommodate more than 30 to 50 ml of the stomach, and we relieve back there a silent, how we can say, a stomach. And here we bypass it by the jejunum about 150 to 160 the raw limb, with the biliopancreatic limb which comes from jejunum around 50. So in collection we would like to bypass around 2 meters of absorptive surface. So here what we are achieving, 3 factors. Factor 1, we have a small pouch. Factor 2, we are bypassing less absorptive surface, which about 2 meters. Factor 3, which is the less ghrelin or inhibited ghrelin. Yeah. So let's see the weight loss mechanism in a Roux-en-Y gastric bypass. Sorry, I have dogs at home. I cannot control it. So gastric pouch, it's primarily it's a restrictive operation. We have a small pouch to accommodate the food intake. The gastrojejunostomy plays important role in damping physiology, which causes the unpleasant symptoms. So when we take a high sugar, so the patient would avoid taking a high sugar. That's a complication, but it is really our side effect, I would say, it, which is more preferable for this procedure for those category of patients. So raw limb also, we have longer raw limb, so we have increased malabsorptive surface. So what happens on the metabolic point of view and the hormonal changes? The ghrelin is released, of course, because the fundus of the stomach is kind of excluded. The peptide YY, which is increased, and that can cause loss of appetite, and also the GLP-1 and CK, that which induce the anorexia. So overall, excess weight loss, we talk about a 70% in the 2 years. However, in sleeve gastrectomy, in comparison, it's a single step through which we take off or resect 75 to 80% of the stomach. However, that is really very subjective, where we use this through a calibration tube, which will tell us roughly we are excluding 75 or 80%. The important point here, we resect the fundus, which is a releasant of the ghrelin. So the patient, after release of the fundus, the less hunger, less desire to eat. That's why we don't have theoretical conflict of the desire to eat or with inability to eat. So patients with a sleeve gastrectomy, when they, not that they only have a small pouch, which is restrictive. So also they don't have here higher the brain, the desire to eat as well. So there is no conflict between the brain and the wellness or patient wish to eat. So what's happened here? It is a restrictive procedure. Of course, it has a small pouch. The ghrelin here decreased because we removed the fundus. GLP-1 and PYY increased, and promotes a less hunger. That's also how we can say the insulin resistant will get less or improves. Yeah, so that gives us roughly and approximately 60% excess weight loss in 2 years. So again, back to the same question. What is the best surgery? There is no best procedure. No gold standard operation would tell us a certain BMI you should go for bypass or sleeve, or you go for mini gastric bypass. And there is no a certain criteria of saying a class of obesity, you would go for this, not for that. There is no a certain of medical condition you would really absolutely contraindicate patient just to go to that or indicate to go to other procedure. So patients should be well matched to a specific procedure, and that's a rule of the pre-bariatric assessment and counseling with the patient. So here, as what we do in oncology surgery, we individualize the goal of therapy, also individualize goals of therapy or aim of therapy with the bariatric patients is very important. So it's not only about weight loss, it's also about the obesity related comorbidities or complications. Then something which plays an important role here, the local regional expertise of doing certain procedure, not doing the other one, or doing that procedure, how to deal with the complication of the certain procedure. So it's very important for a surgeon or an expertise which the patient should go for. He should know how to deal not only with the treatment selection, also how to deal with the complication of those selected procedures. So here we talk about the personalized risk stratification and how we prioritize the safety first over everything. So then we talk about at the end of the preferences of the certain surgeon and experience with for example, bypass or sleeve, and his comfort zone to do such procedure. Important factors to keep in mind and to consider that very important for us is the patient has any psychological elements or dietary behavioral eating disorder. That is important to keep in mind. The general medical, past medical surgical histories. For instance, for example, a patient with a multiple previous abdominal operation, and you expect as a surgeon he may develop adhesions, so he may be a good candidate theoretically for malabsorptive, restrictive malabsorptive procedure like bypass or mini bypass, but that would not be a best choice for a patient who would have adhesions. So you can predict the adhesions after manipulating with the intestine and doing the dearrangement of anastomosis of the small bowel and the stomach. So you would go for that patient to do a sleeve gastrectomy and to avoid to touch, for example, the small intestine. For example, this is just an example. A patient with inflammatory bowel disease, you don't want to mess with the small bowel, for example, in Crohn's disease. However, mess with or dealing with the stomach is acceptable. However, it has its own complication and own points, but it is less burden than doing rearrangement things with the small intestine. Then a patient comfort and expectation. We experience a lot of patient attending to our clinics, and they ask for a certain procedure in the back of their mind, which they think I would go for, this is easier, it's my comfort. For example, they will ask me, doctor, I would like to do a sleeve gastrectomy, and they are pre-determined and how we can say decided before thinking about the best option for them. So that we call it patient comfort. So that's why it's important to evaluate what is the patient expectation and have a proper counseling and tell the patient this procedure might not be the best for you. This procedure can lead, for example, to severe reflux, and it will worsen your gastroesophageal reflux. Or this procedure will not be suitable for you because you're on certain medication, and we would like to make sure those medication are getting good absorption and effective in your body. So this is important. If you explain to the patient, so you can, how we can say, tune his predetermined decision. Then other thing is ability of medical facilities to handle such a procedure. There are some common procedure that some centers they can handle. For example, they are very capable to and very experienced to deal with sleeve or bypass or mini bypass. There are some centers are not maybe comfortable to accommodate, for example, bypasses. So these are important to see. So certain procedures like the scopinaros, or we can say like a longitudinal switch, those are less commonly done procedures. Maybe the center is not well familiar or have a good experience to that to handle it. So it's important to select also a procedure from your procedure menu where your center can and your team can deal with it effectively. So then we talk about the effectiveness or cost effectiveness. As we know, bypasses, either Ron-Y or mini bypasses, or maybe are considered one of the costliest procedure. But however, at the long run, they are really cost-effective intervention comparing to long-term medical treatment for weight reduction or diabetes and hypertension. So here's just some factors we have to just highlight here, comparing sleeve versus gastric bypass, a never-ending story between the battle between two procedures. So sleeve gastrectomy for patients who are, for example, smokers or chronically tobacco user, would be preferable comparing to the bypasses, either mini or raw and wide gastric bypass. As I mentioned earlier, patients with a long-term of non-steroidal medication, NSAIDs, you would like to have this patient to have one stomach, not two stomachs. So when complications happen, there is no excluded stomach that you cannot deal with. Other thing, is the patient a volume eater or a sweet eater? Of course, if the patient is a sweet eater, it's not a best choice to have a sleeve gastrectomy. Maybe it's a good for a short term. However, for a longer term, the patient, they may come with a weight regain issues and will ask for a different sustainable procedure and sustainable procedure, like maybe he will ask you to do gastric bypass. So if the patient is volume eater and not really from those high volumes, I like to lose more weight, less weight, I would go for a sleeve gastrectomy. However, I expect the patient I need to lose more, I would combine the absorptive or malabsorptive and restrictive procedure like one of the bypasses. As I mentioned earlier, patient with a geographic mess, which means that the patient had multiple abdominal surgeries in the past, and you expect the patient would have a kind of stickiness adhesions, you would go just to deal with the stomach, not to deal with the small intestine to avoid the complications. And sometimes with the sleeve, you'd like to do a quick procedure for a patient who had a major surgical intervention, cannot tolerate a longer procedure. So you would consider sleeve gastrectomy. Or patient with transplant, you don't want to do any malabsorptive procedure for that because of effectiveness of medication. So sometimes we say, why male patients are better with a sleeve than female patients? It's all about the physical activities. Male patients, they tend to have better physical activity after those procedures. So the physical activity will enhance the results of or outcome of sleeve gastrectomy comparing to the bypasses. The ladies, they who has less physical activities, the absorptive part of the procedure can take care of sustaining the weight loss. So talking about gastric bypass, of course, I'm talking about the Roux-en-Y gastric bypass. That would be a good treatment option for those patients who have GRD, gastroesophageal reflux, which will resolve their symptoms. In comparison, patient who would have a sleeve gastrectomy, that will keep them in higher risk of having GRD. Previous surgeries for redo surgery, or we can say the revision operations or revision surgeries, like gastric banding, adjustable band, or sleeve gastrectomies in the past. One of those bypasses, either Roux-en-Y or mini bypass, would be a good option. Then I talk about the sweet eater with high carb consumers. They would be a good candidate for bypass. Diabetes, the gastric bypass has an excellent and very good sustainable remission of diabetes. That's supported also with maintenance of a good weight loss beyond the 2 to 3 years. So when we talk about the sleeve, I just wanted to share.
We are running short of time.
All right, okay. Yeah, I will. Okay, then maybe I pass the video for sleeve. I wanted to just conclude that a sleeve is basically how we do it using those stapler ones, and then we go and however we'll go to the next slide. when we talk about the gastric bypass, we create a small pouch. As you can see here, we create a small pouch and we do the anastomosis small bowel. Sorry, I may just pass it. We just basically, we bring, I said around 150 of a small biliopancreatic limb, the 50 centimeter of biliopancreatic limb and 150 of raw limb, and that the rest would be the rest of the intestine will be the common channel. Estimating that human has 6 meters, if we bypass 2 meters, the rest, the 4 meters can give a good care of weight loss with minimal complication. So then we do small bowel anastomosis, and that's it. Okay, I'm going to bypass the operation. Maybe may not interest our colleagues. Some of them are not surgeons. Nothing special. That's a regular bypass surgery. Every bariatric surgeon should know how to do. So let's talk about. Am I good on time? Just
I think if we can give the people just a couple more questions because time's up. If we can give them time. If you have any points to make, last points.
Yeah. Any questions, audience?
I think there was a question from the audience regarding gastric bypass. Is there a risk of weight returning as before after gastric bypass?
Yeah, okay. When we talk about weight regain, okay, as you hear you, Dr. Ahmed, talking, it's multifactorial, as we know. There are chances of weight regain, but comparing to sleeve gastrectomy, that would be less. If we talk about around 5 to 7% of weight regain in sleeve gastrectomy within 2 years, or talking about 15% of those sectors of population over the 5 years in the sleeve gastrectomy, comparing the gastric bypass as less weight regain, but there are risks of weight regain and multifactorials. Some of them are because of technical issues, like the restrictive part of the malabsorptive procedure is gone, like we have wide anastomosis or the anastomosis widened, or we have something which we call it candy cane, a small part of the small bowel, which is anastomosed to the pouch, has created a little stomach. That would be one of the other reason. The other reason, if we have a fistula between the pouch and the remnant stomach, that also can contribute in weight regain in gastric bypass. In a sleeve gastrectomy, the regain causes are could be first. The first selection is not the best. Maybe the patient is a sweet eater, and we did for him only a restrictive procedure, so he takes low volume but high calories, and that can contribute. Remnant of the fundus, as I mentioned in the sleeve gastrectomy, we have to take out the whole fundus to avoid the ghrelin or decrease the ghrelin release, so that the hunger is less. Those patients, they have a feel of hunger, they start to eat. Other question?
Currently, there isn't. I mean, I agree with your points that you mentioned earlier, that these surgeries need to be tailored according to the need of the patient, and there isn't such thing as anyone walking through the door gets sleeve, or anyone walking through the door gets bypass. What's your opinion regarding bariatric surgeons who can only perform one type of surgery?
Oh, well, I have an opinion, a strong opinion about that. You know, bariatric surgeon, by definition, and Dr. Amir knows and very well, he should be a surgeon who is capable not only to deal with a variable of bariatric procedures, also should be capable to deal with complications of variable procedures. Yeah, so I believe a bariatric surgeon who does a sleeve bypass and mini bypass would also the patient would do revisional surgeries and can deal with complications of those procedures, because bariatric surgeon, he may receive patients from anywhere in the world, and any patient which has done even less commonly known procedure, which I explained here or showed here. So yes, that's my strong opinion. Bariatric surgery should deal with all, should have available options.
Absolutely, absolutely. And I mean, part of this goes to the point that you made earlier. Sometimes patients come asking for a specific type of surgery. Commonly, it's always sleeve. The reason is that they went for other surgeons and they scared them scared the daylight out of them from bypass. And the surgeon does not tell the patient that he cannot do the bypass. He just scares them.
Yes.
You will die. You will have high complications. The blah blah blah. So I mean, we really need to start educating patients that when they go and look for surgeons, they need to go to the right surgeon, somebody who does the whole spectrum, somebody who's trained in these surgeries, versus going to a surgeon that started doing sleeves because he likes doing that.
Absolutely. I would also emphasize that sleeve gastrectomy is not an easy procedure, as some surgeons, they trade it, and not to go to bypass, go to sleeve. Sleeve gastrectomy, I would say it's really a sensitive procedure. There are a lot of measurements there, architectural measurements also, the size, the volume, and the angles, avoiding rotations, avoiding the spiral. It's not an easy procedure. It's not just go and cut it as a drawn in the diagrams. Yes, as you know, Dr. Amar, they think a sleeve is easy procedure. That's why they promote the patient.
It's marketed as the easy procedure.
It's not.
But in reality, you and me know, because we're taking bariatric surgery calls. The majority of cases that present to emergency are post-sleeve.
Yes.
Thank you. Thank you, Dr. Hani and Dr. Amr, Dr. Ali. Really, it is interesting session, and it's very informative. I think because of time, we should shift to the second session. Thank you for all of you for your participation. This session will be chaired by Dr. Sayed Rada and Dr. Barbara McCown. Dr. Sayed Rada is a consultant cardiologist, head of Department of Medicine in Awali Hospital, Kingdom of Bahrain. He's regional coordinator for medical education, Royal College of Physicians of Edinburgh, and he is external examiner, Arabian Gulf Medical University, peer review author for various international medical journals, has published research and scientific work in various reputed journals. Dr. Sayed.
Thank you.
Thank you. Good evening, everyone. First of all, thank you very much, Dr. Sat, for the very kind introduction, although I didn't need it. I have here my moderator. I would like to welcome her here as well, Professor Barbara McGowan. And I know it's a long day. It's probably the last session we are having this evening. So without further ado, I would like to invite the first speaker, Dr. Richard Quinton. Again, Dr. Richard Quinton perhaps does not require any formal introduction. By now, you know who Dr. Richard Quinton is, but it's my duty to just say a few words about him before he starts to speak. Unfortunately, I cannot read very well, but let me tilt his. So Dr. Richard Quinton is basically a consultant and senior lecturer in endocrinology, Royal Victoria Infirmary, University of Newcastle upon Tyne. He is the regional specialty advisor for the UK Northern Deanery. He has been awarded the Nobel Prize by the University of Cambridge for his MD thesis on hypogonadotrophic hypogonadism, which remains his principal area of research interest. So the screen is yours, Dr. Richard, whenever you're ready. Thank you.
Many thanks for the very kind introduction. And share. So can you all see the screen now?
Yes.
Okay, so let me just
If you can put it on slide mode.
Yes, I'll do a slide mode now. Yeah.
Thank you.
Okay. So many thanks. I've been asked to talk about testosterone, diabetes, and COVID-19 fatality in men. I have to say there's not going to be a huge amount about diabetes, but it will be mentioned. So I'll start with this slide. This was the British Medical Journal, I think in November 2020, and these were the first UK doctors who died of COVID-19. Now, for different people, different figures jump out at us. For Dr. Barbara and for me, Alpha Sadhu jumps out at us because we used to work with him. For some people, what's really striking is out of these 33 doctors, there's only 2 white British, both of them obviously clearly older, both male as well. The other way to look at it is actually, that's Alpha Sadhu, only 2 women, although 2 is still too many. And that's something that has been obvious throughout the beginning of the pandemic. So at the beginning of the pandemic, Italy was thrown into chaos, but actually their statistical data was impeccable. Just that the Anglosphere was basically too arrogant to look at it. But with a number of colleagues, I did look at the data from the Italian government website, and we tried to get it interested in a journal, but there was absolutely no interest. But essentially, you can see how the relative risk of fatality for males is around 3-fold that of the risk for females of the same age band. And NHS mortality data that came out slightly later was similar. So the first 45,000 deaths, 2/3 are in men. The mortality in patients aged under 85 years was 50 per 100,000 in men versus 25 per 100,000 in women. So that seems to be doubled. However, over 85 years, which is of course the most vulnerable group with the highest mortality, men only make up 30% of the population because they don't live as long as women. And so therefore, in that group, female deaths necessarily predominated. However, proportionally, men still died at a far greater rate. So if you look at under 85 years of age, men comprise around 3/4 of all deaths. In relation to diabetes and COVID-19 fatality, there is a very strong association, but actually when you feed it into multivariate analysis, it just disappears completely. And that's because it's lost amidst the effect of obesity. So obesity seems to be the main risk factor. If obesity has made you diabetic, that doesn't seem to increase your risk of fatality. So what do animal models tell us about this vulnerability in men? So actually animal models we always reach for animal models, but actually they're peculiarly uninformative because actually SARS-CoV-2 was right from the outset, when it first emerged in Wuhan, was perfectly adapted to infect human cells. And there is still no putative close ancestor in the animal world, whichever species it infects. However, looking at a rather more distantly related SARS-CoV variant, an older one, so male mice had a worse disease and higher fatality than female mice. They had a higher viral load, more pulmonary vascular permeability, more alveolar and more inflammatory monocytes and macrophages in their lungs. So male mice were more prone to ARDS in this SARS kind of COVID type virus that not totally similar and was certainly not ancestral to COVID-19. So in relation to the sex ratio, so what was the UK government's risk assessment for healthcare staff done early in the pandemic? So remember, we've established that this is a condition that predominantly kills older men. And so what risk assessments were performed in the UK NHS in relation to its staff early on? Well, this is it. They decided that even though there's absolutely no evidence for this, that they would send home women who are pregnant for more than 28 weeks and remove them from direct contact with patients. Those who are less than 3 weeks pregnant will continue to work in patient-facing roles. And this was done by the College of Obstetricians and Gynecologists and Pediatrics. And so this is truly bizarre. We have a condition which predominantly puts older male staff at risk, such as me at the time, and I was pretty scared. And the risk assessment was, let's send the young girls home. Bitter? Yes, I'm still bitter about that. So there are a number of theories regarding the excess male fatality, and they're all basically 3 variants of what I would call blame the dead. So men smoke more and take less care of their cardiometabolic health than women. Men have worse personal hygiene. And this marvelous one that was aired on Irish state television, men are always touching their faces. Now, clearly, we do know that some men touch their faces, having put their hands in rather odd places. And some of you may remember these distressing images from the Euro 2016 football, where the German manager is clearly putting his hands in unspeakable places and giving them a good sniff. But I think he's the exception rather than the rule. I hope so. I don't think he's representative of us males. And another thought, more logical, it's something to do with the immune regulating genes on the pseudo-autosomal region of the X chromosome, the genes that escape X inactivation. And finally, could it be something to do with testosterone? And so could testosterone promote infection? And yes, there are some data to support that possibility. So the spike proteins utilize a transmembrane protease serine 2, TMPRSS2, for entry into host cells. And if you add testosterone to culture media, you actually increase expression of that serine protease in human lung adenocarcinoma-derived cell line. And if you shut down testosterone secretion by means of androgen deprivation therapy, long-acting GnRH analog, as used in the prostate cancer, that lowers expression of the serine protease. And at the time, it seemed there was an impression that men with prostate cancer on androgen deprivation therapy seemed to have perhaps a lower fatality, but this was preliminary data and certainly no RCTs. But certainly, testosterone-bound androgen receptors are transcription promoters for that serine protease, and they could thus facilitate SARS-CoV-2 entry into cells. And so we see the pattern here. Androgen receptor binds testosterone, activates the androgen receptor, promotes transcription, the serine protease. This then primes the SARS-CoV-2 spike protein. These then bind to the ACE2 receptor, which then allows entry into the host cell. So there's a plausible mechanism there. And so one question arises, well, should we lower testosterone levels in sick men infected with COVID-19? And when you think about it, one of the treatments, the first treatment shown to have a benefit, dexamethasone, we know that high-dose steroids at Cushingoid levels will certainly suppress GnRH-mediated testosterone secretion. And so could that be part of its mechanisms as a testosterone lowering, not just as a anti-inflammatory, and perhaps could you achieve the same result with GnRH analog androgen deprivation therapy? Another way to look at it, actually, could testosterone promote survival? So older men have got lower serum testosterone levels, albeit the effect is largely mediated by correspondingly greater burden of comorbidities, including obesity, and the kind of like what I would call the testosteronistas in the endocrine community would say, no, we need to give testosterone. These men are falling over because testosterone is lower because they're older, because they're obese. Nothing like a theory that you can't prove or disprove. But certainly we do know that low serum testosterone levels in older men are associated with a low-grade pro-inflammatory state, and the testosterone treatment of older men with low serum testosterone lowers the pro-inflammatory footprint, particularly at IL-6 levels. And we know that both low testosterone and higher IL-6 levels are associated with more severe disease and worse outcomes in a number of viral respiratory infections, and that's hospitalization, progression to ARDS, and fatality, including influenza and COVID-19. And so another process should be offering testosterone instead of testosterone blockade to sick older men infected with COVID-19. So this is an impress from Jeff Hackett. And Jeff Hackett has skin in the game. So Jeff Hackett, urologist in Birmingham, great promoter of testosterone, certainly rather more than me, fell shockingly ill with COVID. It's a miracle that he was very close to death. And it so happens that the physician looking after him was endocrinologist Ramachandran, with whom he'd published. And just really before Jeff lost consciousness, he said, Rama, check my T level. If it's low, fill me up with libido. Please do it for me, old friend. And Rama did it. And Jeff survived, and whether there's any connection at all, we've no idea. But certainly, Jeff believes that this is what saved his life. This was a study which they had in press, looking at the relationship between survival and testosterone levels. And interestingly, what you see is that clearly all these men had low testosterone levels. So 3.9 nanomole per liter, that's maybe 100 in old units, American units. And so the difference between having testosterone above 4 or above and testosterone less than 4 seems to make a big difference to whether you survived. But of course, it's hard to know what's cause and effect, because clearly the sicker you are for any reason, the lower your testosterone level is going to be, because that's part of non-gonadal illness. So potentially testosterone here is just a marker, a reverse acute phase reactant.
أطرش لك اللينك مال في اليوم كونفرنس IMDO. أطرش لك إياه يمكن يفتح معاك بدون يعني أنا واحد سجلني registration.
Okay, so I think I probably show this slide in all my presentations, but this was the science bit showing really how the Candida neurons in the medial basal hypothalamus integrate internal and external homeostatic signals, and then drive as its slave the GnRH neurons in the medial basal hypothalamus, which then drive the pituitary gonadal axis. And we can see how inflammatory cytokines, steroids can suppress that axis. So, and again, when we talk about male hypogonadism, I just wanted to specify what we're talking about. So in primary, it's like the test is not working. This is like the light bulb is broken. And in secondary, this is the lack of LH deficit stimulation, which is the light switch is turned off. And really all the studies looking at COVID-19 suggest that if there is low testosterone, it's because the light switch is turned off. And of course, it might be true hypogonadism, but it might also be the non-specific effect of illness. So another theory is, well, it's not testosterone, it's the estrogen, stupid. A number of studies showing that postmenopausal women not taking HRT had higher fertility rate than those who were taking HRT or those who remained postmenopausal into their 50s. So maybe actually it's the fact it's not that testosterone is bad or good for you, it's that estrogen is really good for you, and men generally lack it. Although actually obese men tend to have slightly higher estrogen levels, but anyhow, it doesn't totally fit. And also postmenopausal women have higher levels of pro-inflammatory cytokines such as IL-1, IL-6, and TNF-alpha. And estradiol treatment lowers these to premenopausal levels, as does testosterone treatment in men. And then going back to that mouse study, looking at the related COVID virus, in fact, female mice that had been overectomized or been treated with the estrogen receptor blocker, tamoxifen, did just as badly as male mice. So the animal model, it's the absence of estrogen rather than the presence or absence of testosterone that is what increased the risks of ARDS and fatality. And then the final theory, I think, is actually, no, it's not testosterone, it's the overall state of androgenicity. And androgenicity is more complicated than just testosterone level. So testosterone binds the levels are partly mediated by availability by binding to SHB in the circulation, but also how does it act? It binds the androgen receptor, and thereby, especially after metabolism into the hydrotestosterone, promotes a cascade of processes that result in clinical features that define androgenicity. Now, actually, the androgen receptor gene on the X chromosome encodes a highly polymorphic polyQ tract at its end terminus, normally ranging from 9 to 36 CAG repeats. And the longer the more repeats you have, the longer the tract, the less effective is the androgen receptor, and therefore the lower androgenicity. So either a lower testosterone level, or you having an androgen receptor with a large number of CAG repeats, that leads, either of those can lead to lower levels of androgenicity. And the polyQ repeat size varies amongst different populations. So Africans have the shortest, so Caucasians, and I think Middle Easterners in the middle, and the longest in the Han Chinese. And so, interesting study coming out of the Lancet Biomedicine from Italy. Actually, a lot of the studies in this area have come out of Italy. So they they looked at infected patients, and they looked at the antigen genotypes of the most severely affected patients compared to those who were kind of asymptomatic or oligosymptomatic. And certainly males, the longer your polyQ tract, the less effective your androgen receptor, the more severe disease you had. And also, there was also an association with testosterone levels, which I'll come into because it's slightly complicated. So having longer AR alleles was associated with worse clinical outcomes compared to having shorter alleles. There was greater inflammation and higher CRP levels. Interestingly, if you had a longer allele, so a less effective androgen receptor, actually you did have higher serum testosterone levels due to reduced negative feedback on pituitary LH secretion. But overall, you had lower overall androgenicity due to kind of blunting of that central axis by non-gonadal illness. And so this also helps to disentangle issues raised by the reports of better COVID-19 outcomes in prostate cancer patients on ADT, because of course prostate cancer patients tend to have shorter polyQ repeats of their androgen receptor. So testosterone and long COVID, again, Italian study. This is from San Raffaele in Milan. And these were 121 consecutive men who'd recovered from laboratory confirmed COVID-19. And they found that hypogonadism, what I might call non-gonadal illness, low testosterone levels, was ubiquitous during acute illness. And although levels increased over time in men who'd recovered, over 50% steroid levels under 300 picomole per liter, 9.2 nanomole per liter at 7 months. And 10% of them actually dropped the levels even further over this time. But of course, low testosterone was strongly associated with intensity of comorbidities. And of course, again, it's hard to discern cause and effect. So just some final thoughts. So it's unfortunate that the respiratory infectiology kind of axis, which reigns supreme in this area, has shown very, very little interest in COVID-19 hormone trials. They failed to consider vitamin D. The only reason I think that they did studies on dexamethasone is I think they forgot they were steroid hormones. They just thought, oh, it's anti-inflammatory. It must do some good. And I think this is the problem. Like a too small group of decision makers at the top with inadequate experience across medicine led to a too narrow consideration of what treatments might be useful. When you think how many billions of pounds have been wasted doing trials of antiviral drugs, simply because that's just what comes first to infectious disease specialists, and these largely failed in this area. So antigen data, I would say they have inadequate proofs of principle to justify inflicting medical castration in men with severe COVID-19, particularly if you've got very severe COVID-19, you're going to auto-castrate yourself in a sense by shutting down pituitary-driven testosterone secretion. So however, sex hormone treatment in both men and women does merit evaluation. But in European men, at least, it should probably be more cleverly targeted in those with the longer androgen receptor alleles, 23 or more CAG repeats. And actually, we assume that a hormone is there to treat a deficiency syndrome. It isn't always there. Sometimes a hormone is used to treat a non-deficiency syndrome. And one of these would be, we use dexamethasone not just for COVID-19, but for lots of inflammatory conditions. And we use fludrocortisone not just to treat adrenal insufficiency, we also use fludrocortisone to treat older people with orthostatic hypotension. And similarly, the T4DM study that I mentioned in my original talk, where actually many of the men involved in this study to try and reduce diabetes with testosterone, many of the men were not hypergonadal at all. And so this is a template. Remember, we know that hormones treat deficiency, and you don't need randomized studies for that. We do need randomized control studies is for hormones to treat patients who aren't deficient in that hormone. So a great many thanks for your attention, and many thanks for allowing me also to share the fears and anxieties that I really had early on in the pandemic, as I feared, honestly, being put into the front line whilst my younger pregnant female colleagues were just sent to work at home.
Thank you, Richard.
Thank you very much, Richard. That was wonderful. And just let me check if there is any question or questions in the chat box. I don't see any at the moment.
There is one question in the chat.
Yes, there's one question in the box, please. Yes.
Yeah.
Okay, just let me see where it is. Can you read it, Barbara, if you can?
Yes, I can read it for you.
Please,
so, dear Dr. Richard, can any vaccines have an effect on testosterone levels, short-term side effect or long-term side effects?
I don't think anybody's looked. However, the only hormone that's been looked at in relation to vaccines actually is vitamin D. And there's an ongoing study to look and see if being vitamin D replete makes the vaccine more effective in you. In terms of testosterone, I would imagine that the more of a vaccine reaction that you have, if you do have one, then that will result in a short-term lowering of testosterone level. But that's an assumption. It's not based on any data.
Thank you, Richard. Can I ask a question? I mean, I think there's not enough evidence. You've shown some of the evidence, but in your own thoughts, what is your feeling? Do you really think that testosterone does actually play a role? Do we need clinical trials to really prove that it can have an effect on outcomes, do you think? Do we have enough evidence out there on the whole? Because I'm not convinced.
Well, I think let's think of all the futile clinical trials that have been done on antiviral drugs. Let's not be embarrassed about doing trials on hormones. People who should be really embarrassed are the infectiologists for having just blown so much money both on antiviral trials and ineffective antiviral treatments like remdesivir. I mean, absolutely shameful. So I think we should have no shame whatsoever in suggesting hormone trials. We know that both estrogen and testosterone have anti-inflammatory effects, and unlike dexamethasone, they don't cause diabetes. So certainly, unquestionably, trials should have been done with estrogen, testosterone, and vitamin D, and they were shamefully not done.
So thanks.
Or if they were done in a stupid way, like you. I'll give you an example of my favorite kind of hormone study done by non-hormone people. This one relates to vitamin D, but it could be anything. And so there's a wonderful study published recently saying that, done by a bunch of geriatricians, apologies to you out there, vitamin D replacement in the non-deficient elderly has no clinical effect. Well, blow me down. Now that comes as a surprise. And I think this is illustrative of what happens when endocrinologists are not involved in constructing clinical trials.
Thanks, Richard. There's one final question, I think, before we move on, and that's from Dipesh Patel, who's asking, how does ethnicity feature if testosterone is implicated in adverse outcomes?
So we would, if the Italian model is correct, we would expect Han Chinese to be particularly vulnerable as having lower angiogenicity, and we would expect Africans to be relatively protected. And I think, well, the epidemiological data probably back that up, actually.
That's great. So
well, with that, I think, thank you very much, Dr. Richard.
Thank you.
Thank you, Richard.
And so it's now my pleasure to invite Professor Barbara McGowan. It's very difficult to read. No, it's the way it's written. It's very, very small print, unfortunately. Honestly speaking, I can't read any further.
Don't worry, I can introduce myself if you.
Yeah, please do in a few words. Very small print.
Barbara, I'll do it for you.
Go on,
Barbara McGowan, consultant endocrinologist at Guy's and St Thomas's Hospital, Anglo-Italian, like me, professor in diabetes endocrinology at King's College, London, leads the obesity and bariatric service at Guy's and St Thomas's for managing patients with severe and complex obesity. She's interested in gut hormones, appetite control, drug treatment for obesity, and remission of type 2 diabetes, post-bariatric surgery. And like me, she finds it hard to cope with bowel surgery videos before dinner. Thank you.
Thank you so much, Richard, for that. The screen is yours, Barbara. Please go on.
Thank you very much. Now, is that, if I move forward, or do I need to reshare my slides? Because I was sharing and then, let me just share my slides again. Okay. Can you all see my slide?
Yeah, it's there. Yeah.
Brilliant, fantastic. Okay, so thank you very much. And thank you again to Dr. Assad and the whole committee for welcoming me again to Bahrain this year. And today I'm going to talk to you about gut hormone therapies for obesity. So we've heard quite a lot about lifestyle interventions, intermittent fasting. We've heard quite a lot about surgery. So I'm going to hopefully let you know a little bit more about pharmacotherapy and whether we can actually meet some of the weight loss that we see with bariatric surgery. So I'm going to first of all remind ourselves about the approved anti-obesity medications, and then I'm going to really focus on gut hormones and specifically GLP-1 agonists for the treatment of obesity, and then go on to really show some of the future gut hormone combination therapies and co-agonists, which I think are really exciting. I think will definitely change the horizon on how we treat obesity in our patients. So this is just to remind you that there are multiple hormonal signals that influence appetite, and a lot of these signals come from the periphery. So we've got adipose tissue, which of course secretes hormones such as leptin, adiponectin, and resistin. And leptin it reflects the amount of adipose tissue. The more leptin, the greater the signal sort of to the brain, telling them that we have long-term adiposity stores. From the gut, we have several hormones. We are all familiar with ghrelin, the hunger hormones. And then there are several satiety hormones, including GLP-1, oxyntomodulin, PYY, and CCK. And some of these hormones have been manipulated into medications for obesity. And I'm going to speak about specifically about the GLP-1s today. But also from the pancreas, we have other signals. We have amylin, we have insulin, we have pancreatic polypeptide. And again, I'm going to show you today how some of these messages have been harnessed into pharmacological options for obesity. So all of these signals are processed by the brain and translated into feelings of satiety or hunger. So I think it's fair to say that up until today, we've had a bit of a pharmacotherapy gap in the middle. So, we have on the one side, we have lifestyle modification, which probably achieves somewhere between 3 and 8% in terms of weight loss. And then on the other side, we have a number of metabolic procedures from the gastric band, which achieves on average 16% of weight loss, all the way up to a gastric bypass, which probably can achieve about 30% weight loss and 25% in the long term. And I think, like I said, we've not really had an awful loss of medication, bridging this gap between lifestyle and the bariatric surgery. But I hope that by the end of the lecture, I'm going to convince you that we're really much closer to doing so. So what are the pharmacological options for weight management? So here we have sort of Europe and the United States, and I think here in Bahrain we're probably more aligned with Europe in terms of what we can and cannot prescribe. But just to remind everybody, so I think we all have access to orlistat, which of course is a lipase inhibitor, which stops fat absorption in the gut and associated with a number of side effects. In the States, they have phentermine and the combination of phentermine with topiramate, which is not licensed in Europe, and I will not be talking about that today. In Europe and in the States, we also have the combination of naltrexone and ibupropion. For those of you who may not be familiar, this is a combination of an antidepressant called ibupropion with naltrexone, which is the medication used for opiate addiction, and the combination of these two has been licensed for weight loss. Moving on to the GLP-1 agonist, I think everybody's familiar with liraglutide 3 milligram of Saxenda, and I think you are using this here in Bahrain, and I will remind you of some of the data. But I think even more excitedly, now both in the States and in the UK, although not yet Europe, we have semaglutide 2.4 milligram, a weekly GLP-1 agonist by the name of Wegovy, which has now been licensed for weight loss, and I will share some of the data with you. Now, just to remind you that we use pharmacotherapy on, most guidelines advise this for obesity, i.e. BMI of 30 or a BMI of 27 with a comorbidity. So what is the sort of weight loss that we see in people with and without type 2 diabetes? So this is just to show you that up until now, with the medication that's available out there, so liraglutide, orlistat, lorcaserin, which I've crossed off because it was approved in the States, but removed from the market because of increased risk of cancer. Then the combination of naltrexone and ibupropion, which I've mentioned, and then phentermine and topiramate. And this is in patients with and without diabetes. Those with diabetes are those in the light blue. And we can see that on the whole, patients with type 2 diabetes tend to lose a little bit less weight compared to those without. And what's striking here is that we can achieve sort of weight loss around 8%, probably at best, 8.4%, so single digit weight loss. So whilst we're plugging that gap between lifestyle and bariatric surgery, we're really not getting up to those sort of double digit weight loss figures that we see with bariatric surgery. But can we do better? So this is just a reminder about liraglutide 3 milligrams. So this is, of course, Saxenda, licensed since 2015. And Saxenda is a GLP-1 agonist, of course. And just to remind you that GLP-1 works at the level of the arcuate nucleus in the hypothalamus by stimulating the POMC and CART neurons, which are those neurons which stimulate satiety, and inhibiting the NPY and AGRP neurons, which are those neurons that stimulate hunger. And the first sort of phase 3 clinical trials was the sort of scale clinical trials, and this was carried out in patients with obesity and pre-diabetes, so not diabetes. And what we can see here, patients with liraglutide lost about 9% at 1 year versus 3.5% with placebo. Of course, this is on top of lifestyle intervention and physical activity, about 150 minutes per week. And the trial was continued up to about 3 years. And you can see that that difference was maintained with a sort of 7.1% in the Saxenda arm versus 2.7% in the placebo arm. And obviously the other striking thing to notice is that as soon as you stop the medication at 3 years, weight tends to increase back up to baseline. And that's because obesity is a chronic disease and we need to continue treatment for weight maintenance. Now, this is an important graph as well to show you. So essentially, we use this medication and we continue if patients have achieved at least a 5% weight loss at about 16 weeks when we've titrated the drug up to 3 milligrams. And these are called early responders. So what is the average weight if you are an early responder rather than a non-responder who does not achieve at least 5% weight loss? Well, you can see here, so in the dark blue, these are patients without diabetes. And in the light blue are patients with diabetes. So if you're someone who does respond, you're an early responder, at 1 year on Saxenda, you're likely to achieve somewhere around 11.5% if you don't have diabetes, or about 9.3% if you have diabetes. But if you're a non-responder, then your average weight loss is about 3.7, 3.8%. And this is important because at least you can sort of tell patients this is what the trials actually show you. But I wanted really to focus my lecture today on the newly approved GLP-1 agonists. And so we now have semaglutide 2.4 milligrams. And this is really, really exciting because I think we've now really sort of achieved a milestone, which is, a much more successful weight loss. And just to remind you about semaglutide, it's 94% homologous to human GLP-1. And there are a number of modifications, similar to liraglutide, but essentially here we have a 18 carbon fatty acid instead of 16, and this allows it to exist for about a week in terms of half-life, and also it's of course protected against DPP-4 degradation. In the original phase 2 clinical trials, where they tried different doses of semaglutide, and in this particular phase 2 trial, semaglutide was injected every day, so the doses were relatively smaller rather than the weekly dose that we know. But what we saw that compared to liraglutide in the orange is that increasing doses of semaglutide at 1 year showed about 14% weight loss, which was really exciting because this was the first time that we saw a double-digit weight loss. And then, of course, this was taken forward to a phase 3 clinical trial at the dose of 2.4 milligram once a week, and this was published. Can you hear me? It was published in the New England Journal of Medicine in February 2021. And these are the results of the study. So this is to show you that this is the step 1 clinical trials, like I said, semaglutide 2.4 milligrams versus once a week placebo. And you can see here quite a significant weight loss at 60.
سوري في اللفظ.
I think we have
انت كسيلز مانجر مش هتقدر تخلص لي موضوع الترانسبورتيشن، انت ما عندكش اوثرايزيشن على الجزئيه دي.
Sorry, please mute your microphone, others.
Thank you.
ماليش علاقه، انا الاوثرايزيشن عندك يقف
I don't see a way to mute them. Please kindly mute your microphones. Dr. Iman, Dr. Asad, do you know? Because I can't see any option how to mute them.
مش عايز ولا بص هقول لك على حاجه، انا مش عايز اي حاجه منكم كومبلمنتري يظبطوا لي الناس، ومش عايز اي حاجه منكم.
Please kindly mute yourself. Please mute your microphones.
Medical center.
Okay. I'll try and carry on. So the basically this is the categorical weight loss compared to placebo, and what was evident here is that
yeah, I think it's too noisy. Barbara, sorry for that. It says host. Sorry, please mute your microphone.
قبل الديل بيتحايلوا علينا ان انتوا تعملوا دي، بعد الديل ما يتم
Dr. Basim, can you? Dr.
مش
Basim,
عايزين
can you
تعملوا
please?
اي حاجه.
Dr. Basim, can you hear me? If you can mute your microphone, please.
ماشي يلا.
Dr. Basim, kindly mute your microphone.
Okay, hopefully I'll carry on. I think he's finished his phone call. Okay, so so categorical weight loss, as I mentioned, 86% of patients lost over 5%, nearly 17% of patients lost 10%, over 50% of patients lost 15%, and nearly a third of patients lost 20%. So I think now we are getting closer to the sort of weight loss that we see with bariatric surgery. So the STEP program was carried out, like I said, both in patients without diabetes at step 1, which is the results that I've shown you, but also in those with diabetes, step 2, in those with intensive behavioral therapy, and also in step 4, which was a maintenance trial where everybody was given semaglutide and then it was stopped. And you can see that after stopping semaglutide, patients who stopped semaglutide regained, whereas those that continue went on to lose about 18%. But here we are with all the STEP trials, really very good weight loss, about nearly 11% in those patients with type 2 diabetes. And if we look at the percentage of subjects achieving 15% weight loss across all the trials, again, you can see here that, quite a significant number, over 50% achieved 15% of weight loss, except for the step 2, the patients with diabetes, where about a quarter achieved 15%. And then if we look at those patients achieving over 20% weight loss, pretty much over a third, nearly 40% in the step 4 trial, and with 13% of patients with type 2 diabetes reaching 20% weight loss. So of course, if we can try and identify the patients who are going to be the best responders, that would be great. But of course, at the moment, we have no way of identifying who's going to respond, more than others. This is also to show that waist circumference decreased significantly in the step 1 trial by 13.5 centimeters. Of course, we know that decreases in waist circumference usually correlate very nicely with metabolic improvement. So that's semaglutide GLP-1. What about future medications for treatment of weight loss? So I wanted to mention a couple of really interesting candidates. So the first one is tirzepatide, and you might know tirzepatide in the context of type 2 diabetes, but there's also a comprehensive program now for obesity without diabetes. But tirzepatide is a dual GIP and GLP-1 receptor agonist. And indeed, there's a number of compounds which are sort of co-agonists at receptors and are being investigated for weight loss. And some studies have shown a dose-dependent effect on HbA1c and body weight in 26-week phase 2 clinical trial. So let me show you some of these data. So patients with type 2 diabetes, HbA1c 7 to 10.5%, were investigated with diet and exercise plus metformin, and randomized to either placebo or different doses of tirzepatide. And essentially, the results showed quite a very good reduction in HbA1c, which is a sort of dose dependent, and also change in body weight, as you can see here. And studies with tirzepatide have also been done in patients with type 2 diabetes in the SURPASS program, and compared to semaglutide. Of course, the semaglutide dose used in this particular trial was the 1 milligram dose, which is a dose licensed for type 2 diabetes, rather than the 2.4 milligram dose that is licensed for obesity. But you can see here changes, really quite nice changes in weight, 13.1%. Which is actually very good. Remember, with semaglutide 2.4, we saw a sort of just over 10% weight loss. And this is the SURMOUNT clinical program, which is essentially, it will report over the next months and years. And again, this is looking at tirzepatide in patients without diabetes, well, SURMOUNT-2 with diabetes, with intensive behavioral therapy and weight maintenance. So we look forward to these results to see whether we'll have another compound which will be either the same or even better than semaglutide. Finally, I'd like to talk about amylin as an anti-obesity agent. And amylin is a neuroendocrine peptide hormone which is co-secreted with insulin in response to food intake. And you may or may not know that it also acts as a satiety signal, and it slows gastric emptying and suppresses the postprandial glucagon response. So again, amylin has been harnessed into an analog by few changes to the molecular structure. So it's 84% homologous to native amylin. A few amino substitutions have taken place to remove these fibrillating properties of the hormone and ensure stability. And again, a 20-carbon fatty acid chain has been added to the molecule to give it sort of a long half-life, again, of about half a week, and to allow it to revise, to reversibly bind to albumin. And the clinical trials are the phase 2 clinical trials looking at different doses of cagrilintide, which is the name of the amylin analog. Again, very interesting. So this is just to show you, so the gray is placebo, the orange is liraglutide, 3 milligrams, and the rest are increasing doses of cagrilintide all the way up to 4.5 milligrams. And what we can see here at 4.5 milligrams, there was a 10.8% weight loss. So again, sort of in double digit. And this drug was generally well tolerated with some gastrointestinal side effects, but on the whole, patients tolerated this pretty well. So then, of course, one begs the question, well, why not combine cagrilintide or amylin with semaglutide, given that they've got they're both satiety hormones, but act in slightly different ways. So amylin, we know it decreases appetite and food intake by CNS-mediated mechanism, as well as delaying gastric emptying and inhibiting glucagon secretion. And of course, we know that GLP-1 receptor agonists reduce appetite, food cravings, and food intake. And of course, we know that weight loss also improves weight-related conditions. So this led to the phase 1b and phase 2 trials, where there was a combination of the two, and this is, I think, quite exciting. So this was just 20 weeks, okay? So you can see here semaglutide this time in orange at 2.4 milligrams, and these were different doses of the combination of Cagri and Sema. And you can see here that in the black line, that was the highest dosage of semaglutide at 2.4 and the highest dose of cagrilintide at 2.4 milligrams. And you can see that just at 20 weeks, it was a 17.1 weight loss compared to 9.5 with semaglutide. So this is really exciting, and you can see the lines are going down. And so, who knows whether with longer trials, which of course we are starting later on this year, whether we're going to see, even double digit, above 20% weight loss. So I think this is really exciting, and hopefully will, will probably change the horizon when it comes to pharmacotherapy for obesity. So I think I started off sort of saying that there was an unmet pharmacological need for obesity treatment, but I hope that I've shown you that with new gut hormone therapies coming up on the horizons, we are likely to match the sort of weight loss that we see, at least with gastric band, and who knows, perhaps we can, bridge the gap even more and achieve significant weight loss to match the outcomes with the sleeve and the bypass without the surgery. So in summary, there are new pharmacotherapy treatments for obesity becoming available with greater effectiveness that may eventually match surgical efficacy. I've shown you novel GLP-1 agonists and gut hormone therapies as promising future anti-obesity agents, which have recently shown to achieve double-digit weight loss with good safety profiles. And of course, semaglutide is already approved, and indeed NICE has launched the sort of a draft assessment of the drug, which, if approved, would be very favorable, and we definitely change, how we practice and how we prescribe these medications. And I do think that a little bit like managing chronic diseases, blood pressure, and so on, combination therapies will be the way forward for the management of obesity. And with that, I'd like to thank everybody, and I'm very happy to take questions. Thank you.
Thank you very much, Barbara, for that. And most importantly, finishing on time, ahead of time, I would say. Now, before I open the floor for the question, there's a question in my mind. I see a lot of patients, particularly ladies, are trying metformin as a weight loss therapy. What is your view? Is that an old friend forgotten, or still we can trust? So metformin is not a weight loss drug. Otherwise, it would be licensed as a weight loss drug. Having said that, especially ladies with PCOS and insulin resistance, they do find that when they undergo a lifestyle intervention, they find that they're much more successful when they take metformin. So, I do actually prescribe metformin in ladies, usually with PCOS and insulin resistance, mostly to regulate their periods. But, like I said, anecdotally, they do find more that they lose weight more easily. But I do always say to them, look, this is not a weight loss drug. So it may be that we use metformin in combination with some of the GLP-1 agonists, but it's a question of trying metformin. Of course, it's cheap, and if they tolerate it, why not? But it may not always work. Yeah, thank you. Well, there's a question in the chat box. Do you recommend amylin therapy more for diabetic or non-diabetic patients?
Well, first of all, amylin, what we've just seen are the phase 2 clinical trials, okay? So it's not yet approved. We're a long way from using amylin as a pharmacotherapy agent for obesity. So I think we have to do now the phase 3 clinical trials And then there'll be a big, this is likely, this will be done in combination with semaglutide, but there will be obviously just amylin arms, and we'll have to see what the effect is in patients with diabetes and without diabetes. So hopefully we'll be using it for both, but I can see why they're asking, one versus the other. But I think, we're a long way from establishing that.
Okay, I don't see any question, but there's another question that comes to my mind. If a patient is on semaglutide for weight loss, and how long will you try, and before you say you give up, you will not, there are some non-responders to semaglutide.
So I think semaglutide is going to be exactly the same, 16 weeks. And if you don't lose 5% of body weight after 16 weeks, then you're unlikely to do well. And that would be also part of that is part of the label. So we don't understand why some patients respond and patients don't, but I think, that's the 5% weight loss rule will be what we're going to be using going forward. And then, we technically are supposed to use it for life, but I think even NICE will only allow us to use it for 2 years, actually, which is probably more of a cost pressure rather than an actual based on clinical grounds.
Sure. Thank you for that. Let me see if there's any other question. I don't see any more. So thank you very much, Barbara, for the wonderful presentation.
Pleasure. Oh, that means I have to introduce you, I think.
Yeah, I'm not sure if you can read it.
Well, yes, well, I
very small print.
I've read enough of it. Anyway, we all know Dr. Saeed Raza, so it's a real pleasure to introduce you for today's lecture, which is you're going to talk to us about heart failure management in light of the evidence and guidelines. And of course, you are an eminent cardiologist with a vast experience, and you're a member of many associations around the world, both in America and in Europe. And so we're very much looking forward, to your lecture today to share sort of the new guidelines around heart failure. So thank you very much, Dr. Raza. Thank you.
Thank you very much, Barbara. Can you see my screen, first of all?
We can, yes, thank you.
Okay. Thank you. Well, this is the last session of the conference today. So I believe most of you or some of you may be feeling sleepy. So I thought, just to stimulate your mind a little bit, I put forward just 2 questions in front of you. So the first question is, which of the following does not improve cardiovascular mortality? Is it ACE inhibitor, ARNI, which is angiotensin receptor blocker, not neprilysin inhibitor, MRA, beta blockers, SGLT2 inhibitors, ivabradine, or vericiguat? Remember, these are all in context of heart failure. So I'm not going to give you the answer. Perhaps we can discuss in the question answer session. And then I put forward the second question. As per the new ESC heart failure guideline, what does HF small mr EF mean to you? And these are again the options that you see on the screen. So with that, I'm going to speak on the evolving management strategies in heart failure. I'm going to discuss what the evidence is to support these management strategies, and I'll be discussing few trials. And finally, I'll finish with the current heart failure guidelines. And mostly, I'll be speaking about the new or the 2021 ESC heart failure guideline. But the most important objective of mine will be to finish on time. It's a long topic to cover, so I'll be going a little fast. So we all know that heart failure is a major public health problem, and it affects more than 26 million patients worldwide. And more than 10 million people actually remain undiagnosed of heart failure. You have 1 in 5 chance of developing heart failure in your lifetime. And heart failure is now considered as the #1 cause for hospitalization. And it does not end there. If one is hospitalized, they tend to stay longer in hospital. And once they're discharged, then they tend to get readmitted. And there's 50% chance of getting readmitted in the next 6 months' time. Now, how about the survival? The 1-year survival is roughly around 70 to 80%. And in 5 years' time, that drops to almost half. That becomes 40%. And in another 5 years, that is 10 years' time, the chances of survival is just 20%. Now, what you see here on the screen is the development of medications and therapy over last few decades for the treatment of heart failure. And these are evident by well-established randomized controlled trials. But if I take you back to 4 decades, what did the patients had? They were left on the mercy of just digoxin and diuretics, nothing else. But then came the era in 1987 when consensus trial that was done, especially looking at the mortality benefit using enalapril. And that shows a remarkable mortality benefit in favor of enalapril compared to placebo. And then it followed, quite a few trials came along for the, as such as RALS trial, the MUST trial, MEDIT, and so on. And there was a period when cardiologists and heart failure specialists, they got interested in device therapy, ICDs and defibrillators, and cardiac resynchronizing therapy. And a lot of trials were done during that period of time. And then came the SHIFT trial for the ivabradine, paradigm heart failure, and more recently, SGLT2 inhibitors, which has taken heart failure management by leaps and bounds. And although what you see here, these are from the trials that have been done to show the cardiovascular outcome benefit, the EMPEROR, CANVAS, LEADER, and so on. And the paradigm heart failure, of course. But the studies that have been done with the SGLT2 inhibitors are not shown here because they came later and they are quite recent, which I'll be discussing a little bit in more detail. So we tend to look at the medication efficacy. We believe that the medication should be helping the patient to live longer and also let them let them have less of symptoms. And also the readmission rate of heart failure should be less. But we must not also forget the other end of the spectrum that these medications should be safe as well. So we are guided by our treatment, which are evidence-based medicine from lots of randomized controlled trials. And they found the baseline for providing us the guidelines as to how we prescribe medicines for our patients. So this is the latest or 2021 ESC guideline for the diagnosis and treatment of acute and chronic heart failure. So it is quite hot and very fresh. So just as I asked in the second question as to what the heart failure, small m, R, and EF stands. Now, if somebody knows the old guideline, this was classified as mid-range reduced heart failure, reduced ejection fraction heart failure. And now the terminology has been replaced by, it is now called the mildly reduced ejection fraction heart failure, where the left ventricular ejection fraction is between 41 to 49%. So this is a new change in the new guideline here. Now, before I speak about the 2021 ESC guideline for heart failure, let me just go through very quickly through the 2016 ESC guideline, which was the last guideline we had. We always had at the top in patients who were symptomatic of heart failure with reduced ejection fraction, use of beta blocker. It has always been the #1 drug that we are taught to use in heart failure. And then along with it, it was the ACE inhibitor. And if the patient still remains symptomatic, then we had an option to use, or the guideline suggested that we should use MR antagonist, mineralocorticoid receptor antagonist. And if the patients still remain symptomatic, then the ACE inhibitor or the ARB should be replaced with ARNI, which is angiotensin receptor antagonist, neprilysin inhibitor, which I'll discuss a little bit in more detail. And if the patients were in sinus rhythm, they had a prolonged QRS duration of more than 130 seconds, then these patients should be considered for device therapy, which are the cardiac resynchronization therapy, which in layman term you can also call a biventricular pacemaker. And if the patients were in sinus rhythm with a heart rate of more than 70 beats per minute, as you know, we would like our patients to have a lower heart rate. Certainly, they should aim for a heart rate less than 70 beats per minute. But if they had a higher heart rate, then these patients should be considered for ivabradine. Now, what has changed in ESC 2021 heart failure guideline? So what you see in blue, that has changed. So the beta blocker remains where it was. But ARNI, which is angiotensin receptor blocker, neprilysin inhibitor, that has taken a place where it was the third line treatment. Now it has become the first line treatment. And in addition to that, there are two new kids on the block, SGLT2 inhibitor, which is not so new, but the vericiguat is very new kid on the block. This has been added as a therapy for the heart failure patients. And so what the guideline looks like currently. So on the top, as you see, the ARNI is the first. If the patients of heart failure with reduced ejection fraction are taking ACE inhibitor, now the guideline says that the ACE inhibitor should be replaced by ARNI. Beta blocker should be the first choice, and this has not changed. And these patients should also be on MRA and SGLT2 inhibitor. So SGLT2 inhibitor has, as I said, has taken the management of heart failure forward by leaps and bounds. And it now holds a position right in front and shares it with the others who have been there for a lot of years. Now, diuretics should be used in patients who are fluid overloaded, who are congested and symptomatic. Now, previous guideline, if you remember, the QRS complex, the guideline says if it is more than 130 millisecond, they were eligible for CRT. Now it says that if they are in sinus rhythm, they must have a white QRS complex, left bundle branch block type pattern, and they should have a QRS complex which is more than 150 milliseconds. And ICD implantation is recommended as a class 1 indication for patients who have underlying ischemic etiology. Atrial fibrillation, if the patients have atrial fibrillation along with heart failure, then certainly they have to be anticoagulated. And you do not choose warfarin here. You have got to choose the newer anticoagulants or the novel anticoagulants like direct oral anticoagulant agents. If the patients have got underlying valvular disease, if they've got secondary mitral regurgitation, then that has to be corrected percutaneously or surgically. And if there's severe aortic stenosis, then that has to be corrected percutaneously and surgically as well. Now, what is important in the guideline that the focus has been that these patients, they have to be managed by a multidisciplinary team approach. And what I mean by that, the patients have to be adequately taken care of even when they are discharged in the community. So there must be adequate follow-ups. These patients must be looked after by the heart failure nurses at home. They must have ways to monitor themselves, and they should monitor their day-to-day symptoms. They should monitor their vitals, and they should be in touch with the with the doctors in the primary physician, primary practice, or in the secondary area of practice in the hospital. So now these forms the 5 pillars, you can say, of heart failure treatment. And out of these, all of them, they occupy or they have class 1 recommendation as per the new ERC guideline with level of evidence A, except for sacubitril valsartan, which is class 1 recommendation, but it has level of evidence B, because as you know, if you want to have a level of evidence A, then there must be more than one large randomized control trials. But there was just one randomized control trial that was done to prove the beneficial effect of sacubitril valsartan, and then unfortunately it has a level of evidence B. Nevertheless, it has a class 1 recommendation for its use. So I'll just discuss this drug, angiotensin receptor antagonist, a neprilysin inhibitor, where the ARB is the valsartan that is used. And so just to understand the mechanism, first of all, this ARNI is not a combination drug. It is a compound of where the 2 molecules are coupled together, which is valsartan, which is angiotensin 2 receptor blocker, and then the sacubitril, which is neprilysin inhibitor. So neprilysin inhibitor is essentially what it does, it increases your natriuretic peptides, which are ANP or BNP. And then obviously, most of you will know, valsartan is renin-angiotensin. It works on the renin-angiotensin system, and it blocks the angiotensin 2 receptors, and it also decreases the production of aldosterone. So the net effect is that they decrease the remodeling, they decrease the hypertrophy, they decrease the fibrosis in the heart muscle, and they also lead to vasodilatation. They decrease the remodeling in the blood vessels, improve the endothelial function, and in the kidneys, they increase the natriuresis and diuresis, and they also combine together. They decrease the sympathetic activity. So all these that I mentioned, they have got a beneficial effect in the pathophysiology of heart failure. Now, this was studied by a well randomized. It is a well-known or landmark randomized controlled trial that was started in 2009 and that finished in 2014, paradigm heart failure trial. And this essentially compared the molecule, which is LCZ696, which was a name given during the trial for this ARNI, against enalapril. So mind you, it was not compared against placebo. It was compared against enalapril. And this trial continued for about 27 months, and then it was stopped prematurely because of a vast benefit. And as you can see here, the curves, they divided quite early. And there was a definite benefit in favor of the LCZ696, which is the ARNI. And it led to 20% relative risk reduction in favor of ARNI compared to placebo. And it certainly met its primary endpoint of cardiovascular death or heart failure hospitalization. Now, when we look at the individual components of this primary composite, and then you see that the death from the cardiovascular cause was once again reduced. There was a relative risk reduction of 20% in favor of the ARNI compared to enalapril. And similarly, 21% relative risk reduction of heart failure hospitalization in favor of ARNI compared to enalapril. Next, I will talk about the SGLT2 inhibitor. Now, SGLT2 inhibitors, most of you will know, majority of the audience, they are endocrine specialists or they're diabetologists. So this drug or medication was first developed for the treatment of diabetes. Then obviously, these medications, as per FDA regulation, they have to show their cardiovascular safety. And they underwent few trials, which I think I've shown. These were the Declare TIMI 58, and then there was the EMPEROR outcome trial and Canvas trial. So they did prove their efficacy and they proved their safety, and then they also showed that they had a benefit as far as the cardiovascular outcome was concerned. But they were never tried in heart failure. Now, it is a very exciting time for the heart failure, especially that these anti-diabetic drugs, which were meant only for treating diabetes, now they are being used in the arena of heart failure. So how does SGLT2 inhibitors, they help in heart failure? So the honest answer, we don't have a clear understanding as to how the SGLT2 inhibitors help in patients or help the pathophysiology in heart failure. But there are some postulations, there are some theories that have been put forward. And as you can see in the slide, importantly, they lead to natriuresis, diuresis, and so they lead to a decrease in the volume that decreases the heart preload and afterload. And possibly it also improves the myocardial flow reserve. And as you know, the SGLT2 inhibitor, they lead to increase in the ketone bodies. And it has been postulated that perhaps it has got an effect in improving the myocardial metabolism as well. So DAPA-HF trial is the first trial that is done with the SGLT2 inhibitor using dapagliflozin, which is one of the SGLT2 inhibitors. And essentially, if you look at the inclusion criteria, this was NYHA class 2 to 4, left ventricular ejection fraction less than 40%. As I said, that this is a trial done in patients of heart failure with reduced ejection fraction. And they also ought to have NT-proBNP of more than 600 picogram per ml. And these were some of the exclusion criteria. And then they were randomized to receive either dapagliflozin, which is one of the SGLT2 inhibitors, 10 milligram daily, and the other arm received placebo. And they were followed up for a period of about 16 months. And if I can show you the results. So it led to a 26% relative risk reduction in favor of dapagliflozin in reaching its primary composite outcome, which consisted of the cardiovascular death, heart failure hospitalization, and urgent heart failure visits. And then if we look at the individual components, once again, we see that the hospitalization for heart failure, there was a relative risk reduction of 30% in favor of dapagliflozin compared to placebo. And death from cardiovascular cause, once again, that was seen a significant benefit in favor of dapagliflozin, an 18% of relative risk reduction in favor of dapagliflozin compared to placebo. A similar trial was then done with the second SGLT2 inhibitor, which is the empagliflozin, and this is the EMPEROR reduced. And this is a trial done in heart failure, chronic heart failure patients with reduced ejection fraction. A little less number of patients were studied in this trial. But once again, they were one-to-one double-blind, randomized trial. One arm received empagliflozin 10 milligrams compared against the other arm, which received only placebo. And once again, these patients were followed up for nearly 16 months. And straight to the results. Now, once again, the trial showed that the composite endpoint of cardiovascular death or hospitalization for heart failure was in favor of empagliflozin, a very similar 25% relative risk reduction in favor of the empagliflozin, same as we saw with dapagliflozin. And it has a remarkable benefit in terms of the composite renal endpoint. And as you can see here, there was a 50% relative risk reduction in favor of empagliflozin compared to placebo. Now, how about the individual components? If you look at the hospitalization for heart failure, this was shown to have a relative risk reduction of almost 31% in favor of empagliflozin. But unfortunately, the cardiovascular death, as you can see here, this did not show any benefit. And now again, we failed to explain why, because if somebody can remember the EMPA-REG outcome trial, there was a 38% relative risk reduction in favor of empagliflozin. And so it is a little difficult to explain as to why it did not show any cardiovascular death benefit in favor of empagliflozin. So no benefit was seen here. Now, Emperor preserved is the hot cake, you can say, in the arena of heart failure. And this Emperor preserve was being awaited for a long time, essentially because till date, we did not have a solid drug to treat or manage patients of heart failure with preserved ejection fraction. We have few for heart failure with reduced ejection fraction, but until recently, we did not have any drug. So this is perhaps one of the most important the trial that we know of in the recent times. And more important than that, as I said, it's a hot cake published only 6 months ago, 27th of August in 2021, just last year in New England Journal of Medicine. So essentially, these are some of the inclusion criteria, as you can see on the left. And it studied about 6,000 patients and compared empagliflozin 10 milligram against placebo in heart failure patients with preserved ejection fraction, where the heart failure patients had a left ventricular ejection fraction of more than 50%. And as you can see here, the primary outcome, so cardiovascular death and hospitalization was 13.8% in the empagliflozin group, whereas it was 17.1% in the placebo group. And if you look at the relative risk reduction, it was almost 31% relative risk reduction in favor of empagliflozin. So it is a remarkable trial, and we are quite excited to have this. That means that we can use this drug even for patients who have a heart failure with a preserved ejection fraction. And it has some secondary outcome benefits as well, as you can see on the slide. Now, very quickly, I will touch upon the ivabradine, which is the funny channel inhibitor. And this drug acts essentially on the sinus node. And it has received 2A class recommendation, but level of evidence B, because there's again just one trial that has been done for it. And it is recommended in those patients who have heart failure with reduced ejection fraction, and they are still symptomatic, but more importantly, if they have a heart rate which is not controlled by beta blocker, or the patients are intolerant to beta blocker, and if they have a heart rate of more than 70 beats per minute. A SHIFT trial was done for looking at the benefit of ivabradine in heart failure reduced ejection fraction. And you can see here there was 18% relative risk reduction. That was to meet the primary endpoint, which is a composite of heart failure admission and death due to heart failure. But if you look at the individual component, yes, it reduced the admission of heart failure, but it did not have any mortality benefit. So just if you go back to my first question I asked, so this is ivabradine, it did not show any cardiovascular mortality benefit in heart failure patients with the reduced ejection fraction. Now, iron has lately, in last few years, gained a lot of attention in heart failure arena, and a lot of trials have been done to look at its benefit in heart failure patients. And as you can see here, there are a number of trials that has been done. But the most exciting trial that has been done very recently is AFFIRM heart failure trial. And this has used injectable iron, which is carboxymaltose, in the AFAM heart failure, AFAM AHF trial, which is not the chronic heart failure, but this has been studied in acute heart failure patients after they have been discharged. And once again, you can see that the primary outcome, total heart failure, hospitalization, and the cardiovascular death composite, that was in favor of using ferric carboxymaltose. And similarly, total heart failure hospitalization on its own was seen as a benefit when injectable iron was used in acute heart failure patients after they were discharged. But unfortunately, it did not show any cardiovascular mortality benefit. It does lead to improve in the patient global assessment. The patient, they feel better, they're less symptomatic. It also helps to reduce the NYHA class. If patients are in class 3, then they may be in class 4 with the use because of the improvement of symptoms. And they certainly increase the exercise tolerance that is assessed by the 6-minute walk test that is shown here. Now, I showed in somewhere in the guideline, the new ESC guideline 2021, a medication called vericiguat. So where does vericiguat lie in the current guideline? So first of all, what is vericiguat? Vericiguat, again, is a very new molecule for heart failure patients. It has been, of course, used in patients of pulmonary hypertension and hypertension in the past. But essentially, it is a guanylate cyclase stimulator. So what it does synergistically with the nitric oxide, and also directly, it stimulates the soluble guanylate cyclase stimulator that you can see. I'm not sure if you can see my pointer. And then it leads to increase in the cyclic GMP. And increase in the cyclic GMP, of course, has got several benefits. It reduces the inflammation. It reduces the fibrosis, hypertrophy in the heart. It also reduces inflammation in the blood vessels, leads to vasodilatation in the blood vessels, and has some benefit on the kidney as well. So overall, again, once again, a huge benefit with this medication in heart failure patients. And the Victoria trial has been conducted and published very recently. And this is the trial that has given an edge for this molecule to be used in heart failure patients, although it has not been included in the guideline per se, because it has just been published, and hopefully we'll get this drug in the next guideline. So it used studied 5,050 patients, where vericiguat 10 milligram was compared with placebo. And these are the inclusion criteria, as you can see. And the primary endpoint was, once again, composite of death from cardiovascular causes or first hospitalization for heart failure. And the Victoria trial, again, it favors vericiguat compared against placebo, about 10% relative risk reduction in favor of vericiguat as far as the primary composite endpoint is concerned. And if you look at the individual component, the cardiovascular death was non-significantly reduced in favor of vericiguat, but heart failure hospitalization, again, relative risk reduction of 10% in favor of vericiguat compared to placebo. Now, the last trial I'll show here is the Galactic Heart Failure trial. And Galactic Heart Failure trial was done again with a very new molecule for heart failure patients. And, and essentially, this new molecule is called omecamtiv. And then this was compared with placebo, against placebo, and basically the endpoints remain virtually the same that I've been telling for the other trials as well. And it has shown some benefit, but not a great deal of benefit in terms of reaching its primary outcome, cardiovascular death or heart failure events, and first hospitalization for heart failure. But once again, it did not show any benefit for the cardiovascular death. It also did not show any benefit for improvement in the symptoms in the day-to-day activities, 6-minute walk test, and so on. So finally, to conclude, heart failure is a major public health problem. There's no doubt about it because of its high prevalence globally. And management strategies in heart failure, we all have seen. I've just given you an illustration of the number of trials that have developed in the last few years. And they have certainly led to major breakthrough in the last few years as to how we manage these patients of heart failure. And recent guidelines in heart failure have evolved based on high impact evidence from recent robust clinical trials. And it is important that we remain well informed with updates. And that is the key to successful patient management, and so that we can utilize the resources very well. Thank you if I had to rush. I'm not sure if I'm on time or over time, but thank you very much for your listening. And I'm happy to take any questions you may have. Thank you.
Thank you very much, Dr. Raza. That was a fantastic lecture and a really good overview of the guidelines. There are a few questions, and actually a couple of them are sort of similar. Dr. Dipesh Patel is asking, very nice talk. The challenge is, how do we practically start multiple medication classes in heart failure to help optimize outcomes and minimize adverse effects? And indeed, there's another question which is similar for Professor Mahid Yallo, who says, thanks for the nice presentation. What's the time interval for intensification of therapies in heart failure, weeks or months after the beta blocker and diuretic? What's the preferred sequence of heart failure medication? So the two questions sort of tying together.
Yeah, so I think they are very similar questions. So I'll probably answer both together. And it is a very practical and very nice question. Thank you for that. So the first answer is that we have to choose our therapy as per evidence. And that's how we are guided in our treatment options that we have for the patients. Now, whether you will start all the medications in low dose and then increase it gradually, or you will increase one by one. Now, again, heart failure management is now considered as a precision medicine. The treatment has to be individualized. Now, of course, you have to look at the age of the patient and the other comorbidities. Sometimes the patient may not be suitable for a beta blocker. Sometimes patient may not be suitable for ACE inhibitor or suitable for ARNI. So, but if you have a patient where you are able to start all the medication, then you may start not all at the same time. You start maybe 2 or 3. Certainly, you have to start, as the guidelines say, the first line therapy should be there, like beta blocker, ARNI should be there. And if the patient is particularly diabetic, SGLT2 inhibitor should be included. And of course, the MRA, mineralocorticoid antagonist. Now, if you have done that, of course, the basic teaching is that start low and go slow. That's the medical school teaching. And that probably still remains the case. And one thing you must keep in mind, like ARNI and SGLT2 inhibitors, these two are costly drugs. So cost, again, you have got to keep in mind. But having said all that, the maximum benefit that you get from any medication in heart failure is to titrate it up to the maximum dose. That's where you get the maximum benefit.
Fantastic, thank you. There's another question from Dr. Mohammed. Is there much gain in using the heart failure with mid-range ejection fraction clinically compared to the pre-existing heart failure, or does it still need more application clinically?
Yeah, so the mid-range heart failure with reduced ejection fraction, this is now, as I said, the terminology has changed. Now it is considered as mildly reduced. So any left ventricular ejection fraction between 41 to 49% should be considered as mildly reduced ejection fraction, which means these patients are to be considered very similar to patients with heart failure with reduced ejection fraction, which the cutoff is less than 40%. But having said that, the guideline says that the therapy, for example, like CRT device, ICDs, some of the drugs like ARNI, they are still to be reserved for patients who have left ventricular ejection fraction less than 40%. But by and large, I think the treatment will probably remain the same. The SGLT2 inhibitor, like for example, I've shown the EMPA-REG preserved. I believe there's a wide opportunity, big opportunity to use in patients at all range of the left ventricular ejection fraction.
Fantastic, thank you very much. I think that, hang on, I think that should answer all the questions, I think, yes. And you've got lots of thanks and of course lots of wonderful compliments about what a wonderful lecture that was. So with that, I will allow you to introduce our final speaker, if that's okay. Thank you very much.
Yeah, thank you, Barbara. So it's my pleasure to now invite Dr. Bassem Mustafa. And perhaps I can read this. Yes, Dr. Bassem Mustafa is Senior Consultant Physician and Rheumatologist in Bahrain Defense Force Royal Medical Services. He is also a Senior Clinical Lecturer at the Royal College of Surgeons of Ireland, Kingdom of Bahrain. Welcome, Dr. Bassem, and the screen is yours.
Thank you, Mr. Chairman, for this kind introduction. Bismillah ar-Rahman ar-Rahim. Dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. It's my pleasure to be with you here today. I would like to thank the organizers of this excellent annual meeting for inviting me to be one of the speakers today. The good news, I am the last speaker today. And I would like special thanks to my colleague and friend, Dr. Asad Al-Daftar. The subject I'm going to talk today, I hope it will be of interest to the majority of you. As you can see from the title, we're sharing now.
Yeah.
Fibromyalgia. This is a frequently misunderstood and underdiagnosed disease. Okay. Go back. Okay. My objective here in this meeting to increase the awareness among physicians of this medical condition and to update you about the management, the diagnosis, and so on. Because the diagnosis can be delayed for more than 5 years and the patient might be suffering for a long time, and his quality of life is affected, and getting him diagnosed or her diagnosed early, he can have a better quality of life. So let's start. What is fibromyalgia? Just I put this slide just to tell you there are many things. This is it affects, let's say, the whole body from head to toe. You can see on the slide many words like suffering, sleep, pressure, stress, depression, chronic pain, muscle ache, fatigue, stress, backache. So many things. So I'm going to go through those aspects of the disease, starting from definition and ending with treatment. What are the controversies in fibromyalgia? Is it real? Yes, for most patients, symptoms are real and can be disabling. Can it be reliably diagnosed? Is it physical or psychological? Is there an effective treatment? What is the role of the rheumatology and rheumatologist? I'm going to answer those questions in the coming 20 minutes. So simple definition, just to cut short, it's a widespread musculoskeletal pain, fatigue, sleep disturbance, memory and mood issues. This image will show you some of the way we diagnose. Look for multiple tender points. This is an image from front and back. Multiple tender areas. We take like 18 points and 11 out of 18. We say probable or likely diagnosis. This is one of the ways to make the diagnosis. For going further, I would like to present a case. A 35 years old woman come to your clinic complaining of diffuse joint pain for the past several months. In further questioning, she states the pain is all over her body, muscles, pain, bones. It is there throughout the day. It's bothering her most of the time. It's almost there all the time. Worsened by exercise. She gets minimal relief with paracetamol. On further questioning, review of symptoms was nothing significant apart from daytime fatigue and occasional palpitations. Past medical history, none. So she has no past medical illness, or she's not suffering from any chronic illness. And as I said, she was using acetaminophen as needed, mother rheumatoid arthritis, sister hypothyroid. On physical examination, she had 8 of 15 tender points. What's your diagnosis? What further workup does she need? Let's go through some differential diagnosis. Polyarticular disease. Could it be early rheumatoid arthritis? Could be arthritis related to other connective tissue disease like lupus. She's in the age between young, middle age, which can cover those two important diseases in rheumatology. Polymyalgia rheumatica, usually a disease of older age group. Endocrine causes like hypothyroid, as we know, hyperthyroid, both can cause fatigue, tiredness, muscle pain, aches and pain, and so on. Myopathy, polymyositis, rhabdomyolysis, neuropathies, depression, chronic fatigue syndrome, myofascial pain syndrome, anemia. As you see, so many differentials. So what shall we do? What further workup we shall do? It's very important, first of all, careful history and physical examination. This is the most important component and often leads to the diagnosis, as usual in general, in medicine in general. It's very important. What laboratory parameters? We can do simple ones. Causes of fatigue, we do CBC basically for the anemia. TSH looking for hypothyroid, vitamin D deficiency, as we know in our region is quite common, and treating this might help the patients a lot. Cause of myalgia, high CK, we do chemistry panel, simple panel, renal liver function test. Evidence of inflammation, as you know, inflammatory markers, SR, selected protein. Generally not recommended unless you have suspicion. We do ANA as a screening test, basically, for any underlying connective tissue disease. If we have any suspicion, if symptoms pointing towards that, maybe she has some skin rash, she has some dryness of eyes, of mouth, some other features that might lead you to do those tests, as well as rheumatoid factor and others might be needed if you feel is important. Otherwise, you are doing those initial tests and follow up the patient and see. Over the time when reviewing the patient, you will see if you need to do them or not. We don't do a lot of tests unnecessarily. Let's say the result, she came back, the patient, CBC is normal, she's not anemic, thyroid normal, SR normal, no evidence of inflammation. So you are about to tell her, are your vitamin D level as well normal? You will tell her now, want to tell her about fibromyalgia, but then she tells you that she forgot to mention that she has joint swelling in the hand, breast, knees, ankles, as well as mild shortness of breath. What is going on? You become concerned, definitely. You re-examine her. This is important. In general, any patient coming with some symptoms who are in doubt or the diagnosis is not clear, we keep re-examining, re-evaluating. Even we can change our diagnosis or add another diagnosis. This is not wrong. Keeping an eye on the patient, on the symptoms, how they go, the response to treatment. This is one of the principles in medicine we have to apply always. She says that her joints are swollen at present. While she's telling you, she says they are swollen now. So you examine her, there is no synovitis. So this feeling that the joints are swollen, but they are not really swollen. There's no synovitis and her chest is clear. You remain worried. Is my diagnosis wrong? I am wrong. What to do next? In young, otherwise healthy patient, it's reasonable to monitor the symptoms, as I said, rather than investigate a lot. You explain the patient, you have fibromyalgia, and she becomes tearful. Is it a real illness or not? Is it associated with depression or not? Let's go further. Who gets fibromyalgia? Any age, actually, but most common in the age group from young to, let's say, middle age, 20 to 55. Majority are females, as you see, 60 to 90%. It's present in the population in about 10%. Concomitant medical illness. So many suffering from chronic diseases like lupus, rheumatoid, inflammatory, non-inflammatory, even diabetes, hypertension, any chronic illness, osteoarthritis, hypothyroid. One of the studies in rheumatoid arthritis actually recently has shown 25%, as you see, 1/4 of patients with rheumatoid arthritis as having secondary fibromyalgia. So we have to keep eye on this and manage fibromyalgia in a patient with other disease to improve the quality of life. If you diagnose the patient early, treat early, you improve definitely the quality of life. You don't want to miss a diagnosis. Prior medical illness, some diseases like Lyme's disease we know about, viral illnesses can also cause some symptoms related. Drugs, steroids are being used a lot, but if they are used properly in the correct place, they are safe medications. But if you abuse them, this is some do this, unfortunately, keep patients on high doses unnecessarily, and they get all the side effects which we know of. So you have to be careful about this medication. And if the patient does really need the steroid, whatever medical condition there, try to keep the minimal effective dose. If possible, less than 5 milligram or less of prednisolone. So 25%, this is a high percentage actually, of fibromyalgia patients will meet the criteria for depression at the time of diagnosis. Again, more in females, men less, and 50% of those are preceded by a stressor, usually psychosocial problems, stress at work, stress at home. Those factors can induce or can precipitate the symptoms. Other triggers like physical trauma can also, surgery, infection, but I feel stress was, according to the patients I see, stress is one of the very important triggering factor. What other symptoms a fibromyalgia patient might have? They have, as you said in the second slide, so many symptoms. They can have also tension, headache, temporomandibular joint disorder, irritable bowel syndrome can be also there. We know that it is psychosomatic. If you know pathological findings related to this disease, anxiety and depression. What are the causes? This is a good question, is an important question. There is actually no definite cause found, but genetics, it seems to play a role. Infections basically as a trigger for the disease, physical or emotional trauma. I think this is a very important factor in most of our patients whom we see. There's abnormality in the neuroendocrine pathway. So there's increased level of certain neurotransmitters in the brain and in the central nervous system. And this can lead to amplification of the pain. So they feel the pain at small level, but they feel a lot of pain. So this is important to know about. Risk factors, again, female more in males, family history if it is there, rheumatic disease, because one of the chronic diseases, lot of suffering, lot of pain. On the top of that, they get fibromyalgia, again, more and more pain, and this affects their life significantly. And our aim to try to interfere, explain, and manage them with some useful medication. Again, any chronic illness in general can be a risk factor, any chronic illness. What are the complications? The pain, as you know, lack of sleep, pain interferes with sleep. They have difficulty to function at home or work. And sometimes they can lose their job because of that. The disease can be very severe. Frustration frequently leading to depressions and anxiety. And we might need to involve psychiatrists in the management, to counseling, and if they can support us in the management. That's what I said in the beginning. We are dealing with a condition that's often misunderstood and underdiagnosed. How we diagnose, what tests and how we diagnose it. I said, one in the beginning, specific tender points in a person's body. This is one tool we were using for many years. Clinically widespread pain of more than 3 months duration with no underlying medical condition that could explain that pain. But there is no specific blood test to diagnose fibromyalgia. What we are doing is basically a disease of, you can say, of exclusion. But those tests, simple tests, I am pointing here, CBC, SR, C-reactive protein, looking for evidence of some inflammation. Hypothyroid, very important, is common as silent hypothyroid, and vitamin deficiency as well. Here, some recent updates they try to introduce some other ways of adding to the diagnosis. They introduce some indices. I just show you briefly something called widespread pain index, looking at symptoms over the body, different parts of the body, and tick them, and you get a score. Another one, symptom severity, like fatigue, waking tired, difficulty thinking, remembering, pain and cramps, depression, headaches, and you score them and you put your score. And there are many other pain-related questions. You ask the patient and you rate them. At the end, you come with the scores, and according, I will not go deep in this, but based on that score, this is again, it's not 100%, but it can give you some support in your diagnosis if it is there. More than certain figure, or a certain number, it's more likely the disease is there. How we treat them? So to treat the fibromyalgia patient is very important reassurance and explanation. This is number one, reassurance and explanation. We tell them this disease does not affect your organs, doesn't cause heart failure, doesn't cause renal failure, doesn't cause, but this pain is there, and we explain it to them and try to help them to manage their life accordingly. And we'll tell them we'll use some medications to help you, and we'll be in contact with you all the time. We see you, we'll help you. So the patient should have good communication with his physician in order to overcome this condition. What about the drugs? There are different medications we are using in this disease, mostly antidepressants and anticonvulsants. For example, we use drugs like duloxetine, as you know, called Cymbalta. This is a selective serotonin norepinephrine uptake inhibitors, which damp the sensory overload, which is part of the pathophysiology in the disease. Other drug, again, milnacipran, one of the, again, selective serotonin norepinephrine uptake inhibitors, work the same way. We have gabapentin and pregabalin, which are assigned as anticonvulsant drugs, and they also filter out the number of sensory signals which the patient suffer from. Sensory signals can be many, like numbness, tingling, even the feeling of joint swelling can be part of that, of the sensory overload, what we call sensory overload. Amitriptyline is one of the very important drugs, also as one of the tricyclic antidepressant. Also it will decrease the pain threshold, increase the pain threshold, so the patient will feel the pain only when it comes at higher levels. We titrate, starting small dose, like 10 milligram in the evening time, build it up gradually and see the response. Fluoxetine, which under the name of Prozac, is one of the antidepressants again. So those medications, if you use them carefully, with the cooperation of the patient, most of them actually, they get relief, not full. We never get full results, and a patient is free of pain, but at least he can manage his life. He will have a better quality of life. What else we can do? We can, lifestyle modification is very important to reduce stress as much as possible. Unfortunately, many times we cannot interfere. If they have social problem at home or at work with their manager or the in charge, really very difficult to interfere, but we try to tell them to be patient and hope for a better changes in the future. Enough sleep, we advise them to have enough sleep to help them relax more. And when you sleep well and wake up, you will feel more fresh. Exercise regularly, different kinds of exercises, sometimes even group exercises. We try to maintain a healthy lifestyle, tell them about even a diet, a healthy diet. Cognitive behavior therapy and counseling might be needed we can refer them to psychologists or psychiatrists to help them. Sometimes they have groups of patients with fibromyalgia. They chat with each other. They talk to each other. I think there will really, when somebody talks out, speaks up, it gives some help. Do I have more time?
Yes,
Yeah,
you have
just
more time.
4 minutes.
Yes,
How
Dr.
many?
4 minutes.
4 minutes, very good. Yeah, I am about to finish. Patient education and self-management. This is important. The role of the physician to educate him about the disease, that he will not die because of this disease. And this disease is not killing, but it's pain. Like when you have a flu, it's very bad symptoms, but flu within a week or so will be fine. But with this disease, you have to live maybe a longer time, and you have to try to manage with your physician, with your medication. Physical rehabilitation, as you see, this is also, all of those are very important in the management of the patient. Probably this is the last slide. I think I am on time. The typical outcome of fibromyalgia, as I said, fibromyalgia does not herald the onset of a systemic disease. There is no progressive structural or organ damage. Most patients have chronic persistent symptoms, but the level usually gets better, the pain is less, and they can have a better quality of life. Most patients continue to work, but unfortunately about 10 to 15% are disabled, even they can lose their job to this degree, can be very severe. I have 1 or 2 patients over the last years who couldn't do anything at work, even at home, was really like disabled. And it's unfortunate. There is often adverse impact on work and leisure activities and the function of the patient. Most patients' quality of life improves with medical management. This is reassuring, and we can help the patients with those things. Thank you for listening. This is my last slide, I think. And nice to have you today. Thank you very much.
Thank you, Dr. Basim, for the wonderful presentation. I'm sure this is a clinical condition which is not only difficult, but a challenge. And not only to diagnose, but also to manage these patients.
Very challenging.
Thank you. Now, before I open the floor for questions, I just have one question for you. I think you have partially mentioned it in your talk already. Now, if you were to say fibromyalgia, is it a diagnosis of exclusion where you'll do lots and lots of tests, including MRI, and then say, look, we have found nothing, and this is probably fibromyalgia? Yes. Or as a good clinician, you'll just make a clinical diagnosis and say, well, I've taken a good history, I've examined you, and this is fibromyalgia. Which one will you go?
Actually, both. It is a clinical diagnosis, and it is a disease of exclusion also. But I don't think you should need to go far to do like CT, MRIs, unless you suspect malignancy, for example. From the history, loss of appetite, weight of loss, and so many things, you might think this is associated with malignancy. Malignancy is one of cause of fatigue, tiredness, loss of appetite. So we don't go so far unless we have really suspicion. I won't do CT or MRI, but as I said, I rely on my clinical judgment, on my symptoms, examine the patient, I look for if there is any evidence of arthritis clinically, synovitis. I might need to do ultrasound of the joint. Sometimes arthritis or early arthritis cannot be seen only on ultrasound, but not so expensive and extensive imaging studies usually not needed, in general not needed. It is a disease of exclusion, yes, I agree with you.
And I'm sure you'll also agree that these are difficult patients who will shop around from one doctor to another, and then obviously they'll also meet Dr. Google at some point.
Yeah, really, you have to be a very patient physician, listening, good listener. You should be an introvert personality, not extrovert. Let the patient talk more than you talk. This is very important. Let them express themselves, talk up, talk out, and listen, keep listening, and they will be very happy. Believe me, they give them the chance to talk. They should feel your empathy. You are understanding them. You are understanding their disease. You want to help them. They feel it. They will feel it. But
Yep.
if you talk more than they talk, you will lose them.
Lose them. Sure. Thank you. Now, there's a question in the chat box. I believe this is related to the case you presented. With a normal thyroid panel and the patient still being symptomatic, would you consider checking her autoimmune thyroid profile, for example, anti-TPO and thyroglobulin, and treating it if found to have autoimmune thyroiditis?
Yeah, thyroid is a different disease. Yani thyroiditis, autoimmune thyroiditis, or Graves, whatever. You have, this is endocrine condition. It has to manage accordingly. But if the thyroid is normal, that's it. TSH is normal. There's no thyroiditis. It's different picture, different clinical presentation. It won't present in this way.
Okay, let me see. Now there's another question. Dear doctor, do you face patient with fibromyalgia related to COVID-19? And if yes, is it more difficult to treat?
Actually, a very difficult question. I cannot say that because no one of my patients telling me he has COVID-19 nowadays. They try to hide the disease, most of them. But some of them say they recover from COVID and they keep complaining, but for pains, joint pain. Some of them actually presented as one of my seniors admitted a case under me as rheumatoid arthritis because after COVID. So, but this was related to the disease itself, and I didn't start treatment. I managed conservatively, and everything settled. So we don't know much about long-term presentations or complications still. We didn't face many patients, but we have to, they have many symptoms. Many patients post-COVID, they have a lot of symptoms. They can have fatigue, they can have this. If it persists, we'll wait and see. We might do some tests. But in general, if it is related to the virus, most of the time, it settles over time.
Okay. There's another question in the chat box. Fibromyalgia patients, are they at increased risk of having other rheumatological and or autoimmune disease than normal population?
No, not really, no. The opposite, yani many of them suffering from chronic conditions like, as I said, rheumatoid or lupus or scleroderma or whatever, any chronic rheumatological disease. Even some diabetics, many diabetics also complain. Sometimes they come tell you have joint pain and you examine them. You don't see any joint swelling. This is the sensation of swelling, basically. What they feel, the sensation like tingling, numbness, something you cannot get it only by maybe do some test to like pen break or whatever. But this, what we call it sensory overload, is part of the fibromyalgia itself.
And then the other question, I think you have answered it already now. Can fibromyalgia patients present with joint swelling?
No, joint swelling, if it is like really synovitis, no, this is not fibromyalgia actually. It's active synovitis. You have to look for underlying either rheumatoid or another connective tissue disease.
Okay, thank you.
Could be lupus, could be mixed connective tissue disease, could be undifferentiated connective tissue disease. Then you have to do more screening for this. If there is real arthritis, you treat it, you have to have the diagnosis. What caused the inflammatory arthritis? Here your diagnosis is clear, inflammatory arthritis. And you have to see which direction you go and you have to manage that.
Does steroid help in any way if you just give a blind therapy just to see whether it works or not?
I never use a steroid blindly. I don't recommend it to be used blindly also. Even in my patients, I try to get rid of it as soon as possible. We know, for example, rheumatoid arthritis patients, for example, worldwide, about 30% will need small doses of steroids. Should not exceed, if possible, 5 milligram to maintain them going on. Even if I can make it 4 milligram, I will do. If I can make it 3, I will do. If I can rid of it, I'll do. I try always to keep the minimal possible dose if they need it. But just giving steroids blindly, I never give steroids blindly.
Sure. Professor Barbara, did you have any question to ask?
No, I think that's it. Thank you very much. That was really fantastic, actually. Really useful and very useful tips for a difficult and challenging condition to treat. So thank you for that. Excellent.
Thank you. Thank you for your
Dr.
comment.
Bassem, Dr. Sayed, Dr. Barbara, all of you, and for the nice session. We are really happy that we got till now to almost acceptable numbers sitting and observing your interesting lectures.
Alhamdulillah, thank you very much.
Dr. Bassem, you had been deal with really interesting topics, because I just want to comment for a moment. I have two cases in my life I observed. One being diagnosed with rheumatoid arthritis, and then it was early case of acute lymphocytic leukemia. And the second one being diagnosed with the fibromyalgia, and it was intestinal lymphoma. So as Dr. Bassem outlined, it is again a diagnosis of exclusion, but we should be very careful, and the rheumatologist who will sit and look for the patient carefully before giving medication for this specific condition. Thank you for all of you. Yes.
This is good remark from your side. We should keep re-examining, reassessing our patients for anything coming new. Any patient can develop, for example, like lymphoma, malignancy. You follow a patient with rheumatoid, suddenly they have breast cancer, for example. Suddenly comes to you, I have been diagnosed lymphoma. So you keep eye. If they have any symptoms, you can investigate. As physicians, as internists, I can do some workup. And if I come to a certain diagnosis, I refer them to the specialty. Reassessing, reviewing your diagnosis is very important, as you pointed out. I agree with you fully.
Thank you. By this, we will close, and we are looking tomorrow to meet again. And thank you for all of you, and good night.
It's my pleasure. Thank you very much.
Thank you.
Thanks everybody for attending.
Bye.
See you. Thank you.